Good morning, all the respected delegates and the respected International Society Coloproctology, all the dignitaries. I will take this opportunity to welcome all the delegates to this textile city. International Society of Coloproctology and Solapur Surgical Society have jointly organized this CME and the live surgical workshop to focus the diseases of colon and anal canal. These diseases are increasing in the prevalence due to the changes in our lifestyle and food habits. It is, it is said that change is inevitable because it is driven by expanding the knowledge and technology. Both are accelerating at the speed never seen before. So the newer modalities are very important to adapt as previous method of operations. Our job is to master the change rather than the becoming the victim of the change. So the next 2 days, we will upgrade our knowledge, pathophysiology of the anorectal disease and their management with the recent advances. With the help of these all dignitaries who have come all the way from the different places in India and they are expert in their branches and their knowledge is very valuable. Not only we are going to take the theoretical lectures, but also we are covering all the topics in the workshop, operative workshop, and even the interaction, the discussion. After each lecture, CME and operation, we will have a question and answer series, and I hope you will really get the good knowledge of these diseases, and this main aim will be successful depend upon the involvement of the delegates. Please take the participate in the discussion also, and I wish Dr. Ladukar to take over the charge to tell details about the today's program. The lecture series will start in 5 minutes, and after that one inauguration program at 11 to 11:15. Our respected Dean Dr. VM Medical College will come and inaugurate the program for 15 minutes only. After that, the CME means the lectures will be continued, and from 12:30 onwards, we have the operative demonstration. Today, we are going to have rectal prolapse, the multiple fissulas, fissure in ano, complicated fissulas, rectal prolapse. All these live workshop, total 6 cases are today arranged, and in between the 2 cases we will have the case presentation also, depending on the availability of the time and everything. This is a very informative lecture. We will enjoy and participate. Thank you, sir.
Good morning to everybody. Thank you, Dr. Prakash Gatore, sir. Within a very short span of time, he has taken this initiative to carry out this program. Before 5-10 years, we had this program in his own nursing home. But at that time, we were quite young to start with this ISCP. Now ISCP has literally we have crossed 8 years. 8th Worldcon was over in Agra last time, February. Now we are here, we are starting our this new year with this first coloproctology workshop conducted by the ISCP. And this is, we are all here to conduct this workshop that is covered under the live surgeries and the complete detailed discussions about the topics of the coloproctology. Unfortunately, the time was very short, so that many could not gain the fellowships, or they are not here to attend this. But I feel that this will be percolated again in the deep roots of Solapur nearby, and next time we will be having much more candidates for this workshop. Now it is divided into 3. First, the CME lectures would be there. These will be pertaining to the basics of coloproctology as well as some modifications and at the advanced procedures. And those procedures will be very important as far as your examination, which will be conducted tomorrow at 7 a.m. sharp. That will be an examination which will be totally displayed on the board. Every question will be there displayed in front of you, and then you have to take out the proper answer, and you have to take it out on your answer paper. So it will be 45 minutes to 1 hour exam completely. Followed after thereby would be an interview, a discussion in between the candidate and the faculty, and the result will be declared to you. It will be sent to your own address as far as the methodology of the examination is concerned. Later on, the fellowship certificates would be given to those successful candidates in coming WorldCon. That will be most probably in Delhi, coming Delhi in February or March 24. March. So March 24 would be venue for WorldCon Delhi, and there the certificates would be handed over personally to the candidate, those who register for WorldCon also. So this is all the time query is there that those persons, those who are coming for the workshop, they want to have the certificates. They poke on doing all everything, they are asking for the organizers. So it should be very clear to everybody that certificates of the fellowship is only handed over in presence in the WorldCon. Even if somebody has failed in last WorldCon to get it, they have to register for the next WorldCon in Delhi, and they will be getting it. So any of the queries, you can directly contact me, you can directly ask me, you can send me an email, or you can have the WhatsApp message to me also. So regarding this, this is not the first time that we are conducting fellowship workshop. We are conducting 7 to 8 workshops throughout the year. Even if somebody misses this time at Solapur, we can have the next workshop near in Karimnagar, or then Kochi, or nearby, or in the north part of India. Today we are definitely coming, or we are starting with the CMEs, and this will be coming covering many of the topics. Some are very basics. So let us start with the first and foremost very important aspect of surgical field, that is anatomy, and that is surgical anatomy. And this will be displayed over here by Dr. Ganga Shankar. He is junior most fellow becoming very senior most nowadays. Is as far as knowledge, work, and everything, skills and everything is concerned, Ganga Shankar is very growing colorectal surgeon in the field. Grown, not growing. Sir interrupted me. I should not speak. I should speak as grown surgeon, colorectal surgeon from Hyderabad. He is practicing over there. He has got his own website also. And Ganga Shankar is very keen to read, to select out, to put it out on paper. And you must have learned many times what is surgical anatomy. And now he will be displaying his skills in talking, and he will be showing you how the applied anatomy in colorectum and anal canal is important for this. So I take this opportunity to call over upon Dr. Ganga Shankar. Come on.
Sir, thank you very much for nice words. When I gave the fellowship exam, sir asked me about anatomy of anal canal. That time I don't know what is the difference between surgical anal canal and anatomical anal canal. So every conference he is asking me to present the anatomy. Thank you, sir. इसका display करना. Thank you, sir. I welcome all the delegates and faculty. This is Textile City on behalf of ISCP and Solapur Surgical Society. Anatomy, we were taught in our UG days, PG days about the anatomy. This is only just an up-to-date anatomy and anatomical basis for the disease as well as the procedures and understanding of the disease. Why we should up-to-date about the anatomy? Sometimes we may get the complex fistulas, complex cases. To treat them, we should know anatomy very well, and we should understand the anatomical basis. And also sometimes we will face the post-operative complication. When we know the anatomy very well, then only we can treat them. So this is my favorite slide. Sir William Osler, father of modern medicine, UK. A doctor is a student till his death. When he fails to be a student, he dies. So always we should update our skills, knowledge about the surgeries and understanding and diagnostic modalities about the diseases. There is saying in Sanskrit, Anguli evam pradhana yantrama gudavikara. Your finger is the most important diagnostic tool in evaluating the anorectal diseases. And always for medico-legal purpose, document preoperative findings. First we will be talking about the epithelia, then muscles, spaces and fascia. If you look into the picture, the anal canal is like a tube in tube concept. There is one inner tube and outer tube. The pointer hai kya? Pointer. The sir. I don't know how to use that. This is a inner tube. It's a visceral compartment, consists of the mucosa, submucosa and internal anal sphincter. And this is concavo-convex in shape. The outer somatic compartment, motor compartment, consisting of external anal sphincter and levator ani. The inner one fits into the outer tube, because of which will give the final shape of the anal canal. For all the practical purpose, what we talk is about the surgical anal canal only. So, what we read in the textbooks is narrated by the anatomist. They dissect the cadavers and they write the books. The beauty of the anorectum is anatomy and physiology are closely interrelated, and this is very well appreciated while during the surgery. So many terminologies are given by the surgeons. That is the reason we have got the surgical anal canal and an anatomical anal canal. So surgical anal canal extends from the anorectal ring shown in the blue cursor. This is also known as Hermann's line up to the anal verge. This is approximately 4 centimeter in length. Whatever we deal day-to-day practice is always surgical anal canal. The anatomical anal canal extends from the dentate lane up to the anal verge. This is approximately 2 centimeter in length. All of us knows, taught in the PG days, UG days, the dentate line, it is a serrated in appearance, sawtoothed appearance. It is formed by the fusion of post-allantoic gut and proctodium. The surgical anal canal, for easy understanding, divided into 3 parts. Upper area from Hermann's line up to the dentate line, approximately 2 centimeters in length. The middle area, intermediate area, this is also known as pecten. The pecten is a terminology given by Golliger. From dentate line up to the intersphinctary groove. This corresponds to the white line of Hilton. This is also called as Jackson's groove. This is approximately 1 centimeter in length. Below intersphinctary groove is your lower area anal verge, 0.8 centimeters in length. If you look into the upper area, we'll be seeing longitudinal folds of mucosa. Because the wider ampulla fits into the narrow anal canal, mucosa are folded into longitudinal columns. These are known as the columns of Morgagni. If you look at the lower end, they are connected to each other by means of walls. Into the concavity of the walls, the anal gland or intraepithelial openings will be present. These are known as crypts of Morgagni. Coming to the mucosa lining, entire colon and rectum lined by columnar epithelium. So rectum is pink in color. When you come to the surgical anal canal, it changes into red in color. And in the region of the dentate line, just 0.5 centimeter, 0.5 to 1 centimeter above the dentate line, the mucosa is plum colored, and because of underlying internal hemorrhoid plexus. Below dentate line, it is whitish in color, and here the mucosa is a modified skin. How it differs from the anal verge? This is known as the anoderm. It lacks the hairs, no hair follicles, no glands like sweat glands or other glands. And anal verge area skin, it is similar to the perianal skin. Only difference is here the color is lighter compared to perianal skin. Coming to this arrow, this is the area where epithelium changes from columnar to the cuboidal. This is known as the anal transition zone. So coming to what is the importance of anal transition zone. We all know defecation has got the 3 phases: accommodative phase, sampling phase and defecation proper. So sampling is a process where whenever the feces or bolus is subjected to this area, we are able to discriminate whether it is solid or liquid or gas. And if the conditions are favorable, solids will be retained and gases will be eliminated. we all know that there are the receptors like touch receptors, pain receptors in the skin, like Lufini organs, Malpighian corpuscles, Merkel's corpuscles. Here the modified sensory nerve endings will be present. This is from old Goliger. These are the called as genital corpuscles and modified nerve endings. They play crucial role in discriminating the flatus from liquid and solids. This is a plum colored mucosa over the internal hemorrhoid plexus, and on the right side dentate line. Again on the left side the columns of Murgagni and dentate line with anodum. This is a pointer, the point of entry of laser probe. These are the crypts, intraepithelial dimplings above the anal verge. The same in the cadaver, the A is the columns, B is the crypt, and C is the anodum, D is the anal verge. Coming to the anal cushions. As sir said, the incidence of anorectal problems are increasing day by day, and 30 to 40% in high volume centers totally constituted by piles and fissures. So we should understand the basis for the piles. These are the 3 anal cushions present at 3 o'clock, 7 o'clock and 11 o'clock position. Terminology is coined by Thomson. These are major anal cushions when they start producing symptoms. These are actually soft hemicercal globular mucosal projections into the anal canal. These are usually asymptomatic. When they start producing symptoms, they are transformed into something called as anal nodule. The anal nodules, when producing symptoms, called as hemorrhoids. In between, there are the minor cushions. They are responsible for accessory piles. These are anchored to this is internal anal sphincter, this is the longitudinal muscle, external anal sphincter. The longitudinal muscle gives rise to Treats muscle. The Treats muscle plays a crucial role in anchoring these anal cushions to the internal anal sphincter as well as the longitudinal muscle. The Treats muscle has got the 2 components. These are the submucosal suspensory ligament. They surround the anal cushions. Submucosal smooth muscle. Smooth muscle surround the cushions and ligaments anchors to the longitudinal muscle. This is one more picture I got from the net for easy understanding. I said this is the anal cushion. This is a longitudinal muscle. This is the internal anal sphincter. It loops around the internal anal sphincter. And anal cushions have got the vascular and non-vascular components. Non-vascular component is by the epithelium. This is a submucosal connective tissue, consists of green lines, consists of collagen fibers and elastic fibers. And there are the arterioles and venules. The arterioles are given off from the rectorectal plexus, mainly constituted by superior hemorrhoidal artery, very little from middle hemorrhoidal artery. These are the terminal arterioles, gives rise to small arterioles and tiny arterioles. These small arterioles and tiny arterioles are responsible for the bleeding in hemorrhoids. In the past we were told that bleeding is venous. Now they are no more venous, they are arteriole. These are the arteriovenous communications. They are known as corpus cavernosa recti because they are similar to the erectile tissue of penis. And these are the venules, superior hemorrhoidal venule, middle and inferior. Superior drains into the portal circulation, middle and inferior drains into the systemic circulation. If you look at this picture, these are the suspensory ligaments anchoring the entire anal cushion to the longitudinal muscle. And this is the internal anal sphincter. This one is the number 18, hopefully, submucosal smooth muscle which anchors the anal cushion to the internal anal sphincter. Why we should know this anatomy? Today and tomorrow you will be learning new procedures like transanal hemorrhoidal dearterializations and Chivate's procedure, laser procedures. They all aimed at not removing the cushions. They are aimed at inducing the inflammation here and repositioning the cushions to their original position, and also dearterialization of the hemorrhoids. This is a normal histology of the hemorrhoid consisting of the endothelium and fenestrations. This is the symptomatic anal cushions where there is a fragmentation of the muscle and dilated venous channels. Again, coming to the blood supply, above the levator ani, the rectum is supplied by superior hemorrhoidal artery which runs on the lateral half, and middle hemorrhoidal artery, posterior laterally it supplies, and inferior hemorrhoidal artery anterolaterally it supplies. The surgical importance of these vessels, again you may be learning the Chivates procedure where you ligate the hemorrhoidal vessels at two places. The beginners or youngsters, when I started doing that procedure, I had a doubt whether mucosa or rectum is going to necrosed. It is not going to necrosed because of rich transmural anastomosis. Even if you ligate the both superior and middle hemorrhoidal artery, rectum is going to survive. And this is again picture showing the location of the hemorrhoidal arteries from the dentate lane 3 centimeters above. It is approximately 2 to 3 millimeters below the mucosa. This is the area where all your dearterialization procedures like Doppler guided hemorrhoidal arterial ligation, finger guided hemorrhoidal arterial ligation, and laser dearterial ligation and Chivates dearterialization are done. The latest non-excisional procedures like lasers or Chivates procedure will take care of almost all the components. Sliding it will take care of, and rectal redundancy it will take care of, and vascular abnormality also it will take care of. Again coming back to anatomy, this is a crypt opening, this is the anal gland. They were initially described by the Shayari, and almost all the glands are direction is downwards. They are never upward, and they are 8 to 12 in number, mostly in posteriorly or posterior commissural area they are located. That is the reason we have the internal opening most of the time posteriorly, and unless otherwise specified, the crypt is located at the dentate line, and search for the internal opening always at the dentate line. And if you look into the gland, it shows the racemose pattern. They play a very crucial role in spreading the inflammation across the various spaces. When we were in PG, we were taught that glands are located in the intersphincteric space. But now the concepts are changing. There is an extensive study by the Francis Chowen from Singapore. He showed that 80% of the glands are located in the submucosa, and 8% pierce the internal anal sphincter, and longitudinal muscle is pierced by 8%. Only 2% of the glands reaches the intersphincteric space. Only 1% pierces the external anal sphincter. This is a microscopic view where this is a crypt opening. The moment the crypt opening got blocked, there is a cyst formation in the submucosal and intersphincteric plane, followed by the abscess and spread of infection. Coming to the muscles, we know that it is an internal anal sphincter, it is an involuntary. This is approximately 4 centimeters in length, 2 to 3 millimeters in width, and lower end is covered by the subcutaneous portion of the external anal sphincter. The width is more in the distal half. This is pearly white in color. How to locate the identify the internal anal sphincter? Try to use this is called as Pratt speculum. The moment you stretch, the one you see the structure made taut is internal anal sphincter. Try to identify the intersphincteric groove. The pearly white structure will be your internal anal sphincter. How to differentiate it from external anal sphincter? On application of the thermal energy, it will not twitch. This is again from the Gallagher. This is the internal anal sphincter, external anal sphincter. In between is a conjoint longitudinal muscle. Why it is called conjoint? It is partly smooth muscle, and also it receives the fibers from puborectalis and external anal sphincter. And it is thought to be bone. We all know bone is the structure to which the muscles, tendons, fascia, ligaments attaches. So to this, all the muscles like internal sphincter, levator ani and external sphincter got attached, and it also stabilizes the anorectum when enters from the abdomen into the pelvis. And already I told it gives the various extensions. Medially treats muscle. In the region of the dentate line, it gives the Parkes ligament. It separates the submucosal space from the perianal space, and laterally also it gives the fibrous septa which separates the various perianal spaces, and inferiorly this septa inserted into the perianal skin as corrugator cutis ani muscle. Whenever the longitudinal muscle contracts, it helps in wide opening of the anal canal and also helps in the defecation or expulsion of the feces. That is the reason it is called as everter ani muscle. Coming to the external anal sphincter, in 1854, Vesalius made extensive observations, and according to Gallagher, Parkes, Milligan, Morgan, some says it is divided into 3 parts, and some says it is divided into 2 parts. This is the latest concept given by Dr. Arun Rojna School, sir. External anal sphincter has got the subcutaneous portion and superficial portion. For all the practical purpose, levator ani and deep portion of the external anal sphincter and puborectalis, they constitute the levator ani muscle. The subcutaneous portion encircles the anal canal, and anteriorly it is related to the superficial transverse perineum. It also loops around the internal anal sphincter. The superficial portion, it loops anteriorly and laterally anal canal, and posteriorly it gives the extensions known as anococcygeal ligament. It is attached to the coccyx, and anteriorly it is related to the perineal membrane. And deep portion of the external anal sphincter and puborectalis forms the levator ani. The anococcygeal ligament is different from the anococcygeal raphe. If you closely look into this picture, there are the spaces above the anococcygeal ligament. There is one space, below one space. This is deep post-anal space. This is a superficial post-anal space. This is the same thing, cadaver showing the subcutaneous portion, superficial portion, and levator ani. Coming to the puborectalis muscle, puborectalis originates from the pubic bone. It surrounds the rectum laterally and posteriorly, again attaches to the pubic bone. Here is the deep portion of the external anal sphincter. Together they are considered to be the same. Whenever the puborectalis contracts, the lower anal canal, if you look into the picture, ventrally it omits the anorectum. There is a forward movement of the lower rectum, so that there is a diagonal opposition of the anal canal. So it helps in the closure of the anal canal, like a crimp connection. This is known as gross anal closure. So we should not divide these two structures while doing the surgery. And this is a subcutaneous, I already told, anococcygeal ligament, something called as anococcygeal raphe. This is different structure from the ligament. This is formed by the decussating fibers of pubococcyges and iliococcyges. It also should not be divided during the surgeries. This is Rahate sir's favorite picture. Is going to ask in exam importance of this picture. This is the internal anal sphincter, circular in shape, external anal sphincter, surrounding the internal anal sphincter. Why I have shown this picture? Because fissures are most commonest anorectal problems. They are common in posteriorly and anteriorly. This is the area where least supported, internal anal sphincter is least supported by the external anal sphincter. That could be the reason for the fissures common in commissures. Coming to the fascia, the longitudinal muscle, it gives rise to various septa. This is ischiorectal fossa fascia, separates the infralevator space from ischiorectal fossa. And transversalis fascia given off from the longitudinal muscle. This is also known as the Milligan septum. It separates the ischiorectal fossa from perianal space. To drain the ischiorectal fossa abscess, we have to open this Milligan septum. This is again Park's ligament separating the submucosal space from the perianal space. Whenever we are treating perianal abscess and fistula, sometimes we encounter difficulty in treating. Patient may present with the recurrences. We should know thorough anatomy of pathways of spread of anorectal sepsis. So when you are ordered for sonogram, MRI, something called as intermuscular space. This is described in older Goliger and older books, but this is an updated anatomy terminology given by our own Indian, Dr. Pankaj Garg. According to him, there are the three potential spaces. The space between the internal anal sphincter and longitudinal muscle is the inner intersphincteric space. Any sepsis from this inner intersphincteric space spread upwards and forms a submucosal abscess and high intrarectal abscess. There is one more potential space between the longitudinal muscle and external anal sphincter shown in the green. So from here any sepsis may spread upwards. This is above the levator ani called as supralevator space. This is bounded anteriorly by the rectum, laterally by the levator ani, and it is related to peritoneal reflection and obturator fascia. Any sepsis from here may spread to retroperitoneum, even up to posterior mediastinum. These are the abscessor fistulas which will have the odd external openings, like in the anterior abdominal wall, thighs, and somewhere far away from the internal opening. And one more potential space between the levator ani and external deep portion of the external sphincter. This is levator fascia. There is one more potential space. This is outer sphincteric space. The fistulas which arises in this space are known as refill fistulas. Fistulas in the roof of ischiorectal fossa within levator ani. These are the High resolution MRIs, these are my own MRIs. You can see the inner intersphincteric space collection. This is a middle intersphincteric space collection. We should not miss any collection. Otherwise, patient will be making window shopping from surgeon to surgeon. And this is the outer sphincter, this is a levator ani, external anal sphincter. This is a collection inside the fascia. If you look into the picture, ischiorectal fossa is empty. And if you don't drain the properly these fistulas, patient will be having the recurrences. Same thing shown in the pictorial form. Here ischiorectal fossa is empty. Ischiorectal fossa is empty. This is within the fascia of the levator ani. And other spaces, ischioanal, levator and perianal spaces and perineal spaces. This is cadaveric specimen showing the same. Coming to ischiorectal fossa, here this is one of the commonest site for the perianal abscess, medially related to the anorectum and external anal sphincter above levator ani, and laterally by the obturator muscles and fascia, by the skin, and posteriorly by the gluteus maximus muscle. The surgical importance is from any infection from the deep postanal space spread right side and left side, and they form the horseshoe abscesses in the ischiorectal fossa. And second thing, we were taught in post-graduation training, we should give the larger incisions and break the loculi and pack the wound. But now the concepts are changing. If you look into the picture here, these are the pudendal or inferior rectal nerve branches closely supplying the anal sphincter. So breaking of loculi is not practiced nowadays. Only smaller incision, try to drain with smaller arteries, not to break the nerves. Otherwise, patient will have the incontinence in the future. Then again coming back to spaces, below the anocoaxial, as already I said, superficial postanal space, above ligament is the deep postanal space, and above levator ani is the supralevator, and one more space, the retrorectal space. This is between the fascia propria of the rectum and presacral fascia. Any infection from here can spread to any of the space, but to retrorectal space it is very rare. But always insist your radiologist to look for infection in all the spaces, any collection, any side tracks, and so that recurrences will be least. This is one more space. This is the deep anterior anal space present deep to the perineal membrane. This is the perineal membrane. Perineal membrane is separates the superficial transverse perineal from the deep transverse perineal. The surgical importance of the abscess here, it will spontaneously rupture through the rectovaginal septum. So rectovaginal fistulas are common. One should keep in mind while treating these abscesses. And our gynecologists may accidentally or they may misinterpret as vaginal abscess or Bartholin's abscess, and they stab these wounds. This may lead to the rectovaginal fistulas. Coming to nerve supply, the sympathetic supply for the anorectum comes from the lower thoracic and upper lumbar. The postganglion fibers are located in pre-aortic and lumbar sympathetic plexus. Pre-aortic will be in front of the aorta and iliac vessels. Lumbar sympathetic chain is behind the iliac vessel. It unites with the pre-aortic plexus, form the hypogastric plexus. There are the two plexus, one is on the right side and one is on the left side. They are closely related to the lateral pelvic wall, covered by the peritoneum. The postganglionic fibers comes from S2, S3, S4, nervus erigentus. They unites with this hypogastric plexus, forms the pelvic plexus. These are closely related to the lower rectum, lateral to your lateral rectal stalk, and they run anterolaterally to supply the bladder, prostate and penis. While doing some of you may be doing rectal resections, you should be careful not to damage this plexus. Final ABC of the anorectum. A is the anorectal ring formed by the puborectalis, deep portion of the external anal sphincter, a little contribution from internal anal sphincter and longitudinal muscle, responsible for maintaining the continence. Anorectal angle, this is also plays a crucial role in maintaining the continence. The bundle muscles, external anal sphincter responsible for 30% of the anal resting pressure, and internal anal sphincter 55% of the anal resting pressure. Coming to the C, cushions. Cushions helps in effective closure of the anal canal. I told what is gross anal closure. They are also maintains a 15% of anal rectal pressure. We all know that internal anal sphincter is tonically contracted state. So because of its tonic contraction, the hemorrhoidal veins will be obstructed and blood flow will be obstructed. The cushions are dammed up with the blood. And even after contraction of the puborectalis, there is always 7 to 8 millimeter opening remains opened in the anal canal. This 7-8 millimeter opening is closed by anal cushions. by filling the blood in them. So this is called as effective closure of the anal canal. That is the reason we should not remove anal cushions. And content sampling, I already explained, capacitance and compliance function of the rectal reservoir. During the defecation, whenever the rectum receives the bolus, it has got the enormous capacity to increase in the volume or to receive the bolus. This is known as a capacity function. At the same time, the intrarectal pressure will remain same. In fact, it may become the lower. This is known as a compliance function. Because of the lower intrarectal pressure, defecation will be postponed. This is the anorectal angle formed by the puborectal is usually 80 to 90 degrees, and whenever in squatting position the anorectal angle becomes straightened, helps in the elimination of the feces. This is how one should palpate for the anorectal ring laterally and posteriorly for medico-legal documentation. Thank you very much. Hope I did not bore you.
This was quite extensive and intensive lecture. Many doubts must have been cleared, and this was not only anatomy, applied anatomy, and all pathophysiological aspects of the different diseases was also taken up. I don't feel that there will be any questions for this. Now we are moving to hemorrhoids, and for that there are 3, 4, 5 procedures are there. But before that, it will be very important to do with pathophysiology and what is hemorrhoidectomy, which is one of the commonest procedures. And this will be dealt with by Dr. Jiten Chaudhary. He is coming from Bombay, and he works there in a hospital, big hospital, Godrej Hospital. He is their consultant surgeon, doing many of the procedures, many of the surgeries, but he is practically focusing his more attention on pulmonary disease and the anorectal problems. So I'd be happy to invite him. He is the executive member of ISCP. I'd be happy to invite him, Dr. Jiten Chaudhary. He'll be talking on pathophysiology and hemorrhoidectomy.
Thank you, sir. As Ganga Shankar very aptly said, that anatomy is very much linked with the pathophysiology. So I thank Ganga Shankar to cover my topic, and I can sit back, come back, that's it. So anyhow, since the topic has been given, so I'll continue. Good morning from Mumbai. I am Dr. Jiten Chaudhary. I am attached to Apollo Spectra Hospital and Godrej Memorial Hospital. And Godrej Memorial, so I told, yes. So I'll be talking about pathophysiology of hemorrhoids. So although it has been covered extensively by Ganga Shankar, and we already know a lot about it, but still I'll be speaking about it. So let's begin. So Banov was the person who basically divided hemorrhoids into internal hemorrhoids and external hemorrhoids depending on the position. So internal hemorrhoids, basically if they arise above the dentate line, and external hemorrhoids if they arise below the dentate line. So now a little bit about the etymology, means the terminology. So most of us basically interlink hemorrhoids with piles, but I'll ask the house, are piles or hemorrhoids the same as far as the etymology is concerned? So hemorrhoids is basically Latin word, it means flowing blood, whereas piles means a ball, and a swelling in the anal canal which may or may not bleed. So that is a little difference in the terminology. So coming to the causes of hemorrhoids, constipation is a known factor to aggravate the disease and cause the disease. And straining is another factor. Many people strain even if the stools are not hard. There are various reasons that people strain. Some are habitual strainers. Sometimes the patients suffer from ODS, that is obstructive defecation syndrome, which can be because of rectal intussusception, or it can be because of the descent of the rectum or rectal redundancy. So even though the stools are not hard, the patient strains and eventually can lead to the formation of hemorrhoids. Aging is another factor which of course is not in our hands to cure that. Trauma is another factor which can cause hemorrhoids. And some people are habitual to sit in the lavatory for a prolonged time. Some people used to carry newspapers, some people carry their mobiles, and they found it relaxing to sit in that loo for some, they find it more relaxing. But I tell you, the act of defecation should be as swift as possible if someone wants to avoid the formation of hemorrhoids. Lack of fiber is of course an independent factor which can cause piles or hemorrhoids. Hereditary has been one factor which is found to have people have, it's a hereditary preponderance to have hemorrhoids. And diarrhea can also cause to hemorrhoids. One of the factors which is not enumerated here and which is particularly true in Indian scenario is the lack of water intake. Especially in India, if you see, the hemorrhoids are more common in females. The reason I'll say is because of the social taboo. No, right from the upbringing of the girl child, they go to schools and they don't have the proper toilet facilities. And because of that, they learn to drink less water. So that again is one of the major factor to cause the hemorrhoids, especially in the Indian scenario. The other secondary causes can be local, abdominal, pelvic or neurological. Local causes can be anorectal deformity or it can be a hypotonic sphincter. Anorectal deformities can be congenital or it can be because of the trauma. Abdominal factors can be because of the ascites. And in the pelvic factors, we have gravid uterus, means it is commonly seen in almost 85% of the pregnant females. All pregnant females during their last trimester are very, very prone to have hemorrhoids, and it is expected almost 85% of them suffer from it. Another factor can be uterine neoplasm, ovarian neoplasm, which can cause pressure into the venous plexus and hindering the venous return and leading to the engorgement of the hemorrhoids. Other neurological factors are paraplegia and multiple sclerosis, which causes basically the hypotonia of the sphincter. The concept of hemorrhoid formation could be categorized into 4 groups. First is the sliding anal cushion theory, which was given in 1975 by Thomson. And most of the procedures, today's procedures are based on the sliding anal cushion theory, which has laid down the importance of anal cushions, as earlier explained by Dr. Ganga. The anal cushions are important in maintaining the continence. The procedure which was invented by Longo, the Dr. Chiute's procedure, they basically take care and avoid cutting of the anal cushions. Another theory which was given by Eigner was there is a vascular abnormality and rectal redundancy and increased pressure of anorectal vascular plexus are 4 independent factors which can lead to the formation of hemorrhoids. So anal cushions are basically nothing but elastic fiber, collagen and subepithelial smooth muscles which are anchored to the conjoint longitudinal muscle by Treats, ligament of Treats. It's basically the disruption of the Treats ligament which causes the sliding of the anal cushions. And factors can be any. So shearing force of the fecal matter can cause disruption. Malposition of the anal cushions and compromised venous region can cause it, and also the increased interabdominal pressure because of the various factors as enumerated earlier. Now coming to the vascular abnormality, several mechanisms are responsible for the regulation of anorectal blood flow within blood vessels, which can be grouped into intrinsic and the extrinsic. Intrinsic can be increased vascular tone, and the extrinsic can be the disarrangement of the cytokines and hormones. The imbalance between the vasoconstrictor and vasodilator substances basically caused by the dysregulation of the vascular tone. There is an increase in potent vasodilator substance like nitric oxide, which is seen in patients who suffer from hemorrhoids. So coming to this thing, endothelin receptors can be type A or type B. Type A are basically vasoconstrictive and type B are vasodilatory. So basically it is the interplay of type A and type B fibers which decide the how the vascular, as told earlier, that cavernosa recti behaves. So hemorrhoids had a higher protein expression of the type B receptors or the vasodilator receptors. So rectal redundancy is, as told earlier, is basically circumferential prolapsing hemorrhoids which are seen in the internal rectal prolapse, and it is basically the lack of proper fixation to the supporting tissue within anal cushions to the rectal wall. An increased pressure on the anorectal vascular process can be because of the efficacy or defecation is influenced by voluntary contraction of the abdominal muscles and assumption of the squatting position. So what happens in the squatting position, that anorectal junction becomes almost 180 degree and facilitates the passage of stools. So nowadays there was in fact a slide going on, like most of us are using the western toilet. Just to ease out the passage of stools, it is recommended to keep a stool underneath your foot, almost of 2 feet height or 1.5 feet height, and it basically changes the anorectal angle, and it causes the easy passage of the stools. So increased pressure on the anorectal vascular process also affects the venous drainage of the anorectum. Several conditions like pregnancy, coughing, weightlifting can cause increase in the pressure on the anorectal vascular. Now coming to the theory of straining and constipation, it has been seen that low fiber diet causes less bulky stools, which causes straining and defecation, and which causes increased internal pressure, and because of it there is a decreased venous return and more engorgement into the hemorrhoid masses, and ultimately enlarged hemorrhoidal venous cushions. So these various points have already been discussed in the previous slides. Like, just to summarize, the sphincter hypertonicity, anal cushion hypertension, deterioration of the connective supportive tissue leading to the sliding of the anal cushions, abnormality of the high anal pressure, increased straining during defecation, venous drainage impairment, and increased congestion and slippage of the anal cushions. All these factors basically in one way or the other way lead to the formation of the hemorrhoids. Now coming to the classification of hemorrhoids, as already been discussed, if it is below the dentate line, we call it as an external hemorrhoid. I am talking about the origin of the hemorrhoids. If the origin is above the dentate line, then it is called as an internal hemorrhoids. So external, just to illustrate more, it is located at the anal verge and it's covered by the skin and situated outside the anal orifice, results from the varicosities of the external hemorrhoidal plexus, and which ultimately leads to swelling in that region. And since it is covered by the sensitive anoderm, it is usually painful and very prone for formation of the hematomas. The internal hemorrhoids, which is in the anal canal, commences at the anorectal ring and at the dentate line. And since it is the mucosa is doesn't have the somatic innervation, they are usually painless. So the internal hemorrhoids, the characteristic feature is the painless bleeding. Now coming to the grades of hemorrhoids, they have been divided into grade 1, 2, 3 and 4 by Parks. And if it's just the bleeding, then they are just there is no prolapse when we call it as a grade 1, and in the grade 2 when there is a prolapse of the mucosa but it doesn't come out, it's just the patient need not to put his finger to put it down, and when the grade 3 is, it is the prolapse is so much that he has to use his fingers to return the hemorrhoid masses, and grade 4 means the hemorrhoids remain prolapsed. So the importance of grading is basically to decide the type of the treatment. Grade 1 and 2 can be managed with the medical means, and grade 3 and 4 require some sort of a surgical intervention. So basically the indications of the surgery can be mainly divided by the impact of the symptoms and the quality of life. The 3rd and 4th degree piles, as told just now, they require some sort of a surgical intervention. And secondary hemorrhoids, if the conservative treatment fails, then they also become a candidate for the surgery. Fibrous hemorrhoids is another indication for the surgery. And one of the most interesting combination is combination of internal or external hemorrhoids when both the plexuses are involved. Those are the cases which require some sort of surgical intervention, and especially some sort of an hemorrhoidectomy. PPH will not be able to help in cases of when there are external hemorrhoids. So this is just a pictorial representation of the hemorrhoidectomy, Milligan-Morgan hemorrhoidectomy, which still today is considered as the gold standard procedure for hemorrhoidectomy, in spite of so many advantages, in spite of Reginault and Ganga Shankar promoting so much of laser, but still it remains one of the gold standard. So what we do is basically we take a V-shaped incision and take care of the anoderm in such a fashion so that we reach the hemorrhoids, the apex of the hemorrhoids, cutting as less skin as possible, and the wounds are left open. But point to remember here is that we have to keep enough of the anoderm in between all the three excised masses so that the patient does not suffer from anal stenosis. And Ferguson's promoted closed type of hemorrhoidectomy, in which he closed the wound and didn't leave the wound open. He used the sutures in a continuous fashion. Some surgeons basically takes interrupted sutures also. It's a surgeon's choice, and their belief is that the closure causes earlier healing. But as far as the pain is concerned, I don't think there is a difference in the pain score in between the two open and the closed hemorrhoidectomy. This is a pictorial description of the closed hemorrhoidectomy. Now I'll be talking about, I'll be showing a video of my own where I'm using a bipolar shear to do the procedure of hemorrhoidectomy, Milligan-Morgan. So what I am doing is basically holding the enlarged prolapsed hemorrhoid masses and injecting them with Hyalase injection, and I am using 1:1 dilution with LOX with adrenaline. So both this Hyalase and adrenaline causes shrinkage of the pile mass, which basically helps in avoiding too bigger incision and making the surgery little less invasive. You will see that the mucosa blanches immediately after that. Now I am using a dilator and keeping it there for some time. And you can see the hemorrhoid masses have shrunk to almost 80 to 90%. This is a small handle bipolar shear and very useful tool. It makes the surgery almost bloodless, and you see what I am doing is basically pushing the internal sphincter downwards so that the internal sphincter fibers are not getting entangled in the surgery, and I am not causing any injury to the internal sphincter. So I have removed whole of the pile mass without using any suture here. The raw mucosa can be sutured with Vicryl 2.0. It's a surgeon's choice. Thank you so much.
Thank you, Dr. Chaudhary. Sir, you have elaborated pathophysiology and hemorrhoidectomy also. In this crowd, many of the persons will be doing Milligan-Morgan. How are they? How many of them are doing Milligan-Morgan? Please raise the hands. Most of this, everybody does it. But now we are there in the area where, or in the arena where the laser is taking hold of this hemorrhoids, and they claim that everything can be done by lasers in coloproctology. Now the reasons are so many, but now this is a better platform where we should discuss all scientifics of the laser. Not only just using the tool in the hands of full, so we should be quite have a good wisdom to know about the laser and to draw upon it all the features, all the mechanics. There is Dr. Reginald. He is from Hyderabad. He is a young dynamic surgeon attached to Yashoda Hospital also, and he does so many of the surgeries with the aids of laser. He will be talking on the mechanics of the laser, and he will be showing some light how it is useful in the treatment or in the management of hemorrhoids. So I call upon Dr. Reginald, please.
ఇదేనా ఎట్లా ఒకసారి Good morning, everybody. I welcome each and everybody here, the delegates and the faculty, and congratulate the organizers. And I thank the legends of ISCP for giving me a chance and occasion to stand here and then talk. Thank you, sirs. I am Dr. Reginald. I am from Hyderabad, and I have my own center by name Satyaveda, where I usually practice my surgery, though I am attached to many other hospitals. Today I am going to talk about mechanism of laser and its safe applications in coloproctology. Before we start off, it all started with Albert Einstein in 1917 when he started to propose his quantum theory. This laser has come out through that particular theory and has been further developed by Dr. Leon Goldman, who is also known as the father of laser medicine, because he has taken it to much of the peaks. And there have been many people who have been involved at different stages of development of the laser, but one particular person stands out well by name Dr. Kumar, who has actually invented the carbon dioxide laser in the year 1964, and Dr. Kumar is still alive. He is there in US, and every year whoever has innovated good innovations are being given an awards by him in the US every year. And if at all we see, the diodes have been invented in the year 1962, but we are right now in 2023, and we are using diode now. It has taken nearly about more than 60-70 years to perfect the diode so that it can be used in human beings. So what exactly is laser? Laser is nothing but it's an energy. As Charlotte Clark has said, power when invested in the hands of knaves or fools generally is a source of tyranny. In other words, laser, which is an energy, if it is in the hands of untrained, can cause lots of complications, many complications, which there won't be any cure for such complications. That it can just totally burn the tissues. We can't replace a tissue. If you burn the anal canal, you can't replace an anal canal. You burn the rectum, you can't replace a rectum. So it is a good energy source. So we need to be very careful and understand and have some training before we get into the laser part of it. Yeah, as all of us know from our childhood, the laser is an acronym which means light amplification through stimulated emission of radiation. The moment we say light, we think what is visible. Light is what is visible to us. But as a matter of fact, laser falls in both visible spectrum and also in invisible spectrum. I'll get into it. And light, you all know, the heat, everything comes from the sun. The light comes from the sun. The photons, we've been studying about it. So obviously this light is having lots of energy. That is the reason it also produces good amount of heat. That's the reason we need to be very, very careful. This energy is multiplied several times and then using one particular medium. So what sort of a laser you want to produce, the medium you have to change. According to the medium, it could be carbon dioxide or NdAg or ERAg or it could be a semiconductor like a diode, or it could be a gas, anything like that, depending on what sort of a laser you want, you can change the medium. So this is multiplied in a given medium, and that particular medium gives only one particular wavelength. Every medium has its own way of giving out the radiation, that is, it gives only one wavelength. So the laser are having only one particular wavelength when they are coming out, and these are focused out through lenses and come out as a radiation. That is all about the laser. So laser is light multiplied using a medium where it is through a stimulated emission of radiation. As I said, laser also falls in both visible spectrum and also invisible spectrum. Actually, instead of saying light, we could have used the word electromagnetic radiation, and instead of saying laser, we could have said ether. That have made more of sense. Yeah, this is how it is produced. There's an exciting mechanism, like you give some electricity or whatever it is, some sort of an exciting mechanism which goes into the medium there. It excites the medium to produce one particular electromagnetic radiation that goes between two resonators, and it is multiplied and it is focused out through particular lens. It is very much focused. The one what I am pointing out there, the dot which you are seeing is also a laser, right? It is very much focused. So that is how anything comes out. So how do we classify the lasers? We can classify it by the medium what we use. It could be a solid, liquid, gas, or semiconductor. Semiconductor is a diode. The technique, whether you are touching the tissue or not touching, so it is contact or non-contact. The nature, it could be pulsed or continuous. It depends. Like when we start off doing the laser surgeries, we tend to tell everybody to go with the pulsed manner, so that you are very limited in giving your energy. Then the wavelength, whether it's a visible, ultraviolet, or infrared. So again, the power, whether it is high powered or low powered, that's how it's been classified. And depending on the medium, you can see there is a gas, liquid, solid, and semiconductor. And now as of today, we are using semiconductor diode in proctology. The gas, you can see helium, neon, argon, carbon dioxide. Carbon dioxide is one thing which is very popular even now today, which is being used in dermatology. And then in liquid we have tunable dye, and solid there are NdAgs and all these things. And then finally is the semiconductor, which is a diode. See, the diode can also be used in proctology. It can also be used as a biostimulation, which is not our subject, but basically it can be also used as a biostimulation, where the ulcers can be healed or the wounds can be healed by using a laser, particularly in diabetic foot and other things. So what happens when the laser falls in a tissue? So there is some sort of a laser tissue interaction. See, we all know as there is a heat, some protein has to get denatured, and once the protein is getting denatured, it has to go for coagulation. That's all we've been studying from MBBS first year. So here we see the coagulation, that is photocoagulation, that is because of the thermal effects, because of the heat produced, because of the denature of the protein. There is a photocoagulation. Later on, we also see what is known as a photochemical effect, where the bonds between the chemicals present within the tissues are broken. Like if it is water, H2O is broken. In all those things, there is photochemical effects. Photovaporization. Vaporization is at a temperature of 100 degrees, the water, whatever is there in the tissue, gets vaporized. The moment the water gets vaporized, the tissues start to shrink. The heat also produces shrinkage in the particular tissue. So that is photovaporization. Whereas photoablation, the moment you put that laser, the tissue itself vaporizes. It's not the water which is vaporizing, the tissue itself is vaporized. This particular technique of photoablation is nowadays is being used in cardiology, where they are trying to, instead of putting stents, they are ablating the obstructions in the coronary arteries. And a little bit of photoablation is also being used in coloproctology, which we come to know as we go by. Yeah, mechanical effects, lots of things. Like this is one of the effects of laser, what I'm using right now in my dear hand, and other things. So what happens, let's look at the temperature, what exactly happens. The normal temperature is 37 degrees, hypothermia is about 45. As you go to 60, there is protein degeneration and coagulation, and as you go to 100, that as I told you, there is vaporization because there is a steam, and beyond there is carbonization and melting. So when again to see this is how exactly once the laser beam is coming out, the core part of it is where the temperature is the highest. There is a reason there is vaporization followed by coagulation, there is carbonization, and then hyperthermia. You can see different layers there. So this, what does this say? The energy dissipates into the tissue. the laser does not stay at one place, but though it is focused at one place, there is a lots of energy which is going off into different, that means there is a lateral spread of energy, which we need to be very careful. If we are not careful, there are cases where it has caused perforation of the rectums, it has burnt off the, actually it has even caused fistulas. Lots of fecal fistulas have developed, lots of problems have come up, people came out going for laser hemorrhoidectomy, they came out with ostomies. Lots of things have happened because there is no proper control on the lateral spread of the energy, right? There's, as I told you, the laser ablation is one thing where we can also use to just ablate the tissues. It all depends what sort of a laser we use. There we can use to ablate carbon dioxide, or we can use ER-IACs. There are different temperatures at which ablation is done, but if you want to ablate something, you obviously need to do a biopsy before, because you really don't have any biopsy later on, because the tissue just goes off like that. The moment you focus the laser there, it's just gone, right? So that is how it is. These are the things where carbon dioxide and erbium lasers are used to ablate. There was a research which was done to know the temperature of the tip of the particular laser. Usually laser is produced within a machine, right, within a medium, and it is projected out through one particular fiber optics. The tip of the fiber optic, the tip of the laser, how much of heat is being produced, we come to know that the heat ranges from 40 degrees to 200 degrees centigrade. So it is quite high. That's the reason why we need to be very, very careful. If at all you touch the, you don't generate the laser, but you just put the, even the tip somewhere, you know, it's going to cause some sort of a damage. So all those things, actually, as a matter of fact, initial days of my journey in the lasers, invariantly I had pressed a laser and I was focusing the laser, instead of getting into the tissue, I just put the laser elsewhere on the trolley, and it burnt all the drapes. There was a fire in the aorta. That happened to me, right? It was an accident, and it did happen. That was the initial stage of me understanding what was happening with the laser. So we need to be very, very careful, because it's an energy and there's lots of heat, and there could be many accidents which can take place, right? What are the characters of laser? This is very important to understand. That is, it is very coherent. That means all the electromagnetic radiation waves which are coming out, they are in sync. That is, they are phased in one particular way. So this is all coherence. So the potential of that particular electromagnetic radiation is increased multiple times. See, this is all non-coherent. So laser is all coherent. It is unidirectional because it is focused. As I told you, the medium generates one particular type of electromagnetic radiation, that is, the wavelength is the same, so it is monochromatic. If you see the daylight, it is like VIBGR, daylight is having multiple wavelengths, but whereas laser light has only one particular wavelength, so it is monochromatic. It is highly directional. The reason of directional, other than being coherent, and it is also being collimated. Collimated means the waves are parallel to each other, so the divergence is very less. So that is the importance of laser and characteristics of laser. As I told you, it is monochromatic and it is collimated. It is going in parallel rays. Then what is the difference between a laser and an ordinary light? These are the difference, with the laser being monochromatic, unidirectional, coherent, and further, you know, the intensity is very high. It is collimated, that is, all the waves are parallel. It is a single wavelength. Monochromacity is there in laser, whereas polychromacity is in ordinary light. Polarization is there in laser, and Gaussian spatial profile. We will understand these two things just shortly. And of course, you know, if there is medical application, cutting and other things, mechanical applications of the laser are being used. Coming to this Gaussian profile, which I told you, it is a 3D profile which shows that the center of the laser, wherever it is pointed, it is the highest amount of the effect which is seen, but then the laser also affects laterally. So that is where this Gaussian profile is there. It's a 3D pictorial representation. Then again it shows that the energy is also dissipating to the lateral. So you should not think that it is only at a pinpoint thing what is happening. So if at all you continue to give laser, say for example you are using laser for hemorrhoids, and the hemorrhoids have not shrunk on the table, and you continue to give laser thinking you want to shrink that, but you are also increasing the damage by going laterally. The more you continue to do, the more time you are giving, the more lateral it is going on. So the more of damage is happening. So you don't expect anything to happen on the table immediately. Things happen in about a span of 2 to 3 weeks or 4 weeks. Things will better off. That is how it is. And what about the polarization? Polarization is that these are the light radiations which are having magnetic waves which are going at one particular angle. So all the electromagnetic, it's an electromagnetic thing which is happening. That is what we need to understand. That is what the polarization means. Yeah, talking about electromagnetic spectrum, the electromagnetic spectrum extends from X-rays to microwave. So in between is the visible spectrum, which is from 400 to 700 nanometers. Anything below 400 is ultraviolet, and beyond it is X-rays. Anything above 700 is infrared, and beyond is again microwave and TV and radio waves. Right now there are certain things which are coming, which some people are trying to replace lasers with maser. That is, they are, instead of light, they are using microwaves. They are using these microwaves to ablate some tumors in liver. They are using microwaves to ablate tumors in thyroid. They are using microwaves to treat fibroadenomas in breast. There are different ways we are doing. That is maser. So that is happening right now. And yeah. So if at all we see in the UV and infrared, these are invisible waves, whereas this is the visible wave. In UV you can see excimer, and in infrared range you have diodes, and you have NDAGs and ERAGs and carbon dioxide and all those things. The same thing is depicted here also, again excimer in UV and other things here. And visible range, what are the things the visible range can do? These are all the things which the visible range of lasers do. So what happens if the laser is falling on the tissue? So either it can get reflected. So absolutely there is nothing happening with the laser on the tissue. Either it can get absorbed, either it can transmit through. Maybe there is some small changes which happen in the tissue because it is going through the tissue, or it can get scattered. If it gets scattered, the energy is getting scattered. The best of all these things is if the laser can get absorbed into the tissue. So you just focus it on one particular place and it gets absorbed. All right. So the absorption depends on many multifactorial, but then again two things stand out. Again, the laser wavelength and the tissue optical properties. Tissue optical properties is one thing which is very important for us to understand. Where the terms like chromophobes which come up. Chromophobes are some material which are present in the tissue which actually absorb one particular wavelength. That is the wavelength. So for example, if at all we are hemoglobin is red in color and this is hemoglobin, you can see the hemoglobin is absorbing a wavelength which is around 400 to 500, whereas if it is melanin is taking at a wavelength around 300 to 400. That's why if at all somebody is treating melanin on the skin, they use a laser which has a wavelength which is in this range, and water is taking up from 1000 and beyond. So if at all we are thinking in terms of fistulas or fissures or even hemorrhoids which have both blood and also water, I think we need to be matching somewhere in this area a wavelength which is absorbed by these things, so that particular hemorrhoidal tissue can act. We can act better on that things. So it is somewhere around 1000 and just beyond 1000 is the what is the nano wavelength which we are supposed to be using if at all you are trying to treat in proctology. See, there are benign uses of laser and there is also malignant uses of laser. Yeah. So I'm rushing, sir. Another 2 minutes, I'm done. So this is the same thing again. Some of the terms which we need to use know is watts. I will not dwell into this. I would like to tell that we belong to the class 4 where there is a damage to both the skin and the eyes. So we need to be very careful. And this is one thing where they have come up, and this is what diode we use. The most common diode what we use is 980 and 1470. Yeah, this is how the diode machine is there, and this is how fiber optics it is coming out, and these are the tips through which fiber optic comes out. We need to be wearing some protective eye glasses or eye shades, whatever are very needed. This is how the laser is seen in my fingers, and the laser the fiber optics are divided into 3 different things, and they are strengthened by using the coating of polymers or metal or quartz. This is this is the one radially emitting. This is 360 degrees, which is usually used in fistulas or in pilonidal sinus, where the laser is going 360 degrees. This is the one conical tip with quartz, where it can be used in hemorrhoids. How to sterilize? ETO is one being done, but basically fiber optics are to be disposed. What not to do? Never push against the resistance, or else the fiber optics will break. And what we need to know is about the wavelengths and any software updates and other cost and other hidden things which are there in the devices. And precautions: always put a laser hazard outside the OT and use your goggles and proper protection. In proctology, it all started with carbon dioxide, later on went on with NDAGs, then came the diodes. Speed diodes are now very easy because it is compact, it is minimal discomfort, less bleeding and faster healing. It can be used in benign diseases like hemorrhoidopexy, sphincterotomies and fistulas and pilonidal sinus. Here it is still a big debate in fistulas. As I told you, in malignancies it can be used to ablate. If at all there is an obstruction, we can ablate and get through it. Japanese says it can be used in conditions where it is less than 2 centimeters and only mucosal and submucosal, whereas the US people say anything till about 3 centimeters of T1 and grade 1 can also be used. There are certain drawbacks for all the surgeons. Need to have training. It is quite expensive. Once the damage is done, it is irreversible. This is all about the lasers. Thank you. Yeah, sir. I'll just because Shantivardhini madam is not unable to come here because of some personal problems. I would like to project one hemorrhoidal surgery which we have done. Me and Ganga together have done this particular case. Just another 4 minutes, sir. We are done with this. Yeah. So me and Ganga have been working together for the past 17 years. 1 second. No. Hemorrhoids. Yeah. We as a team, me and Dr. Ganga, we are working for the last 17 years. And this one particular thing which we have done together in one of our friends' hospital, and the patient is also a common friend of ours who's an anesthetist. So we did a laser surgery here. We have been trying actually to show the stirrups which we use, which are hydraulic stirrups, which are very good for us and very comfortable for the patient, which gives some protection for the legs and also for the nerves. I'll just rush through it. So he's trying to show that the comfort given to the legs there. And this is how what we start off doing is we actually spray the laser after draining the blood, about 60 joules of it. There are many people who don't do it, but we do it. Till date we had never problem by spraying. Some people, if at all you go much closer to the mucosa, you can burn the mucosa, you can also cause ulcers of the mucosa, so you need to be there. Why do we spray? Because the energy gives some tautness to the tissue there, because there is a protein just takes it up and gives some good tautness. This is a thrombosed pile mass which has been cut open and then is being brought out, and then we can also enter through the same incision made for the thrombosed pile mass. Okay, see the bleeding, whenever we are using the laser, the bleeding is very, very minimal or zero level of bleeding is there. We can go through the same thing. You can see the laser tip there, excision of the thrombosed mass. Then I'll just go through. Yeah, I'm sorry. I'll have to show you the entry of the laser. So that's how we have entered at the dentate line, and we are checking the light. It should not be too bright, neither it should be too dull. If it is too bright, it is closer. This is closer to the mucosa. If it is too dull, it is closer to the lateral walls. So we need to be very careful. Once we come in between, then we start ablating the hemorrhoidal artery. That is about 4 centimeters above the dentate line. We give about 70 to 80 joules. Sometimes we go for 90 joules. So hemorrhoidal artery is ablated, and we come down ablating everything else, shrinking the tissue by giving another 80 joules. That's how we come out of it. But then immediately once we are out, we clean and then put. He is continuing with the other one, but in between we have put in ice cubes there. Ice cubes which are designed to accommodate into the rectal canal and the anal canal. So we just put those ice tubes. That's the entry again. We are going in. We usually go through the dentate lines. There are surgeons who go through the intersphincteric region, but in initial days of our practice, we started with the intersphincteric region. Now we are going through the dentate, because dentate is a fixed line, and the hold is good, and the bleed, post-operative bleed is very less there. So, but one important thing is, as we do that, we keep on moving the laser. We don't put it at one place, so the burns won't be much. See, and slowly we continue to withdraw, and as we come out, we just burn that opening and then come out. So there is absolutely no pile mass. I mean to say no bleed. So that's it. Thank you. Yes, sir. Yes, sir. The stirrups are ready-madely available. They are very comfortable for the patient, and we are very happy because they give lots of padding and protection, so that the nerves of the popliteal area, everything is.
And till now, is there any laser machine which uses both 980 and 1470 in the
sir,
same procedure? Not either of them, but both.
Till date, we have not come across it, sir. Either we used 1470 or 980, but there are machines which generate both the things, but I don't think they generate at the same time.
Okay.
And actually, these laser techniques nowadays this is a pure laser technique which I have shown. These are indicated only in second and third degree piles. They have actually,
most of these companies are promoting 980 nanometer for the anorectal.
Yes, sir.
And 1470 for the vascular means varicose
exactly,
veins.
sir, because 980 is more absorbed by the hemoglobin, and because it is near 1000 meters, nanometers, again little bit of water also takes it up, but in varicose veins it is all more of water, so the shrinkage is more when we use 1470. But 1470 is a better choice because the amount of energy to be used is much less, so the burns or the lateral spread is much less, sir. It is more safer. 1470 is much safer than 980.
Great.
Yeah. So last one word before I conclude. This is pure laser procedure. The laser procedures usually are indicated for second and third degree. There was a time when I also did for fourth degree. Touch wood, and by God's grace we went off. But there are many other degree techniques which can be done for the fourth degree and third degree also. And laser can also be done with a hybrid. You go with you take a circle of and dearterialize, and then by a suture, and then again put a laser. There are people who are doing proximal layer of Chivetek procedure and doing the rest of it by laser. What we feel is, if at all you go for Chivetek procedure, better finish both the layers and come out instead of making it a hybrid. Thank you.
Thank you, Dr. Reginald. You tried to cover everything. It's a very big topic as far as the mechanics of the laser is concerned. But now we move on to a very important topic of hemorrhoids again. And this will be the MIPH, indications, technique, and how to avoid those complications, those who have been depicted in the literature. And no other than a person, one who can be a master of it, is Dr. Rahate. He is the president of ISCP. He has many things to his credit. Where I should start is a question. He is a robotic surgeon from the Vidarbha region. Extensive doing laparoscopic surgeries, many more open surgeries, surgical procedures, and rampant 300 to 400 procedures in a month. You can just acknowledge the crowd of the patient that he does have. And he has done so many of the MIPH procedures when the MIPH was introduced in India. And that time he has done it regularly. He has treated many of the complications of it. He has got his separate presentations on MIPH complications also. But now this topic was given to somebody else, which could not be, he could not attend that, so that now he will be speaking on. Before that, I will be asking some two chairpersons to hold these chairs, Dr. Mronal Ketkar madam and Dr. Jiten Chaudhary sir. You please take those chairs, and I will ask Dr. Rahate sir to continue and to elaborately talk upon the MIPH. Thank you, Doctor.
Thank you, Ladukar sir, and thank you, Solapur Surgical Society and ISCP for organizing this. Can we connect this fellowship workshop? And yes. So coming to the complications of MIPH, basically this procedure is going to be demonstrated in the workshop. So we will be talking in detail during that time. So we will try to cover the complications and how to treat it. There are few videos. This is not a horror show, but definitely we come across this type of complications a lot. So as everybody knows, MIPH is basically removing the strip of mucosa and submucosa, not the muscularis, at the level just above the dentate line, so that the newer staple line which is formed is just above the dentate line and not below the dentate line. So there are very rare and potentially devastating complications. If we label it, there are n number of publications available regarding these complications and how to deal it. So if we start enumerating, at least one adverse event is there in almost 36% of the cases which we operate. Readmission bleeding is in 12%, reintervention in around 6%, and so on. So we will see in detail every complication. So there are almost 20 complications enumerated around about this use of MIPH or by the stapler technique. So there are immediate complications, those are due to instruments, and there are certain procedural fault, and there are certain delayed complications. The complications due to instruments that cut but did not staple, that is the most horrible complications. We have faced this particular complication in one of the ISCP workshop also in Durg, where we had a very torrid time in controlling the this thing. And impossible to remove stapler, that is, stapler was stuck up. While manually disengaging staplers, the company people, they can train you how that stapler is to be disengaged. There are various knobs available over the staplers, they can be utilized, and in both cases we have to do trans-anal manual repair. We will see this video that I have taken up a proper purse string. There was engaging of the stapler gun to the anvil, and it was fired. And after it was fired, there was even click sound, and once we remove it, the anvil didn't come out, and the staplers, they are all there seen. So what is to be done then? You have to take a different stapler, different gun, engage it again and fire it again. That means the stapler were not in a proper way. Or there can be a rare thing that since I have heard the click, without hearing the click, that stapler must have been fired. So that was the faulty techniques. The rectal bleeding, deeper tissue bites if they are taken, the muscular layer is taken, then there are going to be many complications, particularly stricture formation will be there. So we need not take deeper tissues, only mucosa and submucosa is to be taken. And particularly in portal hypertension, there can be lot of bleeding. So it is not a good choice for portal hypertension. If we see the varices at the level of the anal canal and rectum, try to avoid this particular procedure. If the coagulation profile is not seen, is not measured properly preoperatively, that can again bleed. Then chronic proctalgia can happen because of the staplers lying there for months together. So that is, those staplers are to be removed. We will see all these things. So acute pain, if the purse string is carried out too close to the dentate line, either in the lower rectum or in the upper anal canal. So readmission rate is almost 1.6. So proper positioning of the your suture line is very important. And if the pain occurs, then it will be there for at least 6 months to 8 months, and patient will have a hell of a life, and you will have to manage by various combination of the painkillers. So if the hematoma also occurs, if the infection occurs, then also it can lead to pain. So proper preoperative cleaning of the anal canal and rectum is also mandatory. The chronic pain can be there because of the suture adhesions, associated anal fissure, anorectal sepsis and retained staplers. We will see these retained staplers here. These are the pins which are very well seen on CT and MRI. MRI will give a different picture there. And in this particular MRI, you can see that this particular part of the muscular layer was also taken in the stapler, and that was the reason of pain. So if your tissue bites, they go deeper into the muscle, that side of the muscles, they are also removed, and that will give lot of pain. So chronic pain treatment is, if these staplers are remaining there, that particular removal of those pins, that is mandatory, and that particular procedure is called as agraphectomy. And how that is to be removed is a very simple technique. These retained staplers, they can be removed endoscopically or by proctoscopy also. If they are higher up, with the help of endoscopy, it can be removed. Otherwise, just apply a artery forceps and apply energy source to the artery forceps at the back near the grip. It will immediately come out. So retained staplers, they are a very big cause of chronic pain. Even this retained stapler can lead to this type of picture, granuloma formation, and they can cause pain also, and they can lead to lot of bleeding also, recurrent bleeding. So in such condition, we have to cauterize this particular granuloma, and hidden stapler is to be removed. So rectal bleeding, if it is, it also depends on whether they are thrombosed hemorrhoids, you have operated on thrombosed hemorrhoid or grade 4 hemorrhoids, then they are, the chances of bleeding is more. Reoperation after PPH again goes in for more bleeding, and this occurs before the end of the month after your procedure. To minimize the risk of bleeding, 4 factors may help to minimize this risk of bleeding. Manual overstretching of the staple line, use of PPH 03 gun. That means it should be around 31. The size of the gun should be 31, so that the staple height is very good. And if you expect a lot of prolapse, then you have to go in for the bigger size gun, where the staple height is more. So the selection of the stapler is also very important. We will see this video. There was definitely bleeding after firing. So figure of 8 suture at that particular level will help. But the drawback of this particular method of taking figure of 8, that it can hide the staplers way down into the tissue, and it can go in for formation of granuloma or retained staplers after that. So controlling bleeding by figure of 8 is also having both ways. The complications can be there, long-term complications can be there. So this was a MIPH patient, my own patient, which had bleeded like anything and was not controlling. So ultimately the interventional radiologist did control by doing angiography and embolization. Then the skin tags can cause pain, thrombosis of the remaining hemorrhoids, they can cause pain, fecal impaction can cause pain, and chronic proctitis can cause pain. Then coming to the stricture formation, if we take the sutures very deep, the strictures can be formed because of the muscles being removed. So we will see how those are to be tackled. Usually these strictures, they are very soft. But if the muscle is taken, a large bulk of muscle is taken, then very thick stricture can happen. So in order to prevent this stricture, how that is to be judged? You can see, you should see the needle passing through the submucosa and mucosa. That is how you can prevent the taking the sutures very deep. So this is how the strictures they happen. This was a very soft stricture. Just manual dilatation was done and everything was okay. And patient needed few of the repeated dilatation post-operatively. This particular patient had a very thick stricture, and we will come to this particular what has happened. This particular purse string which was taken, the surgeon jumped from here directly to here. So this was the shelf which was formed. Many times you see that the staples will be there, but the donut which is formed will be thin from one side, and that can lead to this type of shelf formation. In this case, there was lot of muscle which was also removed from the other side. So this was a technical fault. A bad surgery was there. So we will see how that was tackled. Endoscopically, this can be tackled, and you will be surprised to see how thick these strictures they can become. And this is a very simple procedure. This can be tackled endoscopically. There is a L-shaped hook available endoscopically, and you can see the retained fecal matter coming there. And that L-shaped hook, we can give a Mercedes-Benz incision at 3 levels. Don't give at 12 o'clock and 6 o'clock. Otherwise, as Ganga Shankar has explained beautifully in his anatomy lecture, it can lead to deformity, the keyhole deformity. This is an endoscopic view. We see exactly opposite. So this is actually happening at 11 o'clock, 1 o'clock. In endoscopy, we see the upside down vision. Right is seen as left, left is seen as right. You can see how the stricture was thick. So it can be removed under vision endoscopically by a very simple technique. The L hook can be used and simple monopolar cautery can be used. Whatever bleeding which occurs at that particular level, endoscopic artery forceps, that is called as coax forceps, that can be used to control the bleeding. Yeah. So that was, again it was repeated at 3 levels. So for want of time, I will shift to it. So this was the MIPS stricture, very low firing. We can see a bad technique, again simple dilatation. The stricture comparison, as I have told you, compared to that of the excisional hemorrhoidectomy, the stenosis is easier to treat. Yeah. And this is the picture of proctitis, which is again a cause of chronic pain. Local abscesses can occur. The rectovaginal fistula can also occur if proper vaginal clearing is not done. Finger insertion into the vagina while taking the purse string suture, and even after closing down the staple, we have to check at 2-3 times, so that this is how we have to check it from vaginal side, whether the suture is palpable. A bare suture is palpable into the vagina, we have to see it, so as to prevent. Otherwise, that particular vaginal mucosa will come into the staple line, and there will be rectovaginal fistula. Rectal perforation can also occur, that can be tackled either through the anus. This is how the dehiscence occurred in this particular patient, and these dehiscence will never close down, because the sphincter here will be increasing the pressure of the anal canal and rectum, and that particular pressure will push the fecal matter and the infected material back into the cavity, pararectal cavity. So what is to be done then? So this endosponge treatment is available by B. Brown, and it is attached to the vacuum, that is the vac dressing is done, and gradually the cavity collapses. Enterorectal fistula can also occur if there is a enterocyl, and if you are not giving proper head-low position, particularly in female patient where hysterectomy has already been done, this thing can happen, that deep Douglas can have loops of intestine, and you can take the purse string, and one of the purse string can engage the small bowel loop, and that can cause enterorectal fistula. If the patient is having ascites, this ascites is also pushed, and that can also lead to peritoneorectal fistulas. Then duplication cyst can occur. The mucosa which is hidden will go on secreting the secretions and will lead to development of a cyst there. Complete rectal obstruction can also happen and has been documented. What is the mechanism of rectal obstruction? If the anvil goes in between the two stitches, two loops of the purse string, it is not going exactly through the middle of the purse string, but by the side of the purse string, then complete rectal obstruction can occur. A rectal pocket formation, as I have already told you, if there is jumping of the purse string, rectal pocket formation can occur, and this can lead to inspission of the fecal matter there and chronic pain. So that is called as sect. Then penile trauma, particularly in homosexuals, it can happen. The retained staplers can lead to, the documents are available in the literature. Tenesmus and fecal urgency can be there because of the low firing of the fecal staple line. The posterior tibial nerve stimulation, that is the very simple technique, and it can be done by the physiotherapist. Posterior tibial nerve is having S2, S3, S4 innervation, and the same innervation is at the anal canal and the rectum. So stimulating this will lead to proper ameliorating the this thing. So these things have been documented in the literature. Pneumoperitoneum has been caused because of the retroperitoneal infection, and it was a very life-threatening complication. Yeah. So deep purse string suture, immunocompromised status, and dehiscence can lead to this type of complications. Recurrence can be there. Almost some of the series they have given us figure of 58, but average most of the series they have given around 6 to 7% recurrence. That is quite low, but around 15 to 20% in Indian scenario. And the recurrence is usually at the level of the anal tax and recurrence of the hemorrhoids. Recurrent hemorrhoidal disease after staple hemorrhoidectomy, the management, how many times that stapler can be fired again? At the most 2 times, because that decreases the rectal compliance and patient will have multiple time fecal matter visit to the washrooms. Otherwise, the other thing can also occur. It will decrease the sensitization of the rectal ampulla to the collection of the fecal matter, and patient will have a low ejection fraction of the rectum. Similarly, we see the ejection fraction of the heart. There is a concept of seeing the ejection fraction of the rectum. That is particularly done by the done on MR defecography. How much of the fecal matter was there before defecation and how much remained after defecation. So both things can happen if multiple times hemorrhoidal surgery, the stapler surgery is done. So management of recurrent postoperative, we have seen the best option is to treat it by either Chiute's or by Milligan-Morgan, not to fire again the stapler. And we should not do this type of unhealthy things because this can lead to infections, definitely. So the take-home message is use judiciously staplers in properly selected patients. Grade 4, more complications. Grade 3, less complication. Grade 2, more less complications. So mentorship during the learning curve is very important. Avoid complications by perfectly following all protocols. Keep a close watch on complications. Early diagnosis of the complication should be the rule, and treat complications early and take help of your seniors and colleagues while treating the complications. Thank you very much.
Nice lecture, sir. House is open for the questions. Till the time the ceremony preparation is there, house is open for the questions. Yes, sir.
Prashant?
Yes,
Small
Vijay.
question. There are now new companies coming with the 3 rows of staples. Where to use the 3 rows and where to use 2 rows?
See, there is not much advantage of the 3 rows and 2 rows, over the 2 rows. But there is one paper by Xu Lu, a Chinese worker, who has done 800 firings by 3 rows and 800 firings by 2 rows. And what he has said, the rate of complication of bleeding is less in his study. Secondly, in portal hypertension, he has fired few of the staplers, and he said that it is better in portal hypertension. And yes, please.
Also, some patients who are on blood thinners,
Yeah.
can we use a 3 row staplers to be on the safer
Yes,
side?
that is what, where there are bleeding coagulation profile abnormalities and chances of bleeding, there 3 row stapler can be used.
Thank you.
But the problem with this 3 row stapler is their anvil is short and it is very difficult to tight the anvil with this. So they are now coming up with a new batch of staplers with a longer anvil. That is what. But that is the only advantage which is there in the literature, that in cases of coagulation defects, the 3O is more helpful.
So many
Otherwise, there is no advantage.
Many people are advocating this 3 rows for the star procedure. They are saying that for the star they have got little more advantage than the. Is
No,
that
no,
true?
no. In star, we have to use a larger size housing
Okay.
because we are doing a full thickness resection.
Okay.
So larger size, 34 size housing is advocated for stapler. It doesn't make any sense with the, and all larger size 34, they are having a higher stapler length.
A lot of problems are being inherited because of the staples.
Yes.
Can we have staples with the PDS or Vicryl like we have?
Absorbable
Absorbable
staples.
staples.
I don't know. I don't know. If you are come across any references, please tell us.
No. So there was a lot of enthusiasm regarding when the staplers came in the market that it's a foolproof procedure or something. Do you think that it still holds true nowadays also? Is that the recurrence rate really less with the staplers? The kind of enthusiasm the staplers generated almost 10-15 years ago when it was launched, is that enthusiasm still there with the surgeons?
See, this is a procedure which is very generating very less pain, but simultaneously it is also having lot many complications, particularly subjective complication. The user who is firing this stapler, if it is a faulty technique, it can lead to lot of complications. So this procedure is not at all a complication-free procedure. Only thing is less pain, and patient will prefer. There is also a paper available, a very good paper available, that after recurrence by stapler, the patients were subjected to the routine surgery, that is Milligan-Morgan, and few of the patients where they were subjected to the staplers again. So the staplers again, patients were happy post-operatively. Yes, sir.
Prashant, good morning.
Yes, sir.
In the same context, I'd like to ask you, will Chiute's procedure replace
Yes,
MIPH?
it has a great potential, and that is the reason why we want a good registry. We have already formed one app. There are few hitches in that particular app. So it will be circulated, that app will be circulated to all the surgeons of India, and those who are doing that Chiute's procedure, they will be giving the preoperative details, intraoperative detail, and postoperative follow-up of those patients. So we are creating a registry in 2-3 procedures. Only few hitches are there. That app has already been developed. So that will be circulated, and then we will come up with a very big study from the Indian subcontinent. And we will replace this particular thing. Yeah.
So that's a great
I
news,
think
sir.
we should try and do that.
Yeah.
Sir, that's a great news.
This is the ISCP doing this thing. Thank you.
Thank you, sir. Thank you so much.
Thank you.
Good morning, everybody. I welcome all the dignitaries and I request our Dr. Dean sir, Dr. Sudhir Deshmukh sir, please come up on stage. Dr. Chivte sir, Dr. Rahate sir, Dr. Ladukar sir, Dr. Shivpuje sir, Dr. Ghatole sir, and Dr. Amjad Sayyed sir. Nice. Good morning, all friends, senior and junior colleagues. Today, this beautiful morning, we have assembled here for inauguration of CME Coloproctology Vision 2023. I welcome you all behalf of the International Society of Coloproctology and Solapur Surgical Society. We are fortunate here to have Dr. Deshmukh sir, Dean of Dr. V.M. Government Medical College, an eminent surgeon, as a chief guest to inaugurate the CME. Now I request Dr. Ghatole sir to welcome the guest.
Welcome all the guests and the delegates. We are fortunate to have Dr. Sudhir Deshmukh sir, Dean of Dr. V.M. Medical College, Solapur, to inaugurate CME. Sir himself, being the very eminent surgeon, will guide us words of encouragement during the inauguration. The face behind the today's workshop is Shanti Kumar Chivte, eminent coloproctologist. I welcome him. Dr. Rahate, President of International Society of Coloproctology, Dr. Ladukar sir, the Secretary, Dr. Shivpuje, President Solapur Surgical Society. I welcome all the dignitaries for this inaugural function.
Now I request Dr. Shivpuje sir to felicitate our chief guest, Dr. Deshmukh sir. Now I request Dr. Jaikar sir to felicitate Dr. Chivte sir, founder president of ISCP. Now I request Dr. Ghatole sir to felicitate Dr. Rahate sir, president ISCP. I request Dr. Rode sir to felicitate Dr. Ladukar sir, Secretary ISCP. I also request Rode sir to felicitate Dr. Shivpuje sir, President Solapur Surgical Society. We all are committed to protect Mother Earth by planting more trees for a better world to live for the next generation. So today we will water the plants to signify the good omen. So I request to all dignitaries to water the plants which are kept over here. झालं. I rec- I request Dr. Chivte sir, Dr. Rahate sir to plant the trees. आहे. Thank you everybody. Now I request Dr. Jaikar sir, Professor and Head of Department of General Surgery, VM GMC, to introduce the chief guest.
Good morning to all the delegates and faculties for the today's workshop in CME. Myself, Dr. Ritvik Jaikar, Professor Head, Department of Surgery, Dr. Vaishampari Smriti, Shaskya Vaidyakiya Mahavidyalaya, and holding the additional charge of Deputy Dean. It's my privilege, honor, and pleasure to introduce our respected Dean, Dr. Sudhir Deshmukh. I've been working with him day and night since 5 to 6 months when he had joined as the Dean over here in the month of January. In brief, I would like to introduce, because his biodata is very vast. Dr. Sudhir Bhaskarrao Deshmukh basically is a general surgeon, and it's my pleasure to tell you all of you. He has been working as a faculty in the Department of Surgery since 35 years. He became professor in the year 2000 and MPSC selected professor again in 2008. He became for the first time Dean in the year 2013 at SRTR Medical College, Ambajogai. Later on, he was again given the charge of Shankarrao Chavan Government Medical College, Nanded. Again, he was given charge of Vilasrao Deshmukh Medical College, Government Medical College, Latur. And in the month of January, he joined over here at Dr. Vaishampayan Memorial Government Medical College in Solapur in January. He is a member of Management Council of Maharashtra University of Health Sciences, Nashik. He is right now member of Academic Council of Maharashtra University of Health Sciences, Nashik. And he is the elected member of Governing Council of ICMR, New Delhi. And I have the privilege to work with him since 2010, when he was my teacher, and he has been my guide throughout the last 20 years. And right now, under his privilege and guidance, I am working at Deputy Dean. Thank you, sir.
Thank you very much, sir. Now I request our respected Dean to felicitate Dr. Amjad Sayyed sir for giving us this venue for in very short time and giving his hospitality. Thank you very much, sir. Dr. Amjad Sayyed sir, Chairman of Noble Super Speciality Hospital, with cooperation of ISCP and Solapur Surgical Society.
The man behind making this program successful and very cooperative, and is a being heart surgeon. His heart is also very helpful to us. Thank you.
Now I request Dr. Dean sir, our chief guest, to address the gathering.
Good morning all. Today's
Coloprocto Vision 2023, Solapur. This CME operative workshop and prestigious fellowship International Society of Coloproctology FISCP being arranged in Solapur by the International Society of Coloproctology and Solapur Surgical Society. On occasion of this inauguration, the dignitaries on the dais, the founder president of Coloproctology, Dr. Shantikumar Chute sir, the present president, Dr. Prashant Rahate sir, and the secretary, Mr. Lakshmikant Larukar sir, the president of Solapur Surgical Society, Dr. Vijay Shivpuje sir, dignitaries on the dais and dignitaries off the dais. At the outset, I declare the Coloprocto Vision 23 to be open for all the delegates. I am really happy to know the subject of this particular CME. Now, this is a very common problem of the society. Coloproctology is more common than we see, because people less oftenly complain unless the problem is severe or unbearable. At that time, they start coming to doctors. That is the problem or hitch in treating the diseases of coloproctal area. So coloproctology, as you already seen, is dealing with the diseases of colon, rectum and anus. Really, this itself is a super specialty, I think. One has to treat this as a super specialty because this is a very important area where the treatment needs to be very meticulous and focused. This we are going to learn in this particular CME, that is continuing medical education. Our students are also attending. I am very happy to see this particular conference being arranged here, or CME being arranged here, workshop being arranged here in this particular hospital. I will again tell you, the modern science, rather our allopathy, have failed to publicize the treatment modalities, rather what we have got for the coloproctology. There has been a tremendous development in the treatment of coloproctology also. We have a lot improved the treatment of abdominal diseases by laparoscopy, single port laparoscopy, robotic surgery, the advanced investigative modalities like the CT, MRI, the various modalities of investigation have really improved our focus in diagnosis. So we are now very much focused on diagnosis. So whatever we were calling before the abdomen as a magic box in our days, now it has not remained a magic box. We are very much improved our investigative modality so that we are able to diagnose the disease. Likewise, in coloproctology also, the diagnosis is not a problem because of advanced medical investigative modalities. Radiology really improved the focused diagnosis. We are able to pinpoint the diagnosis, and that pinpoint diagnosis also with advanced techniques of treatment. Rather, we have seen that now laparoscopy has helped in the colonic surgery. There is a lot of improvement. So the incision has reduced. Minimal access surgery or minimal incision surgery has reduced the incision. So chances of infection, chances of post-operative pain, early joining the duties, and a very good vision because of the magnification of images has really improved our focus to the colorectal diseases. Now what we want, we all know that we have got all the modalities. We have got the laparoscopic surgeries to be done. We have got the scopic surgery, colonoscopic surgeries can be done. We know we can do the nodes, we can do the single incision laparoscopic surgery, we can do the nodes, natural orifice, endoscopic surgery. All these are there with us, but the promotion, or rather the publicity of the treatment development in allopathy has not been done properly in the society. That is the reason that quacks are treating these diseases more often than the allopathic doctors. This is the picture in the society what everybody sees. You must also have seen that. People don't report to the allopathic doctor for colorectal diseases. Rather, they prefer the quacks and the other persons who are sitting on the roads, and they are trying to treat the patients like colorectal diseases. So this is the hinge in our publicity. We are not properly publicized. We take the conferences, but we are only focusing on doctors only. But doctors are not publicizing the developments in allopathy which are there in the colorectal diseases, so that we can treat the colorectal diseases more oftenly, more focusedly, and more with less incisions, so that pain can be reduced, there can be early recovery, there can be good recovery, and there are very good treatments available in allopathy also for the diseases which is not known to the society. So our now aim should be to publicize whatever we have developed to the society at large. This is very important. We know everything as a surgeons, but many non-surgeons, doctors who are not surgeons, also don't know the variety of treatment available by the allopathic doctors that have been developed in recent past. There has been a paramount importance and paramount change in the treatment of the colorectal diseases, but that should go to the society, that should go first to our fraternity also. So our fraternity is also ignorant about the developments in the treatment of surgical fields. So that needs to be rather publicized. It should be focused to do the things so that the doctors, other doctors should know, the society should know that there is a good treatment available in allopathy for colorectal diseases, and these conferences should be made public so that the people will understand the importance of allopathics, because ours is a science. Because we are allopathic sciences, we can repeat the results. Whereas in other sciences, many times they don't know the result, what outcome is there. And that's why they are not science. So we are a scientific people. We are treating the diseases with a scientific base, and that scientific base is very important. We have proved many things in many other factors, like the heart diseases. We have seen acute myocardial infarction. Now that can be treated by angiography, angioplasty, and at last requirement of the CABG or the heart disease, or rather the bypass surgery. That is known to everybody. Every part of society knows that heart attack needs a allopathic treatment. Immediately we can go to the physician, he will take a ECG, he will give you vasodilators and thrombolytics, and afterwards he will refer you to cardiac surgeon, he will do your angiography. If there is a block, he can use angioplasty or subsequent bypass surgery. So this is known to every person in the society. But similarly, treatment of the diseases which is so common in the society, I think 20-30% of people are affected by some or the other disease of their colorectal region. But they don't report to the doctors, or rather allopathic doctors. And we are the proper persons in treating these diseases. We have developed the techniques, we have developed everything, but we are lacking in publicizing our developments. So I request all the surgeons to please not only publicize in surgeons only, it should go to other faculties also, it should go to society also, so that these kind of treatment will be available to the society at a cheaper rate. That is most important. So now people see to the doctors as who are taking more fees. That is the issue, and that's why they don't report to the allopathic doctors. Now we should make the treatment available at a reasonable cost to the common man of the society. That is more important. If you increase the number, increase your publicity, that we can treat it properly, better than any other persons, with minimum chances of infection, minimum incisions, minimum pain, you can go to your work, report to your work as early as possible, then people will come to you in queue. But this needs a proper publicity, which should be done by we only. We are the persons who are responsible for doing this, and beneficiary are we. But at the same time, our beneficiary is our society. That we should keep in mind. So we should treat the society at a reasonable cost, and that if you do, then I think the colorectal diseases will really get a justice in the society, and our surgeons will get a better platform, because we are thinking that neurosurgery has gone to neurosurgeons, head has gone to neurosurgeon, CVTS has gone to cardiac surgeon, then everything has gone, general surgeon is having nothing. But here is the bread and butter of general surgeons. If you do it properly, you can even do a very good work even with MS general surgeon also. But do it meticulously, do at a cheaper rate, do it very sincerely, follow the earlier developments, recent developments. You should know, you should be updated in the CMEs, so that you know the recent advances in the treatment, recent advances in the investigation. There you should take care, and students particularly appeal them that even a general surgeon can do better practice and better service to society by doing these things. So at last, I congratulate all the delegates for attending this particular. Huh? Acha. Free. There is announcement from organizers that today's operative workshop has been said to be free for you, so you can enjoy that. So at last, I thank the organizers for giving me an opportunity to interact with you. Thank you so much.
Thank you very much, sir. Now I request Dr. Rahate, sir, President ISCP, to have few words with us.
Yeah, thank you. Respected Dr. Sudhir Deshmukh sir, Chivte sir, Dr. Ladukar, the President, Solapur Society, Dr. Vijay, Dr. Jappa, who is the EC from this region, pharmacy, and all the senior surgeons from the region, all faculties for ISCP and fellows and my colleagues. It is my real pleasure to be with you and expressing my some thoughts. As Dr. Deshmukh sir has said, see what happens in medical colleges. I am not blaming the system, but usually the anorectal surgeries, they are kept at the last. By that time, all the senior surgeons, they have left after getting exhausted from the major surgeries. And then the residents, they try to do the anorectal surgeries in the third or fourth OT, and they are not given proper training, they don't have the proper mentorship, and therefore what ISCP is already planned, and we have done the few programs in medical colleges, but there were certain hitches, particularly from the medical colleges, head of the department or dean level, that why a person who is not on roll in medical college should come and teach the medical students here. But for that matter, we have changed our modus operandi. We stand there and just guide the students how to operate the chief test procedure, how to operate perfectly the Milligan-Morgan. The lasers are not available, unfortunately, in 99% of the medical colleges. So we take the lasers there and try to give them the training when all the senior people. So what is happening now? The senior people, they are coming to attain that particular thing. So this is how we are making the change. So proper training at the level of the association level to the budding surgeons, who are going to be the backbone of the society. And again, the registry thing we are developing, and the data from the Indian surgeons that will be projected to the world. And that is how we are working now in this ISCP. And we are giving n number of opportunities to the newer surgeons as a faculty in various conferences. The last WorldCon was organized by the youngest surgeon from Agra, who was not senior. There are at least 10-15 senior surgeons above him. So, and he did it fantastically. So that is training the leadership also. That is what the ISCP is going to do. Regarding this fellowship program also, we do operate the patients, and the residents or the fellows who are attending here, they will be assisting us. And if the cases are more, then even we try to ask the fellows to operate, and we just observe, and that will be given live. So that is how the type of training the ISCP is doing. And just I wanted to highlight the work of the ISCP. Therefore, I don't want to be in between you and CME and the live operative workshop. Thank you very much again. Thank you. Today and tomorrow we are operating around 10 to 12 cases by all the faculties of the ISCP. So please do attend the live operative workshop, and there will be prolapse, hemorrhoids, recurrent fistulas, post lift complication, then post procedure complication. There are few cases, so we'll be operating all those cases. Thank you.
Thank you, sir. Now I request Dr. Shivpujay sir to propose the vote of thanks.
Good morning. On behalf of ISCP and Solapur Surgical Society, I thank respected Dr. Dean sir, Sudhi Deshmukh sir, for giving us his valuable time and inaugurating today's CME and workshop and guiding us. I thank founder president of ISCP, Dr. Shanti Kumar Chute sir, Dr. Prashant Rahate sir, for president of ISCP, who has given permission to hold this fellowship program and CME at Solapur, Dr. Lakshmikant Ladukar, all the faculties from the various part of this country who has come to attend this program, all my colleagues, surgeons from the Solapur and periphery, all the delegates. I also thank Dr. Amjad Sayyaz and all the staff of the Noble Hospital for giving us a wonderful venue for this meeting. I thank all the pharma companies for the support for this program. Thank you very much.
Now I declare the inauguration program is completed. We will continue with the lectures. The refreshing teas are available outside, but the lectures will be continued like that only. Thank you very much.
The formal inauguration is over, but we have got very less time. So I feel we should continue with the lectures, because after this 2-3 important lectures, then we will be shifting over to the live workshop. Sir, Chute sir, are you going? Are you accompanying him? Okay. So priority goes to the lectures, to the CME and to the ISCP work. And now you are all excited to know what is about the Chute's procedure. Many of us are doing. Many of surgeons should be doing from Solapur Surgical Society also. So I will invite, many people are there to talk upon, but I will invite today Dr. Shanti Kumar Chute, one who has invented this procedure called as suture hemorrhoid or ectopexy. That's what we label is that Chute's procedure. And he will be talking in details of what is his new modality and how it has affected or how it has impressed the management of the hemorrhoids. So please, Dr. Shanti Kumar Chute, he is the founder president of ISCP. Many more credentials to his names are there because he is one of the innovative surgeons of India. And a list of innovations in surgical field, right from varicosities, lymphatic obstructions, that is lymphedema, to the rectal prolapse, and then a published and accepted procedure nowadays called as Chute's procedures, that is suture hemorrhoid or ectopexy. I won't go to the details of his achievements because the list is very long. But the thing is that this ISCP is the brainchild of Dr. Shanti Kumar Chute. And we are here, you can see the dynamism, the energy, and how he is still dedicated for the innovations. Whenever you meet him, you will gain something new. The lateral thinking in surgical aspects, what the treatment modality is, how we are treating the disease, and how he sees the problem in the different directions. How that investigations to be done, what is the role of investigation, and what is he is thinking, what the world is thinking in a way that just like you take the example of nowadays it is very much focused on, that is pelvic floor disorders. And pelvic floor disorder we are seeing in a different direction. What is the treatment? There is a star. But now what is his thinking? So his thinking is laterally, but it is based on anatomy and physiology. It is not a rational thinking. And out of his thinking, he goes on innovating the things, goes on innovating from a simple dilator to the many more proctoscopes, then fiber optics and what not. We have seen him, rather we are blessed from him from last 20 years. So each and every aspects of his innovations are known to us. And what is important of him is whatever he achieves, whatever he thinks, he tries to give something to the society. First he teaches all surgeons. Those who follow us are blessed. And out of that blessings, this suture hemorrhoidal rectopexy has been accepted throughout India. Those who were blaming, those who were claiming that this is nowhere, but now it is going to be a gold standard for hemorrhoids. Now, just Rati has explained that we have formed the one app that is totally dedicated for this tooth procedure. Those who are carrying out, those who are doing these procedures can register for that app. Now this app would be accepted, this will be definitely run by only ISCP. ISCP will be paying for that app. Nearly it is in thousands. ISCP will already accepted it, and that app will be within 1 month, that will be exposed to the all surgeons in society. So you will be taking the interest. If you are interested, you can definitely join the app. Very simple to join. So this much of a words about Dr. Chiute. I'll be asking him to talk upon his own procedure, that is Chiute procedure for hemorrhoids. Come on, sir.
लेटरल हे करायचं ना या बाजू. Good morning everyone, and I am thankful to Lakshmikant Pladikar, because this is a pet name. He has brought lot of Lakshmi to me. Not only just fame. Fame anybody can bring, but Lakshmi few people can bring. And whatever you have seen now, or what you are going to see it is nothing but sponsorship of ISCP. Let me tell you, whatever I do new, whatever I practice old, I devote to ISCP, nobody else. First ISCP and then to the public. Because whatever I do good things or improvement in the practice, this is not for us, but it is for the public. As Dr. Sudhir Shinde said, we should do at cheaper rate. If cost of the procedure comes low, then you may think about giving for cheaper rate. And this is the procedure where cost of the procedure is hardly 700 rupees. Than anything else you will know it. So let us see what is this procedure, and I think he has given many names for this procedure. First we started with transanal suture rectopexy, then when it went to America, it has become to mucopexy, and when now it is going to many friends, now they are calling as a transanal suture hemorrhoidopexy. So whatever name you give it, I don't mind. But do it, practice it, and serve to the people. Piles is nothing but a gift to the people from the erect position, and you know that because of this gift, all these procedures and everything has come. I'll not go in detail about the causes and other thing, I'll just run it and you go through that. This is again same percentage you know about, nearly 30% of the people, they suffer from the hemorrhoids. But 4% of the public, they require surgery. Mind well, in India, population is 140 crores. And 4% means what? And how much money you can make? Don't think about it. Only you think how much service we can give it. And I'll tell you practically, if you serve the people, people will serve you. Don't think it comes unilateral. Unless you serve the people, nobody will serve you. This is, Napoleon, I not go through. It is a very big lecture, I'll make it small. He had bleeding piles, prolapsed piles. That's why he lost the war. Now, we don't want to lose the war. This is again, same thing has been described, familial disease, chronic constipation, another thing. Etiological factors has been described by Dr. Jiten, so I will not go in detail. History of the, I think, this procedure also will not tell you because you will know it. Pathology of this condition in hemorrhoids, already you know it all, I will not go through. And anatomy, you know it already, Dr. Ganga Shankar has described very well. And I always love to listen Ganga Shankar when he talks. And that's why I will not go through details. And blood supply, you will know, hemorrhoid artery, usually we think it is, engorgement of the superior hemorrhoid plexus, but not like that, friends. It is joined together, not only superior hemorrhoid plexus, middle rectal and inferior rectal, all three are coming together at the corpora cavernosa recti. They will form sinusoids, they will form arteriovenous anastomosis, and that's why you have to take care of all these vessels. Physiologically, same thing. I can say only corpora cavernosa recti, which is situated about a centimeter above the dentate line, and this procedure is totally take care of this corpora cavernosa recti. Physiology is similar. I will not talk to you about more things, about the capillary and other things. I think Dr. Jiten has said. Vascular changes, you know it about what happens. Microvascular changes also has been spoke to you. I will go through ligamentum trees, even though Ganga Shankar has explained to you. Ligamentum trees has got real principle of the transanal suture ectopexy. You are seeing this ligamentum of the trees and park. They are going through the mucosa, submucosa or muscularis mucosa, vessels, through sinusoids. All they go and pucker or get attached to the longitudinal muscles. And in Chiute's procedure, we are doing same. So what we are doing is bringing abnormal situation to the normal. So this is what information you see changes after old age. And now you will, so I want to tell you, you take all procedures together and all grades of the hemorrhoids. I don't think any procedure is very satisfactory. Why I thought over it? Because of that. And even present day's procedure, something like a Morinaga and Longo, after that even MIPH or Longo's procedure, it is creating more and more problem. Maybe people have, less trained or staplers are not well, whatever you blame it, but they are not giving good results. So what are the core factors? Actually, what we think about how we should treat these piles, some core factors we have thought over, and these core factors, how to reduce mass of the piles, how to fix the prolapse which is going down. Then third factor comes, why recurrence should be avoided, and then pain. Mind well, I will give respect to the pain first, rather than any other factors. So let us see what happens. Piles, you know that these are nutritional, these things and other things. But they are, having not only portosystemic anastomosis here, but arteriovenous anastomosis, sinusoids, and all these factors will make corpora cavernosa. It is like a hemangioma of low pressure. Hemangioma of low pressure. And if you cut it, it may ooze or bleed or anything can happen. So these factors I told you already. These are the factors where we think about the. See, This is picture of the McGregor where I studied my anatomy that time for my MS. You see that if end vessels we have ligated at one place, definitely they will create collaterals. If you ligate at two places, these collaterals are not developed. So these collaterals can develop vascularity in humeroid region where you are operated, or they can have recurrence with that. Now same thing has been decided or thought over by the cardiac surgeons. If thrombus in coronary artery is short, they can develop collateral, no treatment is required. But in colorectal, if they develop collaterals, you will have recurrence. This is what you are seeing. This is the area where you will get lot of pain. And all our procedures except Longo, we are operating in this region, except Morinaga also. But we are going through, and Morinaga RAR is operated in this area. So if you operate above the dentate line, automatically there will be no pain. That's why we are operating in above dentate line. What is this procedure? Mind well, you will think or you will give very less and less and less importance to what I said here. Reduction of vascularity or piles mass is after giving anesthesia, give steep head low position, steep head low position. Many people thought I am joking. I am not joking. Give a turgid piles, steep head low position, wait for few minutes, you will see that turgidity reduces. Because 60% of the blood in these hemorrhoids is nothing but portosystemic anastomosis. Portal veins has got no walls, they don't stop anywhere. So blood vessel reduces, they will shrink. Then if it doesn't shrink, you massage the piles. This is also joke. People think क्या massage करना है, वो भी piles का. करो दोस्त करो. You will get fruits for that. If you do massage, pile reduction occurs to nearly 60 to 70% on table itself before you do anything. This is the crux of the surgery. If you don't these things and keep on doing Chiute's procedure, you will see some pile masses after procedure also. And then you feel, मैं इसको क्या करूँ अभी? Shall I remove it? Shall I do laser? Shall I inject sclero? If you do these two things, you will not require anything to be done. I'll tell you why. After massage and this pile masses reduces, then you will use the proctoscope. These are the instruments, minimum instruments what you can require. A regularized proctoscope is required. This proctoscope is self-illuminated. I'll show you different parts of that. Needle holder, kindly don't hold or use needle holder which is very short. I'll tell you. If you use very short needle holder about 6 inches, your hand will come in between. What you are doing, you don't know. So use about 15 to 20 centimeter needle holder. So you will not seeing how needle is going, how it is coming, where to hold. Otherwise, every time you have to see above your hand. So don't do that. Use longer needle holder. That is the best thing. This is the adapter for this fiber optic rod. Body is there. And adapter can be connected to any universal light cable except striker, I feel. Otherwise, all you can. This beak, you say importance of this beak. It is on the wall of the proctoscope, this beak fits there. So it will not come in your procedure. No thread will be caught in that. So this is what you are seeing. This is the full proctoscope assembly. And we can reduce this. And now you are seeing this proctoscope, what you are seeing here. You see, this is what view inside you will be seeing. This is, pilot for that, and this is proctoscope. And I'll not go in detail of this proctoscope, others you will start manufacturing. So these are the snaps where you can fit up this rod, fiber optic rod, which will not turn all the way. Now you see this, I was telling in the morning to my friend, this margin of the proctoscope is about 4.5 centimeters. Right from the anal verge to the dentate line this goes. Once you have reduced pile mass with the head low position and massage, now same pile mass you are going to push inside to its normal position. Normal position means above dentate line. If you are pushed up this above dentate line, that should be remaining there. And this proctoscope does that work. If you are using half cut on this proctoscope, this pile mass will be again swollen and it will come in between your way. See, this proctoscope has required 4 generations to go. 4 generations. We have done open proctoscope, then sliding proctoscope, then half cut proctoscope. Now we have to come to this conclusion because this will give compression of the piles in the anal region. So no blood vessels or swelling in the anal region will remain. All pile mass and relaxed mass will be going above this thing. So again, one more thing it can do, it will give way to suture you above the dentate line. If half circle and other thing is there, you have to find where and what you are using. Okay, so this must be understood why this proctoscope is required. This is again very basic, dear friends. Actually, I am afraid to tell in front of such well-known people. But needle you hold when you are suturing in the dip at the tip. If you hold at the tip, that tip will wobble, needle will wobble. And you are suturing, I told you, already in such a cavernous hemangioma type vessels, this will bleed. And you will see, yeah, kitna bleed hota hai, kya, isko kya karna. No. What you do, you hold your needle in the center of the needle holder and flat surface of the needle, even though it is a round body, then it will not move. Your needle and needle holder, they will act as a uniform or single body. And your hand should work, not, you should not pull or push. Your movement should be prone to supine to prone. If these movements you do and use this type of needle work, then this procedure will become a traumatic. So this is, first line, all now by this time, 2 centimeter above dentate line. Each of this has got its meaning. Meaning means not technical or this thing. Because if you put 2 centimeter above, you have left the mucosa where it sensitizes fluid, solid or gas. You have left that thing and you are going above. And in this region only, corpora cavernosa starts. In this region only, it joins all these vessels. So you are going to ligate that. And to avoid this collaterals, you are going 2 centimeters above that. So 2 lines are a must. Without that, you cannot have success of this procedure. So, and what sutures and this thing use? We are using, very commonly used is, I use 30 mm half circle needle on 20 Vicryl, and this beautifully works. And only thing you have to control yourself for going to the depth. And that also, this needle will take care of your depth also, how I will tell you. See, this is what depth you have to go from the mucosa to the muscle. How this needle will take care? Your needle holding will be nearly 1 centimeter in the needle holder. Then depth you will go 1 centimeter going up, down and coming up, and the 1 centimeter you require to hold needle again. So that will take care of the depth, how much you go by the needle. You need not to worry about kitna jayega, whether I will go to external sphincter. Don't worry about that. You use 30 mm needle, hold this thing 1 centimeter in the needle holder to have a fixed idea. So needle will take care, you need not to think. So this depth will be achieved by needle. So this is what you will achieve. And 2 centimeter above, all these sutures will be there right from this. And this you will definitely get what I will tell you in this figure. You will ligate in this all blood vessels, all venules, all arteriovenous anastomosis, portal anastomosis, and you will fix up the prolapse of the rectum, prolapse of the anal mucosa. So all these, whatever pars ligament and Treitz ligament they are doing, they are fixing mucosa to the rectal internal sphincter or longitudinal muscle. Same thing you are doing with this procedure. So nothing more you are achieving than bringing abnormal position, abnormal going piles to bringing up and fixing it there as a normal position. So that's why your procedure is more physiological, more achieving without causing any abnormal, symptoms. Because of that, you are causing this. This is, I don't know whether it works or not works. I'll show you this video. Yes, it probably works. You are seeing these are pulsatile piles. Can you see that? Appreciate. And this you are seeing, after giving head low, I am doing massage. And once you do massage, Actually, people, editor of the DCR did not believe that after massage, pile mass is reduced. See, I stopped it there and showed him, and same picture I sent it there. Now, see, lateral position, this portion from the ligament, long muscle, it will come into the proctoscope, and ultimately you need not to hold with anything. Now you are pulling this thread, creating tent. That means you don't require any forceps in that. Once you take a millimeter proximal to this tent, then you take a simple stitch and you will be getting all these things. Now you see minimum bleeding is there because varices is there. This procedure I am showing only because you should have confidence that you can do any procedure with this. Now tighten this knot with the needle holder. So mind well, whatever you are doing, you do only thread, needle holder, and make tent of every position. So your thread will be fixed and your mucosa will be fixed. You need not to use forceps anywhere. If you are thinking using forceps, you are thinking pushing your knot and other thing with the finger, that means you are not learned proper technique. So this is all what we are showing. It is nothing but proper technique. First of all, I will think, you should put sutures on the simple cloth and see how knot can be held with this and how double, locking can be done on needle holder itself, and take this thread, because otherwise this long thread will get jumbled and every time you have to cut through and get another thread. So this is all will happen if you have proper training of the suture. I know telling this to you is, I don't want to offend you, but still you must learn this thing. Now you put it this needle very well, come down, and sometimes bleeding can occur, and then you need not to worry about that. This is spurter. I told you this is a varices. So this spurter can occur, and still you put double locking, pull it thread, this also stop. If it doesn't stop, take another re-stitch there, and that will stop. Okay. Now this thread is little small, that's why I have to take a reef stitch in this. I cannot have loop and then tie. That's why now I'm, loop means what? Double lock it, go around twice to the both threads, and again go through one more lock and pull it. That is called reef. So then whether you have, any thread or not, there should be no what. This is second suture line. I'll not show you in detail. Few steps I will be showing. Now you will see, once you pull it, rectal mucosa and rectum is very lax. That will come in near your vision. Rather than first suture, this is easier. Can you see it now? It is coming more in your vision than first stitch, because that is fixed to the dentate line, this mucosa. Now you are seeing, this is 3 o'clock, mind well, 3 o'clock and 12 o'clock mucosa will not come higher because that is fixed. Your internal muscle is fixed there, that's why it will not be elevated. So mind well this thing. Second thing, now when we are doing these sutures, at the anterior portion, right from the 11 o'clock to 1 o'clock, keep judiciously this tent very hard, because then you will be saved from taking your suture through the vagina. Like MIPH also, you should take care of that. And once you take these sutures with this tent, you will never go into the vagina. So all these factors, if you keep in mind, and if you finish this thing, and I think probably you will have bloodless field after operation, because every stitch you are going to put something like a low pressure hemangioma, that can ooze any time. And once you complete this, you wipe it once, probably all bleeding will stop, and then you will be very happy when you are closing down this procedure, because otherwise open hemorrhoidectomy, many times, I did not sleep at home because something was oozing that time when I was doing hemorrhoidectomy. And evening again I used to go, अरे क्या bleed हुआ क्या? नहीं ना, ठीक है. So नहीं है तो ठीक है तो फिर problem, because you cannot do anything more than that. So all these factors you should keep in mind. All procedures, they have pros, cons, and their own factors. This has got his own factors, but very simple one, which you can tackle very well. You are seeing 2 lines of the suture above the dentate line, and very easily you are seeing and minimum oozing is there. Now you can go ahead for this, and now you are seeing these post-operative results on the table. I will not say all cases you will get same results, because those external piles which has got hardened, fibrotic, they will require a long time to have this. You have reduced blood supply from lower side and upper side. Some blood supply of the external piles has been also reduced. But reducing external piles, which is hard, will require longer time. Longer, for in my experience, maybe more than 1.5 months also. Ask them to give some steroid ointment, something like anovate, and put it. That will settle. You need not to cut down that thing. Many people suggest that this should be cut. So not necessary. Such type of piles also you can see. This was given case to me in Massicon. You will see that. And all these factors, if you see, probably we are justifying doing piles up to this. And now my individual case is nearly 3,000. And post-operative, one thing you should remember, it may bleed between 7 days to 14 days, because the sutures which are nearly so far tight, sometimes when rectum is lot of full, and sometimes while passing stool pulled and then constricted and passed stool, that time they may have cut through, and that will ooze. That you have to keep in mind. But that settles on its own. Maximum you have to give some conservative treatment, and there is no necrosis in between these two lines, because lateral blood supply is there. Those anastomosis we are not touching with them. You will understand. I think Dr. Ganga Shankar will remember all the time to you, because you have suggested that thing. Lateral blood supply is there. So all these cases, our recurrence of these piles are 0.7%. I don't call it as a cure, but it's near to cure. So I'll feel this also can be reduced if judicially 2 lines are put very well. Then earlier I used to think like you, little lazy guy, I'll do 1 line, but no, 1 line you will create again piles more. 1 line you will create more bleeding for that patient. So better don't do that. You should do 2 lines. And this is what DCR has been published their flyer for our human rights. This is people from the India, not less than 12 institutes from the teaching and universities. They have published their data and comparative studies with the Milligan Morgan, Stapler, on all those things. And you are seeing this. Now we are very happy people are starting doing it, and their problems, whatever there. Another problem used to come about the proctoscope, because this is not a very popular procedure. That's why many people never wanted to put money in this proctoscope. So and that too, person like me who want to change design every time, so nobody wanted. So I have started my own thing. Proctoscope can be available. Now these are all advantages. I did not to tell you. You all learn or you know it everything. And this is a comparative statement what we can give to the other procedures. And I will not go through this. Thank you very much, because the rest of things can be done. This lecture is very big, as haven't for 2 hours, so I don't want to give. Well, I don't think any queries are there. You will not embarrass me by asking this. So, okay, fine. What is it? For what? No, see, if something is bleeding and you are not stopping with that same line at same place, you can go 1 centimeter higher up and put it. See, basic principle, sometimes what happens, when hemorrhoids are turgid and edematous, even though they go to above dentate line, there also they can have cut through. That time, usually you should have, this type of, not 3 lines, 2 lines, sometimes another stitch up or somewhere. And one more factor I can tell you, when you have one pile coming down and prolapsing, and sometimes you see this pile is still remaining down, you can pull that piles, with stitch and tie it higher up. So that will settle matter. You need not to excise anything. And people who are thinking that whatever mass is remaining with the Chute procedure, we should treat with the laser. They are creating painless procedure to painful procedure. they have to give all these people who have done laser, next day ice candies only, not for eating. So this remembers, always, you should not do extra when not necessary.
So
Thank you very
one
much.
more small question, sir.
Yeah,
If the
no.
mucosa is very friable and you are facing the cut through of the suture during the suturing, so what is the how you deal with that, sir?
See, you're always, hemorrhoids has got friability in a particular region, 1 centimeter above the dentate line. Maximum edema goes up to another 1 centimeter. You are going above 2. So friability of the hemorrhoids doesn't matter for your procedure. But sometimes really edema is there above. There you can put one more suture at every place also. See, all varices we are doing with single line only. So there also we can do with single line, but maximum you can put one more suture there.
Okay, sir. Thank you.
There is no question, sir. There is a comment. I suggest all the proctologists who want to practice as a coloproctologist, learn this procedure nicely. This can change your fortune. It has changed mine. And it's a really wonderful procedure.
I don't agree with. Not only proctologists, all surgeons they should do. Because, see, I seen person with DM gastroenterology, laparoscopist and robotic surgeon. They are asking me how they should do my procedure. And they are asking my proctoscope, I want to do it. So don't think everybody is doing this procedure, because piles, fistula, fissure and prolapse rectum, they are bread and butter of every surgeon. So they have to do it. Thank you very much.
Yes, sir.
So one more question. Dr. Sachin Jamma. While rotating the proctoscope, many times I find some difficulty. So shall we withdraw it in between, and withdraw means a little withdrawal, or shall we use more jelly and something like that?
Dear friends, you are using old proctoscope. That's why this is happening. I have put nearly 8 lakhs rupees now to create this new one. You got it? So
Okay.
now you need not to pull or this thing, no obstruction will be there, because your tube is there in the anal canal where it is holding. So there you are easily you can. We now don't remove proctoscope outside and then put it.
Yeah, that is
So
not needed.
gradually we can retreat it, no problem.
Okay. Thank you, sir.
Dr. Shivuji has asked the question, is the third line is important? This had happened in one of the workshops of ISCP in Brahmapuri, when one of our faculty was operating, and that time it was his initial experience. He put these 2 lines and he came out, and then again see something is bulging out. He asked me what to do. I said, go above, push that whatever the prolapsing mucosa is there, and apply the third line. He applied that third line, patient is happy. So in earlier patients, when you are not comfortable, when you don't know that how the mucosa to be pushed inside, how the hemorrhage to be blanked upon, how they are to be pressed, how they are to be emptied, and once you empty the things, then the procedure becomes easy. So there was again one question or one comment was there, is it going to replace MIPH? Now this will be answered by a person coming from Mumbai all the time, and he is nothing but he is Dr. Kanekar. He has experienced both. He has done MIPH, he has done tooth procedure, and now he will be talking something comparatively how the things matters. So I call upon Dr. Kanekar to talk upon MIPH versus tooth procedure.
चालू करून दे मला, मग फक्त वर आणि खाली एवढंच पाहिजे मला, बाकी काही नको. आता मी फक्त हे बटन वर आणि खाली एवढंच ना, बाकी काही नाही करेल. हां झालं. Good morning everybody. Now we have learned about all the modalities that are available for surgical management of hemorrhoid, and now is a time for you to decide which modality I should adopt, because I think anybody who is practicing exclusive coloproctology, barring the ISCP people, anybody is practicing exclusive coloproctology in this audience? You are. There is only one person there. How many of you are postgraduates, meaning surgical students, or who have passed their MS DNB less than 5 years back? How many of you are there? And how many of you are appearing tomorrow for the exam? So basically this my talk is for those general surgeons who want to practice coloproctology, and those who are in a formative years of training into various modalities. Like I say, की पोरगी शोधणारा नवरदेव असे जे लोक आहेत तुमच्या ऑडिटोरियममध्ये, where they are going to 10 places eating kanda poha, batata poha, looking at the girl, and what do you think? What do you assess? That first thing is, if I marry this girl, will she put me in trouble? One is, will she put me in trouble? Secondly, is she suitable for the environment in which I am there? My family, my relatives, will she adjust with them? So here you have to see that you have to adopt a procedure that is suitable to you, not which is fancy, not which is well published, not which is done by many people. One which is suitable for your practice and is in a comfortably safe zone. Now another thing why I picked up this comparison is because I met a surgeon in Rajamundry, which is in Hyderabad, who was impressed by a fantastic MIPH demonstration in some conference, and he purchased the gun and he started doing it, and in very first case the gun got stuck inside, he couldn't get help in a proper time, and he lost his very first patient. So you should not land into that. Now, of the many procedures, why I have selected Chiute procedure versus MIPH? Because see, other modalities that were talked to you were laser, DJ Hall nobody talked, and I think DJ Hall is not very popular in India up till now, very few people who do this. These are all high investment modalities, and most of you, if you are a general surgeon and doing also coloproctology, then you may probably not go into it, and they have a very higher learning curve. Whereas MIPH, Chiute procedure, Milligan-Morgan and its modifications are no investment modalities. Milligan-Morgan I omitted because to my mind, in this era of painless hemorrhoid management, Milligan-Morgan, once a gold standard of hemorrhoid procedure, is no more relevant and is slowly going into oblivion. But as it is said that in government hospitals still, how many of you training in government hospital do Milligan-Morgan up till now? There will be large number, and it is very surprising, and it is the only reason is that the training of the budding surgical residents is not up to date. We are not with tune with time. and that is why most of them are still doing Milligan-Morgan. But it doesn't have much importance, and why we are losing hemorrhoid patients to quacks, the only reason is post-operative pain. Otherwise, nothing else. Now MIPH, we have seen why we have to compare it. Because these two procedures on the face value look very similar. That you do fixation of a mucosa to prevent prolapse, you do devascularization so that there is no bleeding. One procedure is done with instrument, one is done by hand suturing. Okay, both of them are done transrectally. Okay, and that is why this procedure apparently looks similar. Now we will see what is the difference between fixation and devascularization in these procedures. So in fixation, in MIPH, there is no true fixation, it is suspension. The suspension is done by removing a strip of mucosa and bringing cut lower end to join upper end with stapler. This stapler includes mucosa and submucosa, both of which are weak structures and are prone to disruption due to shearing force of passing mass, fecal mass. Whereas in Chiutte procedure, it's a true fixation is by 2 rows of interlocking stitches to rectal muscles. And then there is a strip which is formed, which is 2 centimeters multiplied by circumference of the rectum, and this entire strip is fixed to the rectum. So fixation is over a wide area and hence it is reliable. This is the picture sir has shown you and explained it to you, also why 2 lines. Now this is how exactly is. On my right is MIPH, which is suspension, that the sagging pant you pull by strap, pull it and hold it there, whereas in Chiutte procedure it is true fixation with a band of your belt which is fixed to your circumference of your organ, and that here it is from outside to inside to your stomach, here it is from outside to your wall outside. Now devascularization. In MIPH, due to single site interruption of feeding vessel, collaterals develop quickly as a natural response to obliteration of the feeding vessel. That is also explained to you. Hence, this devascularization is temporary till the time the collaterals open and revascularize the area. Whereas in Chiutte procedure, due to ligation of feeding vessel at 2 places, collaterals do not develop and devascularization is permanent. This picture has been shown to you by sir and explained, so I will not go into that detail. Now we will come to safety profile of these 2 procedures. Because hemorrhoid is a benign disease and the basic principle of any surgery is primum non nocere, do no harm, and it holds more and with much more force in a benign disease which will not kill you or not harm you very much. So safety profile is a prime important anchor in deciding which procedure you will select. Now safety profile, when you see safety profile, we'll talk about MIPH, and I think Dr. Rahate has already dealt with this, why there is high sepsis rate in MIPH. High chances of sepsis is due to breakdown of suture line by shearing force of passing fecal bolus. raw area heals by secondary intention, that is either granulation and later on fibrosis. Granulation will cause delayed bleeding, chronic anal pain, tenesmus, and fibrosis will cause stricture. Whereas in Chiute's procedure, there is minimal chance of sepsis because there is no raw area. And because there is no raw area, there are no consequences of raw area like fibrosis, granulation, and its other consequences. Now, safety profile. If you go to the literature and see about safety profile, there is a vast margin of opinion as far as MIPH is concerned. And there are people who claim that MIPH is extremely reliable, safe modality. And that was happening right up to say 2018-19, when the complications of MIPH slowly started coming off because of certain events that I will show you later on. And now they have put a addition to that, that it is safe in expert hands. But that is also not true. I will prove you later. There are another people who are totally opposed to MIPH. No, this is a useless procedure. And they say the nature and rate of complication is such that surgical stapler should not be used for benign disease as hemorrhoid. So there is a vast difference of opinion, group of opinion in MIPH. Whereas in Chiute procedure, since I think 2012, that papers are published, and I think list was shown to you by Sir just now, that none of the paper has said that there was any major or life-threatening complications. So it is undisputedly safe and reliable method with no known drastic post-op complications reported as yet since 2012. But today only, I learnt it today only, I didn't know about it, from Dr. Rahate, who has done many MIPH, many Chiute procedures, that he got a patient from operated somewhere outside, that this strip of mucosa which was left between two rows of this thing got necrosed and bled. And then I asked him why it has happened. I asked it to sir also. And he realized there was two reasons. The two suture lines were taken very close, less than 1 centimeter, and they were taken too deep. And that is why the sideways perfusion which normally occurs did not occur. And that is why there was necrosis. And the treatment that he did was he excised that gangrenous area, but before that he took one purse string suture above this line which closed the bleeding so that it was easy for him to excise that and suture in place. This is a new one, for the first time I have heard, and that's about the complications of Chiute procedure. Now, if the MIPH is safe and it can be done by everybody, no problem, you need not have to discuss anything about it. But if there are people who are saying that it is not correct, it is not safe, then we have to look at it and find out what are they saying and how true are they. So for that, I have picked up one paper which is very important because it is published. This is the paper which is published by, read below, Mario Pescatori. And who is Dr. Mario Pescatori? He is the inventor of transanal circular cutting stapler, which is used for MIPH and STAR procedures. And that is what, this is the paper written in 2008. These are his observations. Relatively high rate of post-op bleeding implies that vascular supply to hemorrhoids is not interrupted by PPH as hypothesized. This is the hypothesis that if you cut the superior rectal arteries, the vascularity will increase and hemorrhoidal mass will shrink and get better. He has also written that PPH is contraindicated in 4th degree hemorrhoid. This simply explains you that it is not fixation, it is suspension, and it can get loosened, and larger the mass of the hemorrhoid, earlier it will loosen and prolapse again. And what does he say in conclusion? In conclusion, complications of PPH are not infrequent. It is polite way of saying that they are very frequent. And the important thing is, and may be difficult to manage, and Dr. Rahate has shown you how difficult it could be to manage such complications. After doing that, what does he say? He says, hopefully, the future trend will be the return to an old validated policy by increasing use of less invasive outpatient procedures. Now, when we saw the comparison between MIPH and Chiute procedure, you would believe that Chiute procedure is far, far less invasive than MIPH. Although it is still not outpatient procedure, and you should not do it as an outpatient procedure, because the patients are so happy that they are walking propaganda of your expertise. And then he comes to a conclusion that over 90% complications occur due to failure or malfunction of stapler, whereas only in less than 1% cases operating surgeon is at fault. So now you have to decide, are you going to suffer for somebody else's mistakes, or are you going to be responsible for your mistakes? Because in Chiute procedure, if anything goes wrong, it will be only because of your wrong surgical technique, nothing else, never ever because of instruments. And that is why the claim that MIPH is safe in experienced hands is false. That is my conclusion. And if you have attended adequate coloproctology conferences where you have seen more than 5 cases of MIPH procedures being done, I am very certain that you would see at least one complication. Because in Rahate's paper also, he has said that at least 36.7% of patients have one or the other minor or major complications. These are complications peculiar to MIPH, which is stated in that paper and multiple other papers. And they are all dreaded, horrifying complications. So the simple question is, why is MIPH still used? If it is such a useless procedure, then why it should be used? So many people are still using it. Why? So if you want to get the answer to this question, please take a photograph of this. Everyone in the audience, take photograph of this. Go to this paper on your web and read it very carefully. And you will find multiple questions and answers of our pathetic medical practices. Done, everybody? Now, complications of Chiute procedure, I showed Dr. Chiute has shown 3000 cases. Complications of Chiute procedure are infrequent, are easily manageable. No life-threatening complications are reported as yet since publication of this procedure. Worst complication is recurrence in 0.7%. And somebody in the audience, as sir was giving this lecture, asked me why then the recurrence in these 0.7% cases. So there is only one answer, is improperly executed procedure. Because to my mind, I consider Chiute procedure as a single ideal stitch repeated over and over again till you complete 2 rows of sutures. This is the definition of Chiute procedure to me. And each and every stitch can be ideal because the procedure is done under vision. It is easily reversible. If you put a stitch too superficial, you can withdraw the needle, take a deeper stitch. If you have gone too deep, you can take it up, take it at a proper level and take an ideal stitch every time this is possible. And if you do this, give your time and do this procedure, there should be no recurrence. So the only thing is that if there is a fault, 100% surgeon is responsible for it. One. And secondly, sometimes the ODS represents as a hemorrhoid. And if the history is not taken properly of digital evacuation and things like that, proper digital examination is not done, then such patients continue to strain even after surgery, and then they will break anything. Okay, even if the fixation is strong, but still they have the will and power to break it, so it will recur. Sir has shown you his complication. This is my humble complication of 10 years. Here you will see that there are 4 recurrences out of this. 2 were for bleeding, 2 were for prolapse. All of them occurred after a bout of acute gastroenteritis. And when gastroenteritis was treated, then 2 patients did not come back again, but 2 came again, and we had to do, the only thing that you have to do is repeat the procedure. Okay, I am finishing. So what is a take-home message? The painful procedure for hemorrhoid treatment, also called MIPH, achieved a huge success by relieving immediate post-op pain, but created a multiple of complications including death. Dr. Chiute's transanal suture rectopexy retained the virtue of painless procedure for files, but made it completely safe with reliable fixation, reliable devascularization, thus reducing recurrence rate drastically. And as Dr. Deshmukh, who said that a country like us, where the large number of poor population is there, we need to give them affordable medical treatment. So it is cost effective, a major requirement of a country like India with large population. This is a procedure which I am very certain will take place as a gold standard of hemorrhoid surgery in very near future, and we at ISCP are committed to see that this procedure gets an international recognition. Thank you very much.
Thank you, Kanikar sir. Before closing this session, the first session, and going in for the live operative session, the last lecture by Dr. Ladukar. For, अच्छा. Transanal suture sacrorectopexy. Dr. Ladukar sir will be demonstrating.
नहीं आला जो. In literature, there are multiple procedures for rectal prolapse. Out of that, there are two important areas where the rectal prolapse is taken care of. Is one procedure is abdominal procedure and others are pelvic procedures. Pelvic procedures, there are 2-3 important procedures like Dillerom's procedures, Ultimus procedure, and in abdomen we know multiple. Open abdominal rectopexy, then anterior rectopexy, posterior rectopexy, then Epstein Barr, so that then laparoscopy came in, where the mesh is reposed anteriorly, posteriorly. So in all, if you go to the literature, you will find that there are 180 procedures dedicated for rectal prolapse. It itself suggests that there is no confirmed or gold standard procedure for rectal prolapse. It is very true. The thing is, the differences are there because of the different personalities, like in what age group it is, because you know that the rectal prolapse can be seen in pediatric age group also. And 10 years of patients, 20 years of patients, some adult patients are there also. And 20s and 30s also we have to operate, and it is a common disorder for the old aged persons. So the occurrence of the disease is also varied. So the treatment is also varied, and this is a new procedure called as transanal sacrorectopexy for prolapse rectum. You can just estimate that this is something new child. This is again a brainchild of Dr. Chute sir. Nobody can think in that way that this rectum should be fixed posteriorly through the transanal thing, that is through the rectum. Except the rectum has to be fixed to the sacrum, presacral fascia, and this was the new idea where we are all are disturbed to do in that particular area, because we know that below the presacral fascia there is plexus, and that bleeds very heavily. That is taken care of in, we are doing it with a very much of caution, and still this procedure he has tried to do, and now we are doing it regularly. And one of the cases there in workshop also today we will be showing you. So this is the procedure where indications are very few, that you know it is endosusception, total or complete rectal prolapse, and adult to old age up to ASA grade 3. Investigations are regular hemogram and cardiopulmonary evaluation. Now, what are the things? Evaluation at the time of defecation is important. At the time of defecation, you must evaluate what the type of prolapse it is. It is a complete prolapse, or it is a partial prolapse, or it is really a rectal prolapse, or it is a mucosal prolapse of the hemorrhoid. So that evaluation is done by proctoscopy. If available, you can do sigmoidoscopy and epigraphy also. But investigations are only these two. Hold up. Can somebody help me out? Arey, just hold up. Evaluation and histogram, and that's. Now just coming to the procedure, how it is. It is done with a special self-illuminating proctoscope, it requires a long needle holder. Previously sir used to use a laparoscopic needle holder, but I don't use it. I only use two needle holders, very long needle holders. And what is important is suture material, which is PDS number 1 on 40 mm round body needle. That is the requirement, that is very important. That should not be, the size of the needle should not be more or should not be less than this, because the operating field is very adequate, very less, and that in that area you have to move your needle. That is 40 mm round body needle. Proctoscope, it requires a proctoscope which is 20 centimeter long, diameter is 4 centimeter, window of 1/8 circumference for operation, sliding over this there, self-illuminated, and window for operation, and slim long needle holder of 25 centimeter. These are the requisites which are needed for this surgery. The bowel preparation is a must. Before bowel preparation, you should not do these procedures. The bowel to be prepared very nicely once or twice. Preoperative antibiotics are given, and it is most of the time it is done under spinal or saddle anesthesia. The preferred position is lithotomy, steep head low position again. That is very important. Steep head low position. Not only lithotomy, steep head low position, so that all of the things, all of the intestine should fall upon. It should go just it occupy the abdomen, not in the pelvic cavity. Prolapse is washed and pushed inside. PDS number 1 is used. Needle is passed through rectal mucosa. I will show it in the video. Through rectal mucosa to presacral fascia, and then turned up and knotted to fix rectum to presacral fascia. From S3 to sacrococcygeal junction, 4 to 6 sutures are applied. Then let all the next phase of this surgery is injection sodium tetradecyl 4 ml, that is a sclerosant, which is mixed with 6 ml of air, and that the foam is created, and then that is injected. Patient is asked to strain, it comes out, total prolapse. Then prolapse is washed with saline and even metrogel also, given a wash. Then it is pushed inside. That's pushed inside. When you have to reduce it from outward to inside, your finger should go in the cavity. Now this is the proctoscope. It is set in. Steep head low is given, and the proctoscope is inserted inside. Now 6 stitches up to there is a put to fix there. Now there is a first suture. The needle is fixed, passed from the mucosa to the through the muscle layer, and it touches the presacral fascia, and it is when you pull it, you feel that whether it has fixed to the presacral fascia, and you have to knot it. Now he has knotted it with a needle suture pusher or not pusher, but we can use that both the needle holders, and you can knot it in such a way. You have to, it seems very easy that how the suture is going or the needle is going, how it comes out, but it's very difficult. While putting the suture, putting the needle inside, and the tips comes in, you have to catch hold of the tip, because once the needle hobbles inside, it will be bleeding inside. Your attempt should be only once, putting the needle and pricking and taking up the needle, the tip of the needle. Now how the sclerosant is foam sclerosant to be done with pushing the air and mixing it with the tetradecyl sulfate. And now this is in retrorectal position. A spinal needle can also help. We'll be showing you over here is in the retrorectal position. Now the needle should not pierce inside, it should not go above. It should be below the rectum, and it should pass from outside. You see, this is how we are fixed up. The sclerosant will do? It will bring about the inflammation, then followed by fibrosis, and whole of the posterior rectal wall will be adhered to the retrorectal place. Here it is shown that through the ultrasonographic image, how when the sclerosant is injected, how it pushes inside and how the rectal wall is pulled up. That needle is seen over there, and when it is pushed, see how it is pushed inside, and now the rectum is rolled up, and the post-operative position is like this. You see, postoperatively how it is, that is the pre-sacral fascia, and through the up to the pre-sacral fascia your needle goes, and you have to attach it at 5 to 6 junctures. Now take hold of this. This is showing you the sacrum where S1, S2, S3, S4 and S5 is given. Now sacral premonitory is there. When you are operating in a laparoscopic field, when you are doing laparoscopy, you talk all about the sacral premonitory which is in front of you. But that is an intraperitoneal space where you are operating. Now your adherence, because we know that anatomically the rectum starts at S2, S3 level. So you have to fix that level at always be not more than S2. It should be always, you should come from midway between the S2 to S3, but the better positioning is in S3, so that you are not in a intra-abdominal plane. Whatever is being done over there, even if there is some inflammation occurs, it will not be intraperitoneal, so that intraperitoneal complications like abscess would be avoided. So this is a must. You should know it. Otherwise, pulling the thing and going above and trying to do it in a in intraperitoneal way, that will create the problem. Because the problem of this process are only two. One is bleeding and second is infection, because we are going to the transanal space. Now preoperative procedure is being shown, and what the post-operative on-table result is there. Patient is symptomatically absolutely alright. It becomes after 1.5 months to 2 months, because after that there is some certain type of incontinence. Along with this procedure, I do suture transanal rectopexy also, so that whole of the anal mucosa is sutured to the deeper structures, so that nothing will prolapse out. When I will be doing this procedure today, I will be trying to show it. And what is the post-operative follow-up? What is important is head low position to be given, liquids for 48 hours, not for 24, 48 hours, and soft diet on 4th day. Try to keep the patient NBM for at least 1 or 2 days. Mild purgatives are given. Since January 2009 to 2020, now more cases are added. This is the old presentation. Male 30 cases, female 12 cases. Age was, average age was 42. Average in females was 56. In females, it's more occurrences there, but age is varied. The results of 1 to 9 years of follow-up, there was one recurrence in 42 cases. Incontinence can be there. If a very long durational prolapse is there, definitely if there is an injury to the external sphincter, or sometimes if the puborectalis is weakened, so that incontinence will be there. But after this procedure, incontinence improves. Grade 2 and 3 in 15 cases, 35.71, improved in 11 to grade 1 in 6 months. Constipation is occurrence in early, to start within 15 to 20 days. This was in 23 cases, changed to 5.1. Feeling of incomplete evacuation, called as tenesmus, is reduced after this procedure. Use of enema and painful defecation is also reduced, because this procedure, sometimes these patients are very much acquainted to do that. They feel that there is always a painful defecation, and there is no fresh incontinence or constipation. All the time the question comes that why there is no bleeding. So for that, he evaluated the 37 abstracts and 13 papers on suture rectopexy for rectal prolapse. In 1164 procedures, the pre-sacral plexus bleed is 0.3 to only 3%. Now in this procedure, while you will be doing it, you should know that your needle should not go dip, you should not pull it out. Putting and pulling out at the same place should not be there. Otherwise it will, because the procedure is blind, absolutely blind, you don't know what is there inside. So that pushing the mucosa, pushing the rectal prolapse inside, see that good head low is given, and contraindication in this procedure is very important is patient should not have a history of previous pelvic surgery, one, and the adequate pelvis should be there. So in that the bleeding was very less. No bleeding by suture itself. But a single suture line which you have to knot from above doesn't bleed. So conclusion is it is a non-invasive method. Very rightly, once you are acquainted with or with the result oriented it is, when you are very much trained and confident it's a very good procedure. It avoids so many of the queries and complications of the other procedures. no incision, no pain, safe. Corrects external prolapse, internal prolapse. Obstructive defecation syndrome is also a bit lessened. No costed staples. And very important is when you are doing the laparoscopic procedure or open procedures like for rectal prolapse, there is high chances of injury to the nerves, which can lead to incompetencies or impotencies in the young population, and it's very dreadful complications. And after all that, it is a longitudinal prospective studies. Still, we have to come up with a very datas. Dr. Rati is doing, myself is doing, other centers are also doing it. But till that date, we have found that we are operating in conferences also. The results are very nice. This is, and all the time he says or said that nothing is permanent in life except the change. In the last few years, if you are not changed, discarded a major opinion, if you are not discarded any major opinion or acquired a new, it means that check your pulse, you might be dead. So this is the version out of that, because all the time innovation is there. And thank you for your patient hearing. If you have got any queries, you can ask me.
Hello, sir. This is Dr. Chaudhary here. Sir, this operation I believe can be done only for unicompartment prolapse. Can it be done for 3 compartment prolapse?
Yes, it can be done for 3 compartment
if
prolapse.
If there is an associated uterine prolapse also there?
Oh, no. Uterine prolapse is a different entity. You can operate. One case was there with me, that was a lady having a uterine prolapse and rectal prolapse. What I did, I tell you. First time, because she was very old, I did the theory stitch first. I did with rectal prolapse first. Then I did, at the same sitting, I did this procedure. I followed this procedure and I did the rectal prolapse. After, for the uterine prolapse, I did it hysterectomy. After 1.5 months, I removed the theory stitch and I did the same procedure. So at the same time, you cannot do it because prolapse, uterus and prolapse, these things are very difficult. Uterine prolapse, you can easily operate. Remove that and it can be done afterwards.
And can the patient use the Indian toilet and for after how many days?
Within after 7 days, patient go for Indian toilet. There is no problem. Only 3-4 days are important postoperatively, because we are in danger. We know that. Is there any infection? Is there any bleeding? Patient, does he have any, he or she has got a pyrexia? You are careful, you should have to be careful and keep the patient under observation, keep for 2 days NBM for your safety. If the patient is not having any of the complications, like there is no pyrexia, there is no pain, there is no tenderness inside, you feel that there will be nothing inside then. For 2-3 days are very important days. And if you have taken the suture for S3 level, I don't feel that the intraoperative or intraperitoneal complications will be there. So after postoperatively, 2-3 days are very important, even if you have done the good surgery. So keep the patient NBM, keep him on that's antibiotics and anti-inflammatory agents, and after 7 days, patient is okay. We have operated that in one of the conferences, Akola. Patient is very nice. That was a young guy of 27 years. And we operated it and it is very nice. Our experiences are very nice, but it is still a challenging procedure because you have to take over, or you should have that control to ligate the things. Once you master the art of Chiu-Teth procedure on hemorrhoids, you can definitely step up for this procedure, because the length of the proctoscope is too high. You have to take the suture at too high a level. But once you get those skills, it is a very good procedure. It stands over, or it is having no complications than the other abdominal procedures. S3 level, it is because it is very easy in that proctoscope. Proctoscope length is 20. That goes to the tip of the, sometimes it sacral pulmonary को भी touch करता, वहाँ से आप नीचे आइए, or just go 3 inches from the anal verge. S3 level you can definitely, so that the length of the proctoscope itself will tell you, you should not go beyond, you should not push it inside. Even if some stitches you left at upper level, it is okay. But you should not go in the intraperitoneal region. That is the safety, first major safety, if at all something happens.
See, going inside, sacrum is curved organ. and rectum is associated with that. Once you are pushing straight proctoscope, it will not go beyond that curve. Where it touches, that level is S3, S2 level. Because see, what he was suggesting that we can go up to sacrum is not possible. There are certain cases where sacrum is flat. You got it? In this flat, it may go, but you should not go there. About 10 centimeter or 12 centimeter of the proctoscope, you can push it inside. Don't go beyond that. If you go beyond that, you are in the peritoneal cavity, even for putting stitches. So there anything can happen. So judiciously you should see, you should not go more than 12 centimeter inside, even though proctoscope is of 20 centimeter. Okay? Yeah, carry on.
Only one complication which was there, which I sorted about. The danger is all the time patient should be given steep head low position and proper bowel wash. Before putting the proctoscope inside, you put your fingers inside and you feel that if there is any enterocele or if there is any intestine inside. Because if that complication occurs, then it will be a graded complication, because once you go through the intestinal loop or if you fix it to the sacrum, then patient will lie in septicemia. So be very careful. Don't operate any of the previously operated case for pelvic surgery. You don't know. Or if you want to do it, you put a laparoscope inside, you see the pelvic cavity sometimes. Or do MRI. Best is to do MRI. If you are well satisfied, we know that if anything there are adhesions because of endometriosis or any adhesions, if you suspect, definitely you should do that. If the patient is having plain pelvic pain, subject the patient for MRI, and then you know that pelvic cavity is empty or not. It doesn't require any of the resection rectum. You know so many of the procedures that there are. Sometimes we do resections of the colon, sigmoid colon, then resection, anastomosis, and then fixation with it. So many of the things are avoided with this little procedure. Thank you very much. Anybody having any problem? Any questions? No.
In one of my patients, he has had the rectal intussusception. So I don't know, I was right or wrong. I have done this same procedure for the posterior fixation, and I did star for the anterior this thing.
Now
so I did basically this thing. One side you use the the stapler, and for the lower
some people are now combining the two procedures, stars for anteriorly, but logically what sir says that it is not important. I have not come across, there is one patient is with me for rectocele, I will not be doing it.
See, naturally, rectum is not fixed anteriorly anywhere. Naturally, rectum. It is covering peritoneum. Lower down, there is no peritoneum. Lower 1/3. Upper, middle 1/3, peritoneum in the side. And upper 1/3, it is covered. So, where is fixed here? Only peritoneum is not, any fixative part there. Rectum is fixed posteriorly, that's why it doesn't come anteriorly out. So once you fix posteriorly, I can tell you one more procedure or where total enterocele was there through the prolapse rectum, which we handled. And in this case, when we tried to open this case and thought that this is through the pouch of Douglas, this rectum is coming into the prolapse of the rectum. And after dissection in the vaginal wall, we thought this is the pouch of Douglas. What we got? Good ballooning. We opened it, it was rectum. We sutured it. Then, mind well, we cannot do any other procedure there. We did not do any procedure. We just fixed by sideway that it should not have tension on that. But after fixation of the posterior, even this enterocele has not come back again. That means your control of the anterior part is done by the posterior part. If that comes down, this will also come down. Naturally, rectum is not fixed anteriorly anywhere. You know that lateral ligaments of the rectum, they are also nothing but just peritoneal thickening. So they are not fixed, as it is fixed in the posteriorly. It is fixed to the posteriorly by very thick fascia. That is after presacral fascia. Not presacral fascia is not fixed, but to the presacral fascia, a strong collagen material is fixed with this. So you need not to worry about the anterior work. If you think that you are not sure about what you have done, then you can do anything. You can tackle every point of the rectum and think about whatever you want to do it.
Friends, now we are shifting to a last lecture of this series, because after that there will be the live workshop. Before that there is a very good interesting lecture now. This is on pilonidal disease, and this will be presented to you by a professor of surgery, Dr. Mronal Ketkar madam. She has come down from Pune itself. She is a professor in Bharati Vidyapit. She was HOD of surgery. Now she is having HOD for medical education. And now you will experience how the teacher should be. Get prepared for answering some questions also. These questions will be something tricky questions, and this will encourage the interest of the participants, those who are hearing her. I call upon Dr. Mronal Ketkar ma'am to present her lecture on the pilonidal disease.
Thank you for that kind words or introduction, I must say. So I think with all that kind words, I must start with the first question, which is very much relevant. Do you want this lecture now, or you want to go for lunch? So that's my first question. Yes, sir? First lecture. Okay, fine. So I would like to be, sir, nobody else is saying that. How many of you would want it now so that you can go for all demo surgeries post lunch? Do you want that differentiation? So nobody else is raising hand. Okay, fine. Okay, anyway, I will try to be as brief as possible, and as sir has said, yes, that teacher is there in me, because I have been a teacher in the medical college since last 28 years now. Yeah. So this is actually an overview of pilonidal sinus disease. How many of you are treating pilonidal sinus disease? All of you? Okay. So can you tell me what kind of surgical procedure that you are following? How many of you are doing just primary excision and allowing it to heal by secondary intention? Anybody? Yes, there are 2 or 3, yes. And how many of you are doing excision and suturing in the center? Midline closure, okay, that. And how many of you are following flap surgeries? Many. Okay, fine. So that itself makes my talk little redundant, because you already know. How many of you are doing minimally invasive now? Yes. So we know Ganga Shikhar. Yes. Yes, minimally invasive. So I would like to know what exactly you're doing and which cases you would want to do it. Fine. So I think a brief introduction, pilonidal sinus disease. Yes, when I was an MBBS student, this was a very small topic and mostly a topic for say omitting, because not so important for undergraduate. But as I became surgeon, during my MS practice, this was the case which was most painful, because the surgical procedure that was followed then was excision and leave it to heal by secondary intention. So it was the JR who was doing dressings for almost 1.5 months. So anyway, so historical background. Herbert Mayo was the first person to identify pilonidal sinus as a disease in 1833, but it was Richard Hodges which gave it its name, that is pilonidal. Pilus mean the hair, nidus is a nest. So a nest of hair, that is what we see coming out whenever you explore any of these small openings which are there on the back or in the natal cleft of males or females. Why that image of horse is there? Because it became sort of a big medical problem post World War. Almost 55, majority, more than 40% of the soldiers were admitted for more than 55 days. That is the statistical data. Because the surgical procedure that was followed then was again healing by secondary intention. So it became like a most big medical problem because of the morbidity of this procedure and a prolonged healing time. Then the second issue, contentious issue, was whether it's congenital in origin or it is acquired in origin. And by now we know that this is acquired origin piloneal sinus. And two names which come up when we talk about acquired origin of piloneal sinus disease is Bascom's and Karidakis. Bascom's and Karidakis both talk about the hair follicles. Karidakis says that it is the obstructed edge of the hair follicle or blocked opening of the hair follicle, which distends, gives rise to an acute piloneal abscess, which then leaves a vulnerable skin in the midline. Okay, so he talks about three factors which are most important in the formation of piloneal sinus. So there are three culprits. One, hair, it has to be there. Secondly, the force. So what exactly is the force? Is the action between the two buttocks every time when we are sitting or getting up. So it's kind of a suction effect. So you have loose hair in the natal cleft. Okay, you have a vulnerable skin in the midline. And what is the force is this? So more deep the cleft, so more obese a person, okay, more vulnerable the skin and more rough the hair type. There are more chances that the person will develop piloneal sinus disease. So there are nothing but the risk factors for piloneal sinus. Bascom's also explained this, but he explained how the hair entry takes place. Okay, so the next thing that we came to know that, you know that all of us, we have seen primary opening of the piloneal sinus and multiple secondary openings. Okay, so the basic thing that is, the primary opening is the route of entry of the hair, and the secondary opening is, because it's a foreign body going in and irritating, the secondary opening is nothing but the hair coming out through the other end. And it is said that the secondary openings are usually cephalad, that is at above than the primary openings. So this is just the risk, note down of the risk factors, usually much more common in males as compared to females, 2 to 3 times more common, but it's not rare in females. Okay, I am seeing more and more female patients now. Many of them are our own medical students also. Okay, and post COVID also we have seen an increase because of the people have been sitting at home for long hours, working from home, work from home. So the other category of people that we are facing now, or the patients, are the IT professionals. Okay, so it's not so, we believed, when I became a surgeon, we believed that it was in the low socio-economic, G bottom, soldiers, so various different kind of strata of people, but that doesn't hold true now. We are seeing it from the elite people also. My own son had a piloneal abscess. Okay, so it's that particular fixation that we had about, okay, this is the strata where piloneal sinus disease is common. That is not so now. So deep natal cleft, sedentary occupation, I think all that I have already explained. Positive family history, I haven't got many references for these. But yeah, obesity, yes, definitely, especially in females who are coming with piloneal sinus, we see that they have the central obesity mainly. Then local irritation of trauma, this goes in favor of the Karidakis theory. And another very interesting paper that I came across when I was searching for this is hereditary and the number of baths taken by the younger individuals. Less the number of baths, more dirty they are, more chances of piloneal. Okay, so this is something that I want to introduce, current concept. This makes our choice of surgical procedure or choice of treatment easier. So we need to get used to this terminologies. Yeah. So this is the navicular area. Okay. So actually you can, this is the way you will mark the navicular area and anal triangle. So if at all you are taking any flap, you need to avoid this anal triangle or going near the sphincter complex of the anus. So if at all you are taking any incisions here, it has to be twisted or it has to go away from the central part of the perianal area. So this is the navicular area, anal triangle. This is the current terminology that is used. And this, to take it further, this is the classification that has been proposed for piloneal sinus disease. So type 1, so just correlate it here, asymptomatic pits, Usually they are limited to midline, but as the disease become chronic, you will get a picture like this. So you have extensive disease from type 1 to type 5. So how to mark the navicular area? This is a simple guide to that. So patient is standing, you just put the buttocks together and mark it. Pull the buttock apart. Okay, so this is a simple way of drawing the navicular area. Now you see there is one pit which is outside the central navicular area. So a guide, a simple, easier guide depending upon which type of teasel this is. You can use one of these methods, whichever you are familiar with or you are confident with. So this is a simple guide according to the teasels classification. So all of us know that the spectrum of the pilonidal sinus disease varies from a pilonidal abscess. So what will you do for pilonidal abscess? Yes? IND, yeah, but what precaution would you like to take for incision and drainage of this? Yeah, so yeah, we have to go laterally. How lateral is that? So at least 1.5 centimeter away, depending upon, so there might be a highest point maybe in the center, but go little away from the midline because you want to avoid a vulnerable. So if you give a incision in the midline, that means when it heals, you are leaving a vulnerable skin in the midline, that is the scar tissue. So that is a principle for doing an IND. Okay, so let me go back to, yeah. So the spectrum is from pilonidal abscess to multiple recurrence even after doing a surgery. So what is the principle of pilonidal sinus disease? It should be simple to perform, limited inpatient stay, low recurrence rates, minimal post-operative pain, limited wound care, early return to activity, and it has to be cost effective. So what are the various types of treatments available? I have already asked these questions to you. So we know that all of you are doing any one of these. So as I said, incision and drainage. So can we add something to this which will make the recurrence rate less? So the evidence suggests that 60% of patients who are treated in acute setting do not require any further surgical intervention. I think hopefully my son falls into that because I have not had a recurrence. That I have done his IND at least 12 years ago and no recurrence till now. So he is in that 60%. Then 40 to 60% will go on to develop PNS, that is a chronic pilonidal sinus disease. But the recurrence rates can be reduced to 15%, and this is very interesting, and this is what now people are following. Even in my institute we are doing this. This can be reduced to 15% if a second procedure to excise pit is added within or 48 hours after the IND has been done, because it becomes very difficult to spot those pits when the patient has a very painful inflamed swelling in that region. So what exactly is pit excision? So this was first described and it has also been part of Bascon's presentation online if you go to see his original presentation. So it was described in 1960s. If you go and read one of the, I can share the references with this also. So this is a very, very simple procedure. It is, I would say an office procedure. So IND is already done. Patient comes for a second or third follow-up to you for dressings. Okay, so what you do is you require this simple the punch biopsy forceps or instrument that is used by dermatologist, and they are available in various sizes from 2 millimeter to 5 to 7 millimeter. So you have to procure one of these and you have to do a pit excision. So there is one small video. So this is actually, pit excision can be combined with any definitive surgeries also. It need not be always after incision and drainage of abscess. It can be combined with any of the other minimally invasive procedures. So you can see, so we had planned a laser surgery, that is minimally invasive procedure for this. So before doing that, we are doing a pit excision. So this is very, very simple thing. Patient is in the prone position under required anesthesia. There are multiple pits in the midline. Yeah. So it actually comes out like a cylinder. You go right up to the presacral fascia, excise as many pits as possible. See, so there were at least 3 or 4 pits. So once we removed this, then we proceeded with the laser procedure. I will be showing you this clip again. So that was incision and drainage, and you can reduce the incidence of recurrence from 60% to 15% by doing adding a simple procedure of pit excision. Then comes excision and healing by secondary intention. Recurrence rate is very high. Marsupialization, you add marsupialization, it has a better healing chances. And what we have now is VAC, which helps in ambulatory treatment for these patients. Excision and primary closure, we all know that has a very, very high recurrence rate because you are leaving a large amount of vulnerable skin in between. And now this is what majority of us are following, that is the asymmetric excision and asymmetric closure, that is off midline closure of the sinus. So this is what we follow in our institute in all 6 units. So it is a very simple procedure, versatile, easily adaptable by general surgeons because it has a very broad base and it very difficult to lose the flap. Okay. So that's about, and minimum complication. That's so you can have multiple versions of rhomboid, that is bilateral rhombic flap. So this is one of the case that we have done. You have too many lateral openings which cannot be fitted in single rhomboid, so you use 2 rhomboids. So another variation. So one of the follow-ups, now this was the left one is done somewhere. As soon as I learnt it from our plastic surgeon in 2003. So this is done in 2005. This is the second boy which has been done at least 5 years back. But he had come with little discharge from this. This is the commonest site where you will get a discharge. Okay, so he had come with a discharge, small, but then we could tackle that with a very simple. We just took him in the OPD, give a local and did a scoop. You can see that there was so this is the commonest site for a recurrence or a persistent discharging sinus, but this he has come to us after almost 3 years. Okay, so we did this and did 2-3 dressings and it has healed now. So this is the follow-up. So we have more than, we have been operating since 2003 by this method, and we have, not many have come back with recurrence. So these are the other flaps, that is, this is Caridakis flap. I would like to draw your attention to, in Caridakis, you have a skin and subcutaneous fat, and you go on the other side after excising the inflamed portion, and you have a big thick flap and a off midline closure. This is another very, very famous. How many of you are doing Bascoms? Yeah. So Bascoms, I find it little, I mean, you need to have an expert surgeon to do Bascom, because the flap that you are raising here is only skin, full thickness skin. No buttonholing should be done. Okay. So you're not excising too much of fat here. You want to use that fat of the natal cleft to make the natal cleft flat, so you don't have too much of suction effect. So again, Bascoms. So another advantage of Bascom is you have suture line at 2 different places. So skin suture is happening at another level and the fat is getting close at another level. So this is a double kind of procedure. Then you have Z-plasties, multiple Z-plasties which were coined by our own Dr. Pradeep Sharma sir. So these are all available plastic surgical procedures. VY-plasty, it has fallen into disrepute because you've seen this is taken for 48 hours after, so the 2004, this is the time we had Asicon in Bharti. So see, after 48 hours it has moved to midline, so it has actually not served its purpose. So 5-year recurrence after off midline is less than 10%, and in midline you see much more higher recurrence. So I think I'll skip this and go ahead. So what's new is minimally invasive surgery, which is becoming more, it's a code word, or I would say the key word for nowadays is minimally invasive surgery. And what are you following, sir? Those who raised hand for minimally invasive, I know already what he is doing. You are doing? All of them? Along with laser you are doing? Okay. And how many of you are doing video assisted? Excision? No, nobody is doing video assisted. Somebody raised hand here for minimally invasive. Sir, what are you doing? Sir, apan kya kar? WAFT, you are doing WAFT, yeah, because you have been using it for fistula and you are very well, yeah. So these are the, and EPICIT is nothing but endoscopic piloneedle sinus surgery. So the basis of these two surgery is, so basically you are targeting the hair which are causing invasion. It is done under local anesthesia, high level of patient satisfaction, definitely. When we talked about aims for surgery, the patient satisfaction and going early back to the day-to-day life was, it didn't matter, it does matter. Then reduced time off work, less pain, but the downside is it does require a wound review. The patient needs to come to your office more often, and compliance and wound hygiene incisions, instructions are must. So this is a little bit, what are the downsides of these endoscopic procedure is, we don't have many RCTs, okay, which are comparing, we have very short term results. So those who are following this very religiously need to come out with very good literature support for these endoscopic procedures. So, and secondly, most important thing is, so I am not against this, in fact I am now resorting to minimally invasive procedure myself, but a judicious selection of patient is most important. So these are a few papers which are related to now all the minimally invasive procedures which are coming up, and we are getting more and more number of patients getting operated by this. So this is a video which will show in short. I think Dr. Gangashikar has a better video also, maybe he can share it later on sometime. So this I had showed you that we did pit excision. So once we have done that, you give a nice thorough wash. Yeah. Scoop it. Nice thorough wash. So there was a single track and multiple pits in the center, and so that we decided to do laser for him. So this was a person who was going for police bharti later on. So this was the best thing, almost tailor-made for him. And he came for 2 months and 6 months follow-up, and he is doing very fine. So this very, very simple procedure can be adopted by any of the general surgeons. So this is video assisted laser ablation that we are doing, and Dr. Kamal Gupta and Kushal Mittal sir's paper is there. So healing is, yes, healing rate is very good, but then we do require a long term follow up to find out the recurrence rates. So the laser that is used, we have had an extensive discussion on laser. So it is the fiber and the energy level that you can keep. So choice of surgical procedure is guided by social impact, quality of life and financial implication. Patient may require more than single treatment, complication rates, and what matters for us is surgeon's familiarity with the procedure of choice. Challenges with the new technology, standardization not yet done, cost, learning curve. Procedure takes longer to perform at present, needs repeat treatments, needs high quality of prospective trial data to say it with conviction. And a key quality indicator is you have to tell the patient that he might require multiple settings. And these are few more procedures or types of minimally invasive procedures. They are coming now again in fashion, like phenol injections and sinusectomy. So surgical choice, I would say, asymptomatic piloneedle sinus disease, leave them alone, because it is going to die its own death by 40s. Usually you don't see patients beyond 4 decades. So no surgical intervention. If you see just midline pits, leave them alone. So I want, yeah, your choice of treatment now. If this is a clinical presentation, what would you like to do? What is this Teasel type? Do you think it is in the navicular cleft? Not going outside the midline, no, almost. So what would you prefer to do for this? Yeah, so sir, please tell what that Gibbs procedure. So pit excision is nothing but Gibbs procedure, that is pit excision. It was known as Gibbs procedure 1962, I think that is a reference there. Okay, so you will do, but what about the main opening, sir?
He was Israeli surgeon.
Yeah.
During the Second World War, he performed more than 15,000 surgeries.
Yeah. Yeah. So that is Gibbs procedure. I told you the pit excision. It was coined, I mean, it was first described as Gibbs procedure, and now in Bascom's paper I found it as just pit excision and the name was not given. Okay, so what is your choice of treatment for this? Now you have to answer the professor's questions. Yeah, it's like coring, yeah. No, for this particular patient has come in your, walked into your OPD, what will you do? Your choice, surgeon's choice. क्या करना चाहते हैं? Sir, sir, आप क्या करोगे? Pit excision envelope. Yeah, okay. See, so you can see multi. What about this? Third one. So it is recurrence after two various procedures. Actually, recurrence after Bascom's and after rhomboid. What would you like to do for this also? A minimally invasive procedure will be definitely acceptable to the patient. What about this? So this is almost Teasel 4-5. So maybe a flap procedure could be better for this. So it depends upon where the secondary openings and how much is the disease, we can decide the treatment. So take home messages, tailor make the clinical procedure that you have just done in the previous slide. Master one technique and keep on doing it for the best results. Thank you. Yes. Sir, I think all the risk factors go down. It is actually, yes sir.
Hormonal
yes, exactly.
link also to it. It is like acne has come down after some certain age. This also comes down after certain age.
Yes, so after it has some, see this is more common in the pubertal age group, in active age group, so sexually active age group. So you have more pilosebaceous and where they are active. Okay, even the hairiness goes down. Okay, so all the risk factors, that's what the simple answer, risk factors reduce. Anything?
Madam, one suggestion that you have shown that there was a discharge in the rhomboid flap.
Yeah.
So what happens, normally people used to draw a rhomboid with a center at
yes,
you
so
just shift
skewed,
it,
yeah, exactly. Thank you sir for suggesting this. So we have started making the change. So when there is a rhomboid, you have the lower end in the midline. And because the lower end lies in the midline, lowermost point, you have a limitation. You can't go close enough into that anal triangle. So skew it, turn that rhomboid to either to one side, depending upon where the external openings are. You will avoid that weeping lower end. Thank you, sir. Hygiene, yeah. So there are papers which talk about, so keep that area as dry as possible, and epilation is also advisable. So either use, if the patient is ready for getting it done, permanent epilation with the laser, get it done, or using not razors but other creams for epilation, keeping that area non-hairy. So at least 2 inch on either side of the midline. Yeah.
There have been papers which have shown the hair has come not only from the perineal
from
area.
The native. That's why. That's why not many paper for epilation, because it could not prove.
Then we have to suggest the patient to go bald.
Yes. Okay. Thank you so much.
Karika sir is happy.
Even pet animal hair found in the pilonidal sinus. Pet animal's hair.
Oh, okay. Oh.
Now we'll be having a break to have our meal, no?
इसको नीचे मत करो. That only head has to
किलो.
Okay. They should be up. Audio test कर रहा है headphone में.
हाँ.
हेड लो करा आणि this should be up. And if you can raise the foot end again by increasing the height of the table, that would be better. Because this I want to take. Okay, हो जाएगा. Xylocaine jelly.
हाँ सर. हाँ पटकन.
Can you take some suture material? यहाँ fix कर देते हैं ऐसा. जो में suture material. हाँ, this portion should be just bit above. So can you raise the table? Table height.
Hello.
No.
Hello.
We will
Lakshmikant.
fix it over here. यहाँ दो suture material लगेंगे.
लक्ष्मीकांत.
हाँ.
पेशंट बाहेर काढा ना जरा.
हो पेशंटला पण बाहेर काढायचं. Yes.
टेबलच्या आत गेले.
And can you move this patient outward? इसे खींच सकते बाहर? खींचो बाहर पेशेंट को. खींचे से पेशेंट को बाहर निकालो. हाँ. ओके ओके. स्ट्रक्चर मटेरियल लावून द्या. हे राहू द्या. याचा काही प्रॉब्लेम नाही. हे होऊन जातं नंतर. सुचर मटेरियल द्या मला.
1 लाख रुपये.
सुचर मटेरियल द्या. माझे ते दिले होते रे बघाशी मी ते द्याल. इंस्ट्रुमेंट्स माय इंस्ट्रुमेंट्स. I want one light source also, laparoscopic light source. Cut. Give me some xylocaine jelly.
Ladukar sir.
Ha.
I think before the surgery starts,
I will explain everything.
Position of the patient for the lithotomy is very important. Can you show how is the legs lying in the stirrups?
You can focus upon these legs and everything. Lithotomy extended. This position is moreover it is, and the stiff head low position is already given. I am palpating inside. I want to push my proctoscope inside so that much of the, because this patient has to be followed up after by suture rectopexy also, but there is a history of bleeding also. So mucosal prolapse is also seen. I want to show you. Can you have gauze piece there? Motha gauze piece. Can I push this inside? Yes, I will try to demonstrate that frill stress if it is possible over here now. This much of the prolapse is seen over here. Patients. Yes, it is the prolapse of the rectum itself only. मोठा एक गेला काय हा मोठा एखादा आतमध्ये टाकून पाहता येईल का असं आतमध्ये. लेट गो. येस हा पॅड द्याल तर चांगला राहील. Can you see this? Can you see this? This is not the mucosal prolapse only, because she gives history that something comes out very long, pedunculated things that comes out. On table it is very difficult to pull it out completely. It's a very patulous sinus. Focus it, this light should be on this. Light. इथे focus करा बरोबर. Okay.
Yes, sir.
All of the rectal wall is absolutely prolapsing inside. That is, you cannot pull it out completely, just like Frill's test. You cannot do it, but it is seen.
Sir, your image is little tilted. Can it be made little straighter?
Table or this has to be, just decides me. Make it in this way, straightward. Are you able to see that now?
Yeah, better.
Now you see my whole of my this two finger goes inside, everything is flabby.
Sir, why there is some scar? Just
This is probably
although superficial, there is some scars in anteriorly.
Hello, Lakshmikant. What you are going to pull the rectum down? No, you can put seam speculum and catch hold of rectal wall. It will come out with Babcock. Yeah, now you can catch hold that fold of the rectum. It will come out. If you at all you want to show prolapse. And why such a bleeding is there with that? Yeah, that will come. And now put another Babcock. Don't pull too much. Public he has to demonstrate. No? Yeah, it is prolapse. It is prolapse. From where bleeding is there? That's it.
Halogen jelly. This proctoscope is not needed. This proctoscope what I will be needing. याला halogen jelly लावा भरपूर. Now concentrate. Think of this proctoscope. This is for sacrorectopexy. अजून टाका. halogen jelly टाका अजून त्याच्यावर. अजून घ्या भरपूर halogen jelly घ्या. अजून माझ्या हाताला द्या. I want the light source inside now. Light source. आता हे वरती गेले असं. Can you make this? हो तेवढंच होतं. तेवढं दाखवलं मी. ते काढतो. Can you make the
खाली बघतोय म्हणजे हेडलो कमी आहे त्याची. नाही गेलाय तो सॅक्रल टच झालाय. बरंच झालं. आता हा तिथून घालणार तो पण त्याला फक्त दिसेल ना दुसऱ्याला कसं दिसेल. लक्ष्मी केबल अजून थोडी बाहेर काढ. ती आत गेलेली आहे. हा येऊ दे बाहेर.
बंद झालं का आमचं?
अजून बाहेर येऊ दे.
एवढी पाहिजे.
अजून काढ तू. अजून काढ. मध्ये येत नाही ती.
येते का नाही येत?
It's okay. All right. Okay.
आतल्या बाजूला काय करतोय मला हा ठीक आहे आता ठीक आहे नाही आली बाहेर पण आम्ही कशा बघणार लक्ष्मी यू आर गोइंग टू डू अलोन त्याला वाटतं
आता फेलोजला पाठवा सर पण फेलो इज देअर ओव्हर हिअर कोण आहे
एक
हा.
मिनिट
हा.
लक्ष्मीकांत
हा
तू काय एकटाच करणार आहेस का दाखवणार नाही दुसऱ्यांना
दाखवतो ना सर दाखवतो ना थांबा
कसं
तुम्हाला
दाखवणार
सर इनसाइड अरे कॅन यू सी दॅट इनसाइड व्ह्यू ओ भैया
अरे असं नाही दिसणार ते यू आज देम लॅप्रोस्कोपिक
और लॅप्रोस्कोपिक डू यू हॅव सांगा ना अरेंज करा ना
मॅडम तुमचं लॅप्रोस्कोपी कॅमेरा आहे ना
डॉक्टर गटोळे यू गेट लॅप्रोस्कोपिक rod length of 5 mm with 30 degree and you connect to the camera so we all will see it
असं पाहिजे असं असं मी आणलंय हा हे तर वर हा हे पहिलं काढा ते आणि माझे निडलेले कुठे दोन एक ते नाही मोठा पाहिजे याच्यापेक्षा मोठा हे माझ्या त्याला हे लावलेलं आहे ओके So should I wait or should I start? हो लागेल ना ते ठेवा नाही ते इथे ठेवून द्या की इथे ठेवून द्या
भैया आ जाओ इधर क्यों सुटोल एडमिट नहीं देगा
लाईट चालू नाही आहे बरोबर नाही आहे लाईट हा आता झालं चालू असं ठेवायचं आहे अच्छा हाँ कैन यू शो इनसाइड कैन यू शो मी इनसाइड यहाँ से कैमरा ऐसा करो इधर से लाओ इधर से कैमरा लाओ पीछे से हाँ you just you can focus it from here also just go inside again ऐसा करा वरती त्याचा काही प्रॉब्लेम नाही
थोड़ा सा पाहिजे त्या साईडला जा ते लाईट वरती करू
असं पाहिजे असं हां करा असं वरती तो लाईट
अजून थोडं लाईट होते
लाईट करा वरती हो गया आर यू एबल टू सी इट नाउ इनसाइड बाजूला सर बाजूला थोडं बाजूला हां गो इनसाइड नाउ गो इनसाइड You can see from outward also. Yes.
सर को मदद करो
इसको आप
सर ये स्टूडेंट है
हो ऐसा पकड़ कर ऐसा
स्टूडेंट है सर
हाँ ऐसा ऐसा Is it seen or
लक्ष्मी हॅलो आता दिसायला लागलं बघते
now I have
हां हॅलो नो वी कॅनॉट लिसन यू
hello
Ah,
am I audible now?
Yeah, you are.
Now this is the suture metal which I have taken 10 PDS on. This is on round body 40 centimeter, front is 40 centimeter.
Can you give some more head low position?
Head low.
Yeah.
Can
so
you?
Your proctoscope will look up, and you will also see better.
Can you do head low?
Yeah.
Yes. Now I will be putting my this suture metal inside.
We cannot see that.
Is it?
Huh.
Is it,
No, we are seeing your needle holder now, but inside we will not be seeing.
sir. Is it now? Is it seen?
No, ask cameraman to look inside.
कुठल्या फेलोशिप मुलाला असिस्ट करायचं तर वरती पाठवून सांगा.
If anybody wants to assist from fellow, he can come down. Come above.
Come in the water. OT.
Are Gatode sir,
हाँ sir.
can you get laparoscopic rod lens and camera laparoscopic?
They are arranging sir.
Arranging up. Now after operation, what is?
जाऊ दे. Are you seeing the inside? You have to show inside. तशा प्रकारचं मॅनेज करा बरोबर. Now it is seen properly, probably yes.
Your suture will be still, yeah, little, better now.
आता मला हे पण लागेल ना असं इथेच. हे मला उजव्या हाताला द्या नंतर. I am putting under the lens side and I am yes, it has come up. Yes. Now I have put this in a one knot. This is one. Okay, no, आप कुछ नहीं करेंगे. And this is another two. And now I'll be pushing it, pulling it, going above. I have taken my first. I have knotted it twice. Yes.
Hello.
Yes.
If any of the fellows want to assist fistula, they can go to the OT. Fistula surgery is going to start soon.
I want a, now I want scissor.
So image is getting little hazy. Out of focus.
Blur.
Yeah, better.
I have applied the first suture I have already taken. Okay.
Ask cameraman to show inside view, sir.
Yes.
Inside anal canal.
Is it okay now?
No, sir. Stitch is not seen.
I already given one stitch. How to hold it? Proper position. Okay. Are you not able to see that stitch? That stitch is seen over there. Can you go inside? This is a stitch over there. I already remember. Are you able to see that stitch? Lower down, lower down, lower down. Are you able to see the stitch now? That stitch is there.
Sir, your whole screen has gone blank. Not only stitch, everything is good blank. Yeah.
Light है क्या? Light दिखता है कुछ?
Now we can see, sir.
See? Okay.
Yes, sir. Yes, sir.
Okay.
Sir, Ladkar sir.
Audience
want to know how to decide the depth, how much depth you are going.
This needle is still busy half circle needle. Not touch to the bone. Go and I will try to take out the teeth. It goes and it.
We can't hear you, sir. Some disturbance in the voice.
I think like we take stitch for hernias, when we take the stitch through pubic tubercle, we just pull the threads and we come to know that it's holding on the tissues. Even if it is the peristome, then also it holds. But we need not to go much deeper. With the little pull, we'll come to know how the suture is going to be held. And he's basically using 40 mm needle. 40 mm curved round body needle.
Ladkar sir, can you hear us? I think audio nahi ja raha.
Yeah, you can have an idea. हाँ नवीन हाँ बोल हाँ हाँ अरे उसको लैपटॉप अभी देने की जरूरत नहीं थी मैंने उसको बोला था मैं आऊँगा तब ले लूँगा ठीक है नहीं उसको बोला कि वहाँ पे हॉस्पिटल में कैसे रखेंगे अच्छा एक काम करो तो लेके लेके ना तो क्या कर किसी का रिस्पॉन्सिबिलिटी लवण्य को दे देगा मुझे वो संभालेगी इसको ठीक है ना
हाँ are you able to show now? Show inside.
We can hear you now. Ladkar sir,
Yes.
we are with you.
Now I am putting the third suture. Yes, it has come above again. The needle, I am in search of the tip of the needle.
Ask him to focus inside the animal. He's showing from outside.
तुमचं पहिलं लेअर झाल्यानंतर तिकडे कॅमेरा घेऊन जाऊ का?
Yes.
तुमचं संपत असताना सेकंड लेअर
हो
संपल्यानंतर
हो 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 सेकंड लेअर का इथे एकच लेअर आहे इथे एक लेअर एक झाल्यानंतर
अपर स्टिच आणि लोअर स्टिच.
हां नाही नाही अपर नाही
सेंट्रल इंजेक्शन झालं की
सेटल नंतर हो सांगतो now without the knot pusher I am doing it. This is the first suture. Second I put this inside the knot and then I pull it and then carry out the third one. Okay.
Yes sir. You have nicely slided the.
That is sliding the things is important.
Ask him to show the inside view sir. Inside. Cameraman, a little bit left side.
Little bit left side you have to show. तेच होऊन राहिलं I know it.
What is the distance between first stitch and second one sir?
Hardly 0.5 centimeter. Not much.
Okay.
Not much.
When you pierce the presacral fascia, any feelings sir like?
Yes, you have to, now I will show you again over here. I will demonstrate it now. How does it? It doesn't. You cannot pull that mucosa. Okay. I will clear it now.
Okay.
I will show it how the sutures have been placed inside. Can you focus now inside? Can you focus inside? You have seen over there? Go inside. No, go. Yes. Now focus. Yes.
Yes sir. Now
you have seen the three sutures. ऐसा ही रखो भैया ऐसा.
Okay. Yes sir, we can see.
Now you can see I have taken the three sutures in midline.
So distance in between 0.5 centimeters.
अच्छा उधर से लाओ. If somebody is coming, that camera is ready now. If he can show.
Yes.
But ऐसा पकड़ना पड़ेगा फिर इसको. Somebody has to take it in this way. इसको दिखाना है क्या? अभी तो clear नजदीक आ गया रहने दो.
We have seen three stitches.
Three stitches. I will show you the fourth one now. Now this procedure you have to make that the needle is tightly fixed, tightly taken. And now I will show you how the.
Sir, आपका head बीच में आ रहा.
हाँ, अच्छा.
Okay.
Yes.
Okay.
Now I will show you how it is in the deep region. You see?
Yes.
It's quite a deep.
किती 3 घेतला का 4?
चौथी आहे हे.
सर तुमचा हात कसा फिरतोय?
ये एक.
While you are pulling, we can appreciate that redundancy also.
Oh, that is wrongly placed. It was cut through. I will take another. Okay. Sometimes it happens. हे मॅन्युअर फार डिफिकल्ट असतं. एकाच वेळेला तुम्हाला एक असं आणि हे दुसरं याच्यात टाकायचं. हे नीड यू हॅव टू कीप दिस इन दिस. ओके, जमलं. Okay. In the same patient, I will be doing transversal rectopexy, suture rectopexy also, because this will take care of all the previous for what she was operated. Probably some prolapse is also there. Now I will clean it. So. Now last but one. Okay.
Sir, from the sacral promontory also, first bite is 0.5 centimeter below it, sir. Ladkar, sir.
Sir, it was not up to the sacral promontory. It should be below the S3 level.
Okay.
Not sacral promontory.
Okay.
Otherwise, we will be landing in difficulties, much more difficulties. This is one, and this is second, another. So I will have to keep this over here, also. I have done the procedure. हो ना? आता मी काय करू सर त्याला सांगा.
खांद्यावरून घे, इथून तू जितकं वरून घेशील तितकं अजून उसको थोड़ा टिल्ट करो. हाँ, अभी आया सर.
I will show it. Are you able to see it inside now? The last suture material which is there?
Yes, sir.
Yes. Just it is, now I will be taking the last one. This is again just about 2 to 3 centimeter above the dentate line. It is very close to this. I will do it. I will push it inside and then I will try to prolapse it, put it out. Yes. Prolapse, you can see that protruded mucosa is there in between the two suture lines also. Where you have taken the sutures, in between the mucosa is then protruded. That is how it shows the redundancy of the mucosa, the whole of the wall.
Sir, in what cases would you advise colonoscopy before undertaking the procedure for rectal prolapse repair?
That when you are not sure about where the patient is having the secretions more, where patient is having history of diarrhea, and if you want to rule out something, some other possibilities like malignancy or ulcerative colitis or anything, so that in that
yeah. Then like in the workup for the ODS, obstructive defecation syndrome, as a protocol they say before you take up this patient for surgery, every patient should undergo colonoscopy. This is the protocol for the ODS and for this you have to make a protocol.
I don't do it. I have taken all the five, 6 sutures.
Always protocols are made by business people. So they want to complete all the investigation.
And I will do putting the another proctoscope and doing the suturectomy so that lateral walls will not also bleed. Okay, remove.
So what is the age of the patient?
The age? What's the age of the patient? 55.
So normally these patients are usually of old age. Normally, so any patient more than 50 years old with history of prolapse and bleeding per rectum, I think it's advisable to do the colonoscopy first.
Okay. Now I want to take this suture, Jalakan jelly. Jelly. Now, with this I will be doing suturectomy also. हे पकड़ा याच्यामध्ये नाही घे ब्ल्यू रॉड याला फिक्स करा ब्ल्यू रॉडला. Whatever the bleeding would be there, now bleeding would be stopped. You are seeing it now. I am doing suturectomy now.
Yes, sir.
Now suturectomy in the same patient. ते Vicryl 20. Vicryl 20. मी दिलेले बघायचे फाइल्स कुठे?
All the prolapse patient you will do suture?
Yes, I do regularly. I find it very useful for the patient. There will be no other prolapse from outside. They just open it. It is a very helpful procedure. Suturectomy. Now these walls will be definitely sutured to the deeper tissues like the rectal fat, and so that there won't be any mucosal collapse. Now I want another one, small one now.
Sir, can you ask the cameraman to focus and show the dentate line and above for the benefit of
Yes. I'll be asking him now. Let me take control of the suture.
This is
5/8
circle, sir.
5/8 circle. This is 5/8 circle 20. I'll show that. So what's cover code? So this is nicely dentate line is seen over here. This is the dentate line. If you can see it, are you able to see it, sir?
Yes, sir.
And we have to go beyond that. So this is the dentate line. We will be going above it. This is 5/8 circle round-bodied needle 20. And now we'll go 4 centimeter. I prefer to take first suture line at 4 centimeter away.
You're starting at 3 o'clock position.
Yes, starting at 3 o'clock position.
What is the length of the suture material?
Suture 100 centimeter.
What company, sir?
This is adequate length to cover up the complete suture line. So you will not need the another suture material in between.
What company, sir?
This is of Suture India. Previously, now it is sold by Lotus also. Many other companies, they are also preferring to do it.
Suture India has been sold out to Healthium now.
Healthium is the same product has been taken up by Healthium also. Healthium is also selling it now. So this is how now I am going. No. You have to catch hold of it. 1, 2, I am locking the sutures.
Sir, show us how you are holding the needle with needle.
Yes. Now I will be showing you. Ideally, is it seen over there? Yes. So needle holder I use to like this, hold it like this. Okay?
Okay.
And now once I put it over inside, just go beyond the first suture point. Yes, 1, 2. And just pull it out, 1 and 2. Bas thoda. Push it inside. Bleeding है आतमध्ये थोडंसं काढा बाहेर. Yes. Move it like this. Push. काढा.
Sir, how tight should the knot be? Should it be very tight or?
No, no, it should be optimum. That needle is tightened with the help of the needle roller only. 1, 2, and you see, so move it. With this only, with the help of the needle roller, I push it, tight it. Just take the needle roller inside and just push it. Hold it.
Sir, you are applying some jelly to the suture, sir?
No, not
For
at all.
easy sliding?
Not at all. Not indicated much. Sort of.
Okay.
It's not necessary. Move it like this. Now we are on the line, suture line which you have taken posteriorly. That sutures are also seen.
So, the point to be noted here is when Dr. Ladukar sir is taking bites, it is little more deeper than what we take it for the PPH stapler.
Yes, it is definitely deeper than that.
Yeah.
Because it is not submucosal. It is mucosa, submucosa and the muscularis mucosa also. Some part of the mucosa, muscularis mucosa, that is sometimes what we call it that internal sphincter is also taken care of. You have to fix that collapsum mucosa over there.
Yes. Because if you take these kind of bites in PPH stapler, it will be disastrous.
Not PPH. It is. You are not cutting, you are not going to cut anything, you are going to fix everything.
Yes.
If you are in submucosal plane, you can see the transparency of the needle.
Yes.
The tip, sir.
We should not. Here in Chutet procedure, you have to go deep down to the muscularis, up to the muscularis you have to go.
I would like to add a comment here. See, the longest procedure of PPH stapler was based on Thompson's sliding mucosal theory. So he said that since the anal cushions come down and they have to be fixed. But as told in the earlier day lectures also, the anal cushions are basically held to the internal sphincter by treads, ligament of treads. So while we are taking a bite through mucosa and submucosa, definitely we are not doing justice to the ligament of treads. They can definitely not hold the mucosa and submucosa for a long time. And that is the reason there are not many recurrences which are now being seen for the stapler.
Stapler, we are only excising mucosa, sir. We are not
excising the mucosa and submucosa, and you are not taking care of any of the vessels.
Yes,
some of the vessels which those are very much superficial and in the submucosal lesion, there will be only stapled inside, otherwise everything remains below.
Yes,
whole of the cushions, everything remains below, and sometimes some of the superficial part of the cushion is excised. So this is I'm just completing the first suture line within 1-2 minutes now. Now I am at 11 o'clock position. We have to be very sincere enough over here. We should not penetrate the vagina.
Sir, kindly show your wrist movement in this part. This
you see, okay. This is, I already pushed inside now.
While taking this kind of suture, I think your fingers and thumb should not be there in the needle holder.
That will allow easy movement of the wrist.
टाका कसा लाइट एनीथिंग यू कैन पुट नीचे से पकड़ो ओके हो दिस इज कंप्लीट शूटेज प्रोसीजर ना हे असं करा
We have to be careful when we are taking, especially in females.
Yes,
She's a
she's female. She's female.
She's a female.
Now I'll be after doing this. I'll be keeping my one finger in the vagina. Also, I'll see that whether I have done any injury or not. But I won't feel so. I have done the injury because my needle is moving transversely.
So normally while we are doing this, likewise also in the start procedure, we put a speculum in the vagina and see that whether any bite has been taken during that stitch.
So,
It's always better to examine the vagina during this procedure, especially this female is a 55 years old female and she has a tendency for the prolapse.
Sure. This is LDL. Sure.
There have been case reports while people have made the rectovaginal fistula while doing TPH.
झालं 10 minutes. 10-15 minutes. One line suture will be done. Then you can shift over to next. This hand to be moved. इसको छोड़ दो अभी अब. खूप वेळ लागला का आपल्याला नाही लागला वेळ. हां आणि सॅक्रोडॅक्टर केली सर आपण. We have not done a simple procedure. We have done a sacrorectomy also in this patient.
When Ladukar sir is operating, how can he operate on a simple procedure?
That's why I handed over to Chute sir.
Ladukar sir, there is a query from audience.
Yes.
At the end of the procedure, if you do the vaginal examination, found one stitch through the vagina.
I will cut down the things. I will cut down the suture from the vagina. I will go again. I will insert the speculum inside. I will take the another suture from rectally through rectal. But I will cut down from the vaginal part.
Okay. That is only one stitch is sufficient. Again, you have to repeat.
No. Not 1 or 2 stitches. Not important that. This happened once or twice.
Okay.
When I was doing at my own place, I had because there was a very septum was very weak, and that is possible. So all the time those patients, those are female patients where we are doing Chute procedure. After finishing the procedure, or earlier you have to see what is the do the PV examination, and later on also you have to confirm it after finishing the procedure. That is the safety.
The point to ponder here is this is a patient of prolapse. There might be a chance of that she might also be having vaginal mucosa protruding into the anus. She is not just a case of hemorrhoids.
Yes.
So there are chances that the posterior wall of the vagina invaginates in such patients into the rectum.
I will see to it now. Have I committed the mistake that, or I feel that I have not. But after completing the procedure, I will definitely seeing it. I have just completed the line. I have come down to the next suture. That see that suture, first suture material. Now I am tying it.
Sir, while sliding, if the suture breaks, what to do, sir?
No, you have to tie it. You have to this also happens many times. Your suture material is cut. That time, whatever the suture length is there, you have to apply the artery forceps to that particular one and take a new suture. Again, tie it up from over there, fix it from there, and then do the remaining procedure. This happens many times. This happens in earlier days.
Okay.
It happens. How much of the pressure or strength to be applied, that is to be decided. And this is the cause. While yes, now my first suture line is over. इसका इधर का ठोकर देखो, इसका बड़ा अंदर का जो पुश कहते हैं ये है शायद. So I will see that whether I have done anything inside, any wrong thing I have done inside. I will put my vagina finger. झालं का काय रे बाबा, इसका वजन अभी बहुत ही खराब है. स्पेक्युलम घ्या ब्रेक. आहे माझ्या जवळ आहे सगळं. नहीं टाइट सुचर है, बिल्कुल टाइट टाइट है बिल्कुल ऐसा. नो दिसते का बघा. पुट योर फिंगर इनसाइड. सुचर मटेरियल तर नाही आहे तिथे काही.
नहीं सर, you put your the speculum on the upper wall, not in the lower wall.
नहीं आएगा. नहीं है ना, कुछ नहीं है, नथिंग.
Nice.
Another scope, no, that scope. This scope is over. Take it for cleaning. See that.
In PPS stapler, when we are taking the bites, the whole circumference has to be uniform.
Hello, I could not get your question.
No, I'm just making a comment. While we are taking this circumferential suture for the PPH, the whole circumference has to be at same distance from the anal burst.
Second suture.
Otherwise, the donor doesn't come nicely.
Yes.
But in this, even if you go little haywire,
Second suture
there is some immunity provided.
20. This one is an old one scope where there is no guard over here, but this can show you how far you are away from. This is some prolapsing external pile mass is there. You can put it inside. You do have this suture material? तुमच्याकडे आहे काय मटेरियल? आहे ना. चला म्हणजे आम्हाला दुसरं मटेरियल. Now you can switch out to another because I have to complete the second suture line also. This is a repeat of the first one. If somebody wants to show another procedure, the camera can be shifted.
Nice demonstration, sir. Laddu sir.
Thank you, sir. Thank you very much.
Thank you. I will. You can come back to me when I will be finishing the second suture.
No, sir. You will be demonstrating that also, no? Foam sclerotherapy.
Yes, that is to be done.
You have to show that.
Oh, that is to be shown again.
What you can do is you can just show that and take the bites later on. Can it be done?
No. Now I have just started it. Once I have started it, I will finish it up because this takes some time. That is very easy. Light source. हाँ, लगा दो इसको. This suture. Another था उसका लगाने का दूसरा था ये black. Although I'll show you. Okay. पकड़ो इसे. करा कॅमेरा सुरू. मला जेव्हा ते करायचं नाही तेव्हा सांगितलं.
मला तो प्रकाश म्हणाल नाही ना लवकर आठवा आपल्याला
काय
You are doing second layer, sir.
Hey, second layer. I am doing second layer now.
This is 2 centimeters.
Just 2 centimeter.
Is it better to do 2 centimeters first, followed by 4, sir?
But this I do all the time. Fourth first, then second.
I missed seeing it, sir.
Huh?
I missed seeing it.
I have demonstrated now sacrorectal. Sacrorectal I have demonstrated. That was much more difficult than this. ये तो easy है ना?
Hello.
हाँ, hello.
Laddu sir, have you ever experienced patients after this having a tenesmus, number 1, and having anal stenosis?
No, talking about tenesmus, yes, it is there for early 7 days maximum. Early 7 days because there is a narrowing of the lumen because of the increased edema at the suture line. That is sometimes gives the incomplete feeling of incomplete evacuation. That is tenesmus to be felt within 7 days only. But in my Solapur series of more than now how many of the cases I have done, that's a big question. every day, sometimes daily. 2 days with 2-3 cases. So weekly I do 5 to 6 cases. And out of that, not a single case of rectal stenosis or anal stenosis I have encountered with. So this is a procedure where you will not be having any problem of anal stenosis. Now even if you are doing up that is circumferential hemorrhoids are there, if at all. So if open hemorrhoidotomy, if you have to do Milligan-Morgan, the most disastrous side effect of Milligan-Morgan is anal stenosis if there are circumferential hemorrhoids. Because if you have to remove 3 or more than 3 numbers of hemorrhoids by the procedure like called as Milligan-Morgan, so there the result has to be stenosis. And more often when you come across the patient, those having complicated hemorrhoids like thrombus, prolapse hemorrhoids, where rampantly many of the surgeons, they do excise all the hemorrhoidal masses. So this goes for anal stenosis.
Annular stricture is even seen after the PPH.
PPH I have seen, I have treated those strictures. PPH strictures, they are superficial, they are not so much deep.
They are usually superficial.
They are usually superficial, and even by doing PR examination and putting the finger inside, lubricating it slowly, in early, but that is what you have to do it. If that stricture is there after PPH or MIPH, what we call it as, it should be earlier to be tackled with. Let it not be become hard and stenotic much more. In my own workshop last year, which we have conducted out, one MIPH was done by some of the faculty member, and that patient had 2 days bleeding PR. I felt it to be routinely, it is a incident, but later on he came with a rectal stricture. But fortunately it was very easy for me to dilate it with fingers only. And once dilated, because that is a superficial stitch with that is taken submucosally only while doing MIPH, the strictures are very, very superficial. So there is no need, there should not be any botheration as far as MIPH is concerned, having complication of rectal stricture. But this rectal strictures which I confronted with was in only Milligan-Morgan, where the circumferential pile masses were excised. Not only in that, where the complicated hemorrhoids is presented and where you are in a dilemma what to do now. In that case, now usually what I used to put that thrombosed prolapsed pile mass inside under local or sometimes under short GA also. Allow that patient to be for 8 hours, let that mass be inside for 8 hours and hold up the prolapse surrounding mass. After 8 hours decreases in intensity, its volume is decreased, and so that you can very easily catch hold of, you can very easily catch hold of that necrose mass. You can remove that particular necrose segment of the hemorrhoid, and then you can carry out the Chiutic procedure. I have converted every complicated prolapse, complicated hemorrhoids by suture.
So you just make the patient lie down with the head low.
Head low position, and I have reposed the pile mass which is projected outside. If it is not easy, if the patient is having much of a pain, so try to give some anesthesia, like sedation or sometimes propofol, and I used to repose the whole thing inside. I know that whatever is prolapsing out, every mass is not necrosed. Some of the things are fiber, there are thrombosis inside. So after 8 hours, when you pull out the mass, when you take the patient for surgery again, that times what happens, the whole of the mass is collapsed. And you can preferentially select out that which mass of the hemorrhoid is very bad or it is absolutely necrose. So that part is to be removed. You can remove it by cautery also. I removed by cautery, and then particular pedicles are ligated only of the that selected hemorrhoid, and then I push everything inside and carry out this Chiutic procedure. so that my every complicated hemorrhoid patient is now treated with tooth procedure, so that there is no problem of rectal stenosis. Whenever, and because in rural areas, some of the times patient mostly present with complicated hemorrhoid, and that way this procedure, when you do it preferentially, the rectal stenosis is avoided. Any query, sir? Again, I have just completed the second suture line also while discussing.
So normally such cases of strangulated and prolapsing hemorrhoids, normally I also put them on Defnon or any other preparations of MPFF, and this thing we can start them on enzymatic preparation like Cameron Fort also with the stiff head position, and during surgery we can give little injection Hyalase.
Yes, that is also one of the procedure of choice. Yes. No, my point is to what I say, that even if the strangulated or the necrose part of prolapse hemorrhoid is there, you should not be frightened. Try to repose inside, because once it goes inside, and with that much of the body temperature 37, one thing, then head low position, and the compression being is over, this mass of the hemorrhoids reduces by itself. It helps in your surgery.
Yeah, very true, sir.
And this is not a theoretical discussion. I am doing it practically. You see, most of the patients I have done everything. Now my next procedure of choice over here is to put this sclerosant inside. Now, आता मला काय पाहिजे मी सांगतो. I want a spinal needle number 21. Spinal needle.
सर हे प्रोसिजर पहिल्यांदाच करता तुम्ही?
हां नाही, मी खूप केले तिकडे केले मी बाहेर. प्रोलॅप्स आणि त्याला दॅट इज सॅक्रोरेक्टोपेक्सी विथ सुचर हेमोरॉइडरेक्टोपेक्सी. And now that retrorectal injection of septitol. This will take care of that posterior part of the cetrol. The injection te dakho mala. This is cetrol. This is sodium tetrasodium sulfate. This is to be mixed. This is 2 ml. This is with the mix with the 4 or 5 ml of the air. ते मगाच्या 2 वे आणलं होतं त्याने 2 वे सिरिंज आणलं होतं त्याने 2 वे इथे आणलं होतं मगाच्या 2 वे इथे आणलं त्या 2 वे हे ते कुठेतरी ठेवलं होतं त्यांनी.
Sir, what sir is going to show is basically
what?
Tesseract technique of foam formation, in which 1 ml of the sclerosant and 4 ml of the air can be taken.
Yes, that I want to show. I want to show now.
And sir, why you are using 21 gauge needle? Can you
because a very small needle, if at all, this is 20, I am not 20, I have 20, 21. Do you have 21? 21.
Because like we give for varicose vein, we use 26, 25.
No sir, I want that foam doesn't go very easily. I have seen practically it is difficult to inject. Give me that. Open over here. इसको open करो आप. 10 ml के syringes, two 10 ml syringes.
Sir, take this thing, liver lock syringes.
Liver lock sir. The 10 ml syringes. This is here. Direct काय नाही करायचं, here नाही, हे काढायचं. दुसरं सिरिंज, दुसरी सिरिंज, ती पण सिरिंज नाही, ती फोडू नका, पहिले दुसरी सिरिंज दाखवा मला. बंद कसा करायचा आता, 2 वे कसा असं. Now if I push it like this, आगे बाहर है. This is okay. So though I will be keeping this air over here. आणि मला सिरिंज फोडा ते. मला अजून 5 ml ची सिरिंज देऊन टाका, दुसरी एक.
तू कुठे एकच स्टिच घेतली सर?
5 स्टिचेस प्लस सॅक्रोटेक्टोमी प्लस दिस
चिवटेबल. अच्छा,
फिनिश. पेशंट विल नॉट कम डाऊन टू यू दॅट ऑल. आता याचं काही कारण नाही पेशंटचं. आणि मला 5 मिनिट परत सिरिंज लागेल
फॉर प्रोलॅप्स रे
प्रोलॅप्स अँड ब्लिडिंग होत पडत बिकॉज प्रोलॅप्स पडतं बाजू साईडला थोडंसं ब्लिडिंग पडतो पेशंटला. दिस इज अ कम्प्लीट ट्रीटमेंट नो.
In spite of your fingers are big one, how you can rotate it?
कुठे इनसाइड बाहेरून रोटेट करतो बिकॉज ओके दिस इज
व्हेरी लॉंग.
Total pronation to supination.
हां
डॉक्टर घटोळे
Yes, sir.
चिपास निडल द्या ना त्याला ते निडल कशाला ओळखत बसला
चिपास निडल नाही सर आहे का तुमच्याकडे डू हॅव चिपास निडल
त्याला
चिपास निडल इज देअर.
आहे सर आय हॅव गिवन इट.
अरे तुम्ही दिलेस ना मग जमला काम याच्यामध्ये हां याच्यामध्ये हे टाकून पहिले जस्ट आय वॉन्ट टू पुट द निडल इनसाइड. चला हे मला याच्यात टाकायचं होतं मोठ्या निडल 10 ml ची सिरीजमध्ये टाकायचं होतं ॲक्च्युली हे. ओ हो रॉंगली प्लेस्ड. ओ हो हाऊ टू पुश इट नाव.
बाय वे
हो 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 चलो
Sir, Shiva needle is there.
वेअर
Here. It is coming to you.
त्याला अरे एअर येणारच आहे ना इकडे.
हां ठीक आहे ना ओके ओके गॉट इट. मला एक चिबाज निडल टाकू द्या पहिले आतमध्ये
Shiva needle दाखवा, sir.
दाखवा. अरे बापरे एवढी मोठी लांब.
तर तुम्ही जेवढं वापरता
येस दॅट इज
तुमच्या हातात आहे किती penetrate.
हां ठीक आहे ओके
Shiva needle आम्ही इथे ठेवून घेणार आता.
हां द्या मॅडम.
ठीक आहे सरांचं.
यू पुट हाफ द निडल इन.
येस झालं केलंय ते फ्लश केलंय.
सर दाखवा त्याला कॅमेरामध्ये.
चिबाज निडल बघून घ्या. हॉट अ लॉंग निडल nearly 6 by 6
This is 20 gauge
20 gauge
centimeter long needle. And it is marked how many centimeters are going inside.
Yes, I will be there. I will be putting this much of the needle inside only.
Correct.
And I will be putting it this retroractally. So this should go over here.
तू स्किन मधून जातो की
Skin madun. We have to go through the skin now. Guide it with your finger inside. And now you have to एक मला छोटे निडल द्या. दुसरं हे नाही हे तर याचं आहे. एनी 5cc निडल 5cc होतं ना ते आता सिरिंज 5cc ती द्या. सो हां ते काढून घ्या कारण आय वॉन्ट टू टेस्ट इट नो. निगेटिव्ह प्रेशरने आय वॉन्ट टू सी.
You are too long outside.
Yes, I will be putting inside.
अजून जाऊ दे. Half needle should go in.
10 centimeters.
Yeah, that's right. अजून बघ अजून जायला लागेल.
नाही आता नाही आहे काही सर जा ओके. इट इज नॉट कमिंग.
हां बरोबर
आहे ते. इट इज इन द राईट प्लेन नाव.
येस.
नाव व्हॉट आय विल बी डुईंग आय विल बी शोईंग द
राईट प्लेन आहे ते दाखवूनच लोकांना कसं.
Sir, if you want to see that if everybody is seeing over there, my needle is in retroractal position. You see, it is penetrated through the skin below the anal verge, and now I introduced it around 5 inches inside, and now I just push this. I want to pull it out. It just goes inside. So there is negative pressure is created. So it is one thing. It is not in the plexus. Secondly, it is not inside the lumen. That is confirmed now. Now one thing, now I want to show you that this is the foam I want to clear.
तिला धरायला सांगितले. इथे असं धर. इकडे असं धर.
And now foam is being created. आणि एका ठिकाणी ते लॉक करावं लागेल ना आपल्याला.
This is what sir is demonstrating is basically a tesseract technique for foam formation.
now ही जी आहे थांबा काय काढता ते बंद करायचं ना. नाही ते पण बंद.
Sir, it is recommended to do at least 15-16 times.
Okay.
Make it at least 15-16 times to make it a fine mislay of foam.
Yes. Now. ओके हां
इंजेक्ट करा हळूहळू करा.
Is it freely going, sir?
Yes, not so freely going. Because चिकट राहते थोडंसं. Yes.
आता ते दाखव की
Now I injected. Now I can demonstrate that there is something. Anoscope टाका थोडासा. Can I put anoscope inside? Anoscope है क्या? Scope है क्या? छोटा recto. Anoscope छोटा. This procedure is over. Have you seen? एडिमा वगैरे काही दिसत नाही, चांगला आहे सर, व्यवस्थित.
Sir, how deep it is from the mucosa?
It is around 1 centimeter deep. What I feel, not more than that.
Because
0.5 to 1 centimeter.
Because sclerosants sometimes can cause very havoc complication of perforation of the.
No. It was deep to it. It was below the submucosa. Submucosa below that. So there won't be any problem. I thought so. I won't find it. Do you want to?
You are injecting retrorectally.
Yes, retrorectally.
Yeah, not in mucosa.
Not in the mucosa. Not yes. So that I asked him that he is just below that, retrorectally.
Correct.
Give me them some tablets. Do you have the tablets or Xylocin, Xylocin? No, not that is Dynapar tablets. Boveron or any tablets. If at all available, otherwise you have to inject it out. There is no problem.
Yes, sir.
So this is
Shifting the camera.
Yes, now you can shift it. This was a simple procedure having 3 procedures which was included inside sacrorectopexy and suturehumeral. And now you can push that.
I could not see the sacral fixation.
That was the thing that was to be seen actually. यहाँ से सब चल रहा था नहीं है. Everything was.
सर एकदा पॅक करा, कॅमेरा तिकडे घेऊन जा.
घेऊन जा camera. It is the.
पॅक म्हणून सांगा चला.
Now this is over. सही हे देऊन द्या. Caesar. Yes.
Sir, do you have keep the patient NBM for some days?
Yes, the patient has to be put for 2 days, and the patient should be. So that for 2 days we can observe that if there is any pyrexia, if there is any tenderness, patient will be settled, and then you start, because we have gone through the mucosa to the presacral fascia. Chances of infections are still there.
How many days you would like to take the laxative, sir?
Laxatives for 7 days, not less than that. 7 days. Patient should be put on slowly. After 2 days, patient should be taken on liquids only.
Already patient is on liquid for
Liquids for 2 days. So we can have that. We can have the Orosol or something. Some चांगले packets of Orosol, energy packs. That can be done very nicely.
And you said the patient
Every
can use
third
Indian
day.
toilet also, sir?
Hello, sir.
Patient can use the Indian toilet up to how many days?
Can at least after 5-6 days, patient definitely can use it, because there won't be any effect. Till that time, everything would be fixed. 6-7 days is okay, sir.
Okay, sir. Thank you.
Okay. Thank you very much.
Thank you, sir.
For bearing with me with poor of the things.
Patient, sir. You can hear the applause from the house.
Thank you very much.
Nice demonstration, sir.
मला कोणतं द्या तुम्ही जे म्हणाल
Sure, sir. There is one curious query. You might have done thousands of cases. And by doing this procedure, we are inducing the inflammation followed by fibrosis. What will be the digital rectal examination finding after 6 months or 1 year? Can we feel that fibrosis inside?
No, we don't feel fibrosis, because only thing what you will feel, mucosa and rectum getting adherent.
Okay.
You will not feel hard fibrosis. So because that is not to be expected also.
Okay.
The density of citral, it is in a foam form. It will spread in the areolar tissue uniformly.
Okay.
It will not go laterally. And I showed you, I think he has not shown you, fascia propria of the presacral fascia and fascia propria of the rectum. In between that you are going to inject it.
Okay.
Because these two fascia you cannot separate even by pushing needle.
Okay.
So once you go retrorectally, you are injecting in these two fascia propria. And these fascia propria, laterally they fuse, just earlier than ureters. So your foam will not go laterally. So no complication for the nerves. So all this can be in that small strip only.
Okay.
And you will get fibrosis along that. This is in short, this procedure is depending on posterior suture rectopexy. In that 2 components are there. One is fixation of rectum. Second is creation of raw area for fibrosis. But that creation of raw area creates fibrosis which is like earlier. Why you have prolapse? Because that collagen material is not going to hold it there. That's why new fibrosis with this cetrol will create strong fibrosis than earlier. That is the purpose.
And following that two-layer procedure for hemorrhoids, what are your rectal examination findings after 6 months or some?
In fact, only suture lines you can palpate sometimes.
Okay.
Many times all sutures have gone.
Gone.
After 6 months.
That is normal findings,
Yeah,
sir.
that is normal.
That will not be progressive, whatever
no.
that.
See, whatever happens, you can have any type of design of the vicryl. Vicryl will stand not more than 3 weeks. They
Okay.
will start, getting out. Either they will come in a fragment or even long suture also.
Okay.
Anybody has got any difficulty or problem about transanal suture sacrorectopexy? Okay, if you are knowing everything, shall I ask some question then? No. I also don't like asking questions to me. Gangara, why we should go at least 4 to 5 inches in this rectal space, injection needle? Why we should go above?
Shoulder
Where
one.
we go there? This retrorectally. Why not have small area? It will go there.
You have other. This is a holy plane. You can call.
मेरे ट्रॉली इधर से
But from below, there is a one-tier ligament.
अरे टॉयल क्लिप्स दो ना
One-tier will not allow you to go if you inject in lower space.
Yes.
टॉयल
You
क्लिप्स
have
दो
to go above one-tier.
Okay.
That's why you are using at least 4 to 5 inches of the needle.
Yes, sir.
This 20 centimeters, not less than 10 centimeters you should go inside.
Okay.
Once you reach that,
और दो टॉयल
spread
क्लिप्स दो
itself.
Okay, sir. Understood.
Right? One-tier should be crossed.
टॉयल क्लिप्स दो
Regular spinal needle won't be 20 centimeters. It is.
Not at all. If you use inner spinal needle, it will not go inside at all. That is
20 centimeters.
centimeter.
नो शॉर्टकट मेरे को दो टॉयल क्लिप्स दो
Thank you, sir.
टॉयल क्लिप्स नहीं रहते क्या उसमें हाइड्रोजन पेरोक्साइड बिटाडिन सिरिंज लिया
Yes, to the audience, what you will do for this fistula? Anybody?
दादा दादा पहले सिरिंज दो एक मिथिलिन ब्लू और हाइड्रोजन
What is the plan?
गंगाराम अरे यार
Ganga
दादा सिरिंज दे 5 ml ची हाइड्रोजन पेरोक्साइड
I
बिटाडिन
want to know whether this fistula is the recurrent one or
चल
the primary one or the first timer.
हाइड्रोजन पेरोक्साइड ले दे उधर
See,
तुम दूसरा काम करो
according to
Methylene blue
the
look.
rule, most likely the opening is going to be in the posterior midline. So this may.
मेरे को दो टॉवेल क्लिप्स होना है
It's not that it is going to. That's true. The exceptions are there, but as such, the chances of fistula in the posterior midline are more.
Section लगाओ
Because the anal glands are there more. Section है?
सिम स्पेकुलम
अच्छा, दो-
बाइवॉल
Dr. Hate,
Yes.
Can you please give the history whether this patient has first time or like it's a recurrent case?
This particular patient is around 70 years old male patient with a history of some perianal, इथे लावू ना दादा, इथे लावू ना. Perianal abscess which was drained, and after that he developed that fistula, which
So
is,
can you feel the tract or can you feel the internal opening on examination?
yeah, internal opening can be felt. वाला हे द्या ना दादा, ointment, Xylocaine. इधर कोई सिस्टर वगैरह नहीं है क्या?
ते मिथिलीन ब्ल्यू तर घ्यायला सांगितलं. मला थंड लोक आहेत.
काय लांब आहे सर?
मला जेली पाहिजे.
ए जेली घेऊन ये रे.
And history is how old, sir? When was the abscess drained?
Around
Previously it was operated.
1 year back.
Okay. So the chances of tract getting matured is good enough.
Yes. And it is palpable at 6 o'clock. Sister मला हे द्या ना, जेली द्या ना, जेली.
ओ मेरे इसमें है देखो ए भैया बघ 10 लोक.
Is MRI is done for this patient, sir?
सोनोग्राफी होतं. ए इथं पेपर घे.
Yeah. I can feel it at 6 o'clock very well.
Okay, sir.
And suction connect करो जल्दी. You can see the dye has come into the anal canal.
Yes, sir.
The anal canal is full of the betadine.
Yeah, betadine
And
hydrogen
therefore
production.
you cannot know.
No, we will see, no, after getting suction, everything is to be mobilized here, no? I am waiting for the suction.
दाखव मला. हां नाही आहे काय म्हणतो.
Okay, tip दे ना, tip.
बाई टिपचं
सर जे दाखव.
See. Are you getting the outside view properly? ते suction machine समोर घेऊन घ्या.
depiction of that fistula.
ठीक आहे ना तिकडे दाखवा ना काय दाखवतो. दिसला तो
नाही, ऐसा resting नाही.
किती आहे?
See, the dye is coming through 6 o'clock.
Yes, sir.
Okay.
We can see the depression also.
Yeah, depression, I can palpate the opening, very large. So what should be the planning?
Sir, Dr. Murnal is asking for lift. She wants to
Yes,
see
exactly. The lift is the treatment of choice here. Dada, nikalo mat.
Sir, MRI is done, sir, for this patient.
See, the assistant should not assist like this because he has the tendency to rest his hand over the body of the patient. And then it becomes very difficult for us to see because the blade comes like this into the field. Dada, you will have to like this. Huh? So where exactly the lift incision is to be taken? See, I can palpate, yes. Now, in the intersphincteric plane we have to go, but it should be at the Jackson's groove. That means if we palpate it, the fistula, I can palpate it here. There is a scar also here. I don't know whether that scar I am palpating or the fistula tract I am palpating. But the trajectory is in this direction. So I will take incision from 3 o'clock to 7 o'clock.
Sir, what if you put a probe, fistula probe?
No, that will create false passage. No fistula probing. Cautery.
It is mature tract, na, sir?
Yes.
Coagulation, I don't think it's
It
working.
is.
समी पत्रिका टाका.
Bipolar को connect कर दो.
So this is the.
Some people do this in gentle probing and then
This cautery is not working.
around the probe they can
Coagulation नहीं work कर रहा दूसरा.
नवीन दे.
hook the tract.
Yeah, we will be going encircling the tract. We will ligate it in between the internal and the external fistula, curate this complete tract, and in my place what I do, I put a nephroscope or do fistuloscopy and then do complete argon plasma coagulation. And we keep this open, we remove this outer opening, send it for histopathology, the curating we send it for the histopathology. No, we don't want bipolar, we want a good monopolar cautery which is working, yellow and blue both are working. This blue is not working. सो
आता कटिंग चालू आहे, एक मिनिटात नवीन येईल.
नाही, कटिंगचं झालं काम, आता आपल्याला कोॲग्युलेशन पाहिजे.
सरांना फुटपॅड देऊन बघ, फुटपॅड कदाचित चालत असेल, बटन चालत असेल. हे दे.
होय रे, फुटपॅड घे राजा.
हा फुटपॅड आहे का?
सो एनीबडी डिफरिंग देअर? एनीबडी डिफरिंग?
Can we do coding, sir?
सो बिग?
सर कॉन्ट्री चालू आहे का बघा.
नाही.
नाही बघा ना सर.
Why I am asking? You said internal opening is very
कॉन्ट्री चालू आहे का बघा.
मला द्या ना.
माझ्याकडे आहे सर, मी दाबतो, तुम्ही बघा.
नाही, द्या ना मला.
Rahate, sir.
येस.
You said internal opening is very wide. Does lift is going to work for this fistula, sir?
We will remove that internal opening.
Okay.
We will put methylene blue shortly. Methylene blue.
Methylene blue द्या. होतं नाही ते तयार.
Sir, you said you remove the internal opening. That means, is it proximal fistulotomy or fistulectomy like thing?
Yes. द्या methylene blue. Yeah, methylene blue. Do you do dilution of the methylene blue? टाक ना पटकन, कशाला स्लो मोशन काम करतो. बस. नाही. गंगा.
Sir, I am here.
Yeah. Do you do dilution of the methylene blue?
Yes, sir, definitely. Otherwise, it will stain a lot.
Yeah. How much dilution? Can anybody focus the light?
Light.
See, the dye has come there. And now I will immediately suck it out so that it will not stain. There light nahi hai.
Sir, how much dilution, sir?
50%.
Okay.
How much?
50%.
100%.
And once you have cleaned this methylene blue, don't use it again, this particular mop.
Okay, sir.
Otherwise, while doing dissection, it will stain and there will be confusion. So remove all the methylene blue. Yeah. Yeah. Now I want good retractors, small retractors. दादा, तेरे को ट्रॉली लगाने के पहले बोला था.
हाँ सर, है, चलो सर. मोटे retractor.
नाही छोटे राईट आहे.
Right angle छोटे retractors. See, what we can do.
सर एक मिनिटात येईल.
एक कुठे
बॅकलॉगनी धरला का?
इथला स्टाफ कुठे गेला?
एकच मिनिट. तुम्ही सांगितलं होतं ठेवलेलं आहे. एक मिनिट. काय पाहिजे?
Now remove this. No methylene blue now. I am waiting for the retractors because now only retractors will help me to dissect properly. See, this is the subcutaneous part of the external sphincter.
Yes, sir.
You can see the fibers here. So I will have to go this internal sphincter will go along with this skin and the mucosa there. यार ये तो प्लास्टिक सर्जरी का लाया. यार सब लेके आ तू, मैं देख लेता कौन सा लेना तो. नहीं जर्नीज. हाँ पहिले हे झालं पाहिजे ना. नाही दुसरे कोणीतरी. चलो गिव मी एलिस. Give me Elis. Okay. Just don't let the tissue traumatize. इसको निकाल लो. Yeah, we can apply Babcock also. Yeah, और एक. Yeah, good. So I am going into that particular plane.
Yes, sir.
दादा retract करो. and every time try to palpate the tract. And you can see the blue color also. थोड़ी टेबलची हाईट वाढवता येईल का? नाही, थोडा ढिला हो गया.
The muzzle is contracting, sir. It means external sphincter.
This is external sphincter, and we are going. That light. हाँ, बस. हाँ. So lift is the best option for such long fistulas. Even fistuloscopy is also a good option with ligation of the internal sphincter.
Would you take fitting tube or any metal probe?
Yeah, we can take.
So that will help.
Yes.
Metal.
Yeah.
Stilette or.
You have shown some dye injection and scopy in Lucknow. Can we do this test here, sir? Facilities are there?
No, there is no ICG here.
Is this an ideal case to put a ICG, sir?
We can put the ICG from the external opening.
Okay.
And then we can search for the ये resting हो गया hand, ऐसा रखो. नहीं, dilators नहीं टाका sir. They cause problem. Probe can be here. Normally, with the gastroenterologist, metal guide wire is available, and that is very good.
Right angle.
Yeah. We can palpate it very well. So now I have reached up to the level of the fistula, and this is
Can we use right angle, sir?
mixture, no? Mixture is pediatric here.
Okay.
So let us hope it will work. Yeah. So this is the tract here. Okay. Now 20, yes. With what material you can tie?
नेहमी इन्फेक्ट होतं ते नाही मोनोक्रिल घ्यायला
मोनोक्रिल पाहिजे पण दे डोंट हॅव पीडीएस पीडीएस म्हटलं नाही 20 किंवा 30 हां
कारण ह्यानी
मी त्याला विचारलं ना तो कहाँ गया वो लड़का
Ideally, what suture material advisable?
आइडियली पीडीएस
Number, sir?
2030 is ideal. ओपन करो दादा इधर से नहीं इधर से ओपन करो हाँ ओके so leave it. Now after tying this we can cut it in between. And I will take through the fistula also, so that after cutting the fistula tract it will not come through. नको सर खूप मोठं होऊन जाईल. This particular distal tract can be excised also. Scissor. नहीं एक आर्टरी भी लगा दो ना इसको पहले. ये आर्टरी लगा दिया है. हाँ. Cut it. Don't use mosquitoes for this purpose. Otherwise, for the purpose for which it is designed, no, it will not work. Okay.
Sir, you said you will put the nephroscope and do plasma coagulation. Is it prior to the ligation or after the ligation?
No, after ligation.
Okay.
But not here.
No, in general, I was at your place.
At my place, yes. Now ask the assistant to stretch it so that it will go very submucosally. It is the submucosal ligation.
Now,
Okay? Are you appreciating the fistula?
Yes, sir. Your surgery also, we are appreciating your surgical skills also. Excellent demonstration.
Thank you, Ganga. You can send the fellows to assist here.
I told sir already then. Some of them are coming.
Yeah, I am assisted by Dada. What is your name?
Ravi.
Ravi. You are from?
Kerala.
You are from Kerala where?
Trishur.
Trichur. Trishur. Yeah, great.
They are coming soon.
Yeah, yeah. And you are Prakash from Gulbarga. Great. Cut it. And now we can cut it. Scissor.
For lift, rather than this Langenbeck, the Karodi retractors are better now.
Yes, yes, always, always.
Divers, small divers.
Yes. दोनच्या मध्ये.
Sir, is it necessary you say it for biopsy?
Yes.
Which piece? Outside or this piece?
Yes, now correct. Vertical
Okay. Very little of dye we have seen because it has been compressed by the sutures, no?
Yes, sir.
आता ते इंजेक्ट करून बघायचं का ते
How?
पुन्हा येतं?
5 ml syringe
5 ml
and saline.
इथं आहे.
And saline. Saline.
तिथं त्या वाटीमध्ये घे का नाही? त्या टोपणात घे. टोपणात घे रे ते या टोपणात. वाटलं पाहिजे.
नाही येत ते, आता काय येणार आहे एवढं भरलं.
So it is coming back through the external opening. Okay, so this is closed. So I will cut this also. Biopsy from this side. After curating.
You have again injected, sir.
Yeah, I injected it. Nothing was coming down, but it was coming back.
External segment is long one. Can you cut that? and
So first part of the surgery, disconnection is over, sir.
Yeah.
Okay.
So the second part is now going curating. Give me curate.
Deeptilation.
एक फेलोशिप वाला माणसाला बोलवा सर.
स्क्राइब करने के लिए.
Can we have curate? Curate.
Curate, हा. एक मिनिट पाठव. Curate आहे. BNC करतात.
Sir, one of the audience want to know
Yeah.
what to do if the recurrence occurs after this procedure. What could be the cause?
Cause is usually inadequate technique. Lift is having almost, see, Rojana Sakul has produced best results 94%. Rest of the workers throughout the world, they are saying their results are up to 80% maximum. And the recurrence is usually at the end of the 3 months.
Okay, sir.
So that thing, then we will have to do curating, but that recurrence will always be very short. Yeah, I am curating the complete tract now. I am not thrusting the curate because that will create a false passage.
Yes, sir.
Under vision also that can be done with the nephroscope and proper curating with this particular tissue can be taken for histopathology.
इधर है, इधर है. ठीक है.
Don't rub it with the gauze piece, otherwise we will be losing the tissue. See, I am reaching up to here. I can palpate. I will ask one of the fellows to see. Okay? Yeah. So they have confirmed that I am reaching up to the area where I have ligated.
Sometimes we have to pour it bigger to flush it or not necessary.
we will make this opening bigger.
That
Yes,
is for drainage, third part, sir.
that is for the drainage and for flushing.
Yes, sir.
Because this particular procedure, no, it is a blind procedure, what we are curating. And in the era of optics, no blind things are permitted and to be done.
Okay, sir.
So, curating, so that particular tissue will go with the Okay. So now my second procedure is complete. Now the third procedure is to enlarge this external opening for proper flushing. And I will try to remove as much of the fistula tract that whatever possible, cautery पहा बरं, cauteryचे parameters नाही आहे बरोबर. कटिंग हो रहा है अच्छे से, कोएगुलेशन नहीं हो रहा है. हाँ, नहीं कोएगुलेशन नहीं हो रहा है उसका. Now this is coagulation, yes, now it is there. So what will you do, Ganga, at your place?
Sir?
What will be your choice of treating this patient?
I thought of doing coring, sir.
Coring?
Hmm.
Okay. So this is how the coring is can also be done here. Be near to the fistula tract, small busts of the monopolar cautery.
Yes, sir.
And
you can see nicely. Cool.
And
my results with lift are very poor, sir. That's why I'm not doing that. Maybe technique may be wrong.
No, the worldwide the results are not so good.
Only Rojana school, sir,
60%, 70% recurrence is not good.
Even Dr. Pardasarthi from Coimbatore, he has got good results. I think 80, 82 like that.
I think the choice of the patient has to be good rather than the, we cannot just blame the procedure. In these cases, the tract
retractor लगाओ ना.
And it should be palpable while we are operating, and we should be sure that we are doing this thing. We have got the tract while operating. Otherwise, we should change the procedure.
My hand is not coming in between, no? You are able to see. Normally, if we do fistuloscopy and ablation, then we need not do coring of so much this thing.
Yes, sir.
Only external opening is removed and that's all. We keep doing flushing for 5-6 days, then that is taught to the relatives.
Yes, sir. Sir, you said
एक retractor दोनों.
Is it cheaper, sir? Cheaper than
Argon plasma is better than laser. Check. And better than, and it is very cheap. One cylinder costing 5,000 will be there with you when you do more than 20-30 cases a month. Hello. Because the retractors are little big, I will be expanding this wound.
Yes, sir.
Those retractors, they are not helping me much. Yeah, go now. Otherwise, this argon plasma is a very good tool. It will ablate completely.
As a general surgeon, where you will be using in other places, sir, argon plasma?
In gallbladder fossa,
Okay.
good hemostasis is achieved.
Okay.
People use it for also this thing, treating SRUS, that is solitary rectal ulcer syndrome.
Okay.
Then whenever there is a post radiation bleeding, no, of the rectum or नहीं यार तुम ऐसा करो हाँ post radiation cystitis, post radiation proctitis, there it becomes a treatment of choice. Then in laparoscopy for the endometriosis, if there are very small deposits, no, then they can be ablated with the help of करो ना retract करना है तो don't keep just that.
Sir, you said cylinder costs 5,000. Rest of the equipment, is it costly, sir?
60-70,000 rupees attachment to your cautery.
Okay, okay.
Very cheap.
It will be compatible with all the routine cauteries like Allen, Shalia?
Allen themselves, they are having argon plasma.
Okay.
Shalia is having argon plasma.
People are appreciating your pouring out, sir. Nicely done. Nicely done.
One track is going up, huh? See? One track is going up, the other track is going toward this side.
Okay.
And this is how the recurrence occurs.
This is again one of the reasons. Because if we have just gone for the left, we could have missed that branch.
Definitely, definitely. We would have missed that.
Sir, audience want to know what is the difference between the organ and laser? Energy wise.
See, it is a monopolar source.
Okay.
And there is a probe. That probe is having an aperture, and through that aperture the argon gas flows. Argon is an inert material, inert gas.
Okay.
And dada upar, lift it, light. And argon becomes the medium over which the monopolar cautery, monopolar current flows.
Okay.
I will show you that in video.
Okay, sir.
Of that difficult fistula surgery. Is upar. Yeah, now it is turning back, that covering. If it is turning back to 6 o'clock position, then it becomes a little bit of simple job for us. Are you appreciating the dissection in the depth? Because I am not getting proper view here.
Yes, sir.
दादा ये लाइट है ना मेरे को तुम ये ऐसा दो ऐसा हाँ
छोटा रिट्रैक्टर है क्या सर?
नहीं छोटा नहीं है ना यार इसको खींचो खींचो
Sir, what are post-operative instructions for patient, sir, for this patient?
See, post-operative dressings are very important.
Sir.
See, this is the gluteal, this is the ischial tuberosity. It is going very near to the ischial tuberosity, and hence our fellow is not able to retract it because it is a bone. You
Yes,
can
sir.
see, palpate?
We can see, sir.
Yeah, it is a bone. And it is going very near, very near. So we will have to change our dissection line because that area is not going to be retracted. So it will be difficult for...
You are cutting the sphincter right now.
I have not yet reached the sphincter. I am quite away. You can see.
That is just scoring out, no?
Yeah, just covering out, yes. See, this I have just reached the, just above the, that means it must be the superficial part of the external sphincter.
So you are going to core out entire thing, sir?
Entire thing, because we have found one more track, no?
Yes, sir.
But here I am unable to see. दादा दूसरा भी लाइट लगाओ ना.
हेडलाइट का ना हेडलाइट.
दूसरा पण लाइट आण इकडे. See, तिकडून घेऊन या हा. माझ्या
For the benefit of the audience, always if you are suspecting a long tract, complex tract and recurrent case, ask for the
Yes.
MRI. And always request your radiologist to look for disease in any of the spaces, any collection, any site tracks. So these are the things going to cause the recurrences. Already patient is operated in the past. So chances of the recurrence will be 3 times more if you are operating on a patient who is operated in the past.
And don't keep any ego that I will be doing by this method only, I will be doing by laser only, I will be doing by fistuloscopy only. Just try to help the patient remove the disease completely. दादा नहीं दिख रहा अंदर मेरे को.
हाँ sir, that is a good point.
वो उधर जा रहा है. इधर दो.
And always discuss with the radiologist, ask him to draw a pic, or else you give the pictures and what do you want, ask him. That is best way of pre-operative, something called as anal fistula mapping. So mapping should be in your hands.
एक और मेरे को retractor मिल सकता क्या?
Sir? Yes sir.
One more retractor I am asking for. Let us see if the SIMS can help me. Okay. I am doing the scoring mostly by not by cutting. Not by coring, but by coagulation mode.
Yes sir.
दादा
And again, for
ढीला हो रहा है तू.
benefit of the audience, you can change the tip. Sir is doing in depth actually. So longer tips will be available.
So the MRI basically describes how much of the sphincter is involved. That is the information also we should know in such kind of fistula.
Yes sir.
Yeah.
चलो तुम इधर लगाओ.
Anything more than 30% of your sphincters, it is called.
In males, even till 50% is okay, especially if it is posteriorly. Males में 30% anterior and 50% posterior. Females में no anterior.
Only posterior.
Only posterior.
खाना खाया ना रे. दादा बीच में कोई आ रहा है क्या? लाइट नहीं लाइट मेरा कम हो गया इधर. ये इसके कारण हो रहा है काम. light.
And always discuss with the radiologist regarding spaces. This is posterior fistula. Ask for deep postanal space involvement.
Yes.
Any other space involvement. If you don't remove the disease from deep postanal space, again recurrence going to occur.
देखा लो ना. हे सक्शन देता का कोणी ट्रॉलीवर नाही आहे ना इथे. कोणी ट्रॉलीवर येऊ नाही शकत का सिस्टर किंवा कोणी हे कारण ट्रॉली विदाउट सिस्टर कसं करणार ना. मिळाला का रिट्रैक्टर?
नहीं सर वो ये तुम्हारा पर ही है.
कोई ट्रॉली पे नहीं आ सकता आप में से हेल्प करने? क्योंकि मेरा आधा टाइम यही डिस्कस करने में जा रहा है.
And for the benefit of our audience, something called as recurrence of the disease, persistence of the fistula, and de novo fistula. You have treated the fistula, and even 3 weeks after the surgery, patients having persistently discharged and first discharge and symptoms, that is persistence of the disease. And patient free of the symptoms like wound is healed, there is no discharge, but recurrence of the symptoms within 6 months, then it is called recurrence of the fistula. And there are no symptoms for first 1 year, and if the patient develops the symptoms after the 1 year, then this is de novo fistula.
असा जो नसेल तर मला पाहिजे इन्स्ट्रुमेंट्स पाहिजे रिट्रॅक्टर्स पाहिजे.
After 1 year.
Yes sir.
At the same site also, then it is called as a de novo.
Same site.
So
चलो व्हाट वी विल डू, वी विल ओपन कम्प्लीटली.
Different classes.
नाही जाऊ दे, मी ओपन करून टाकतो.
Type 1, type 2, type 3. 3 and type 4. Type 1, same internal opening and same external opening. That means during lift we missed the track.
You're talking about the recurrence.
Recurrence.
And you're talking about which classification?
I don't remember.
Okay, no problem. Carry on.
Then there is something called a type 2 type of recurrence. In that, same internal opening is there, and in the intersphincter groove which we made, it is showing the recurrence. That means the internal tract is remaining, the cryptobladder
we have to see for that bleeding.
Tracking out through the intersphincter groove.
ट्रॉली पे कोई नहीं आता यार यहाँ पर.
हाँ सर कितने सरल माता हूँ
तर करून सक्शन करो.
Jatish sir, 1 year patient is free of the symptoms. If it is disease reoccurring at the same place, we can call recurrence now. We cannot say it is persistent. You know means the internal opening should be different, the external opening should be different. That is another one. If it is the same internal opening and the different external opening, that also is a persistent.
रेस्टिंग हैंड है.
Share with me.
Put it there. सर डेप्थ मध्ये पाहिजे असे.
मग हे घेता का
ते खूप जाड होऊन राहिलेत सर.
बघा मग तुम्हाला
ठीक आहे, राहू द्या आता जसं जमते तसं बघू. पण
सर आता ते हाय व्हरायटी झालं का
ठीक आहे. दिस इज द बोन and just adjacent to the bone that fistula is going. सर थोडं हेड लो करू शकतो का आपण? हां आता फिक्स झाला असेल. हां 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 बस बस. थँक्यू.
Dr. Rahate,
Yes.
you are dealing with the branch, the fat branch now, no? It's not the main tract.
I really don't know. I am doing covering and MRI is not available.
Because as per the picture which is shown to us in the diagram and the you have done lift, the main tract should be at the 6 o'clock position. You are going
Yeah, it is coming. This is the pudendal artery, which is bleeding. It bleeds sometimes torrentially, and it is very near the bone, so it is difficult to catch also. The pudendal canal is just adjacent to the inferior pubic rami, and I am near the inferior pubic rami. This is the ischial tuberosity, and just from the ischial tuberosity, inferior rami will go there.
You are in the Alcox canal that
I am in the Alcox canal now. And the retractors are very difficult to go there because it is all bony structure. Therefore, I have asked for the head low position so that I can go there. Now I will try to burn it completely. नहीं, bone है ना? Pardon? Yeah, I am charring it.
No, the tip is charred.
Tip is charred. Okay, so I will clean it again. But there are some bubbles forming at that particular level.
Shooter sir, this is infected surgery. Bone is exposed. We are very near to the bone. Any chances of osteomyelitis in the future?
No.
Okay.
So मैं हिम्मत करके उसको रिलीज करने की कोशिश करता हूँ. Yes, it is again bleeding. Yeah. For bipolar it is a big, हाँ, just ऐसा पकड़ो. थोड़ा लाईट देता येईल करे दादा आतमध्ये. आता हा इथे चाललाय. हा. हा. Yes, thank you. Yeah. Any suggestion how to control that bleeding? नाही पण बायपोलर साठी मला हे सोडावं लागेल. Yes sir.
Can you put a gross stitch along with the bone and periosteum with the alpha canal?
Sir, there is not much space. Only my tip is going there.
No, but still you can try, I feel.
Yeah.
If it is possible.
Yeah. Now it has stopped.
Good. It stops with the suction. Very good.
Again started. करो suction करो. See sir, it is so narrow plane there.
Hello.
Yes.
Otherwise you can pack it and hold for some time rather than sucking it.
Sir, it is arterial. It is arterial, and I will fear that it should not retract.
Yeah, that is main thing, because then you have to go through abdomen only or intensive radiology.
सर मागे जाऊन बायपोलर लावलं तर अष्टीच्या मागे.
I will try bipolar. There are suggestions that go behind the bipolar. Yeah. Very difficult. Yeah. Bipolar forceps दो ना यार.
हाँ सर पड़ा. नहीं.
ठीक है. So this type of things you should be ready. Proper lighting, proper equipments, they are very mandatory in the OT. I will try to take, I will keep all the options ready. Yes, sleep can also do. ये बज कहाँ से रहा रे? कटरी किधर से बज रहा है?
कटरी कुंडा वाला ले रहे हैं. कटरी का सर नहीं इधर का है. इधर से क्या है? अच्छा.
ठीक है. मिल गया बाइपोलर?
इधर बायपोलर होना क्या? बायपोलर फोर्सेप.
Once I release this artery, the bleeding starts. चल पकड़ बरा इसमें.
बायपोलर लाव रहता ना.
Okay. So now the bipolar is available. पैडल पैडल बाइपोलर का पैडल दो ज़्यादा.
ते बाजूला ढकल अजून पुढं. शांतपणे कर, पुढं ढकलते. पूर्ण पुढं ढकल.
हाँ चलो सक्शन करो.
Sir, is the patient position is head low?
Head low, head low.
Okay.
Then only I got some visual this thing.
Yes, sir.
You are getting some view
Yes,
there?
sir.
I will take a stitch also as Chiute sir has said.
त्या आरटीला पण हे द्या की करा.
आर्टरीला दिला ना,
दिला.
मोनोपोलर भरपूर दिला. बायपोलर तर नाही लागणार त्याला. सक्शन सक्शन सक्शन. गो इन फ्रंट. हाँ. I don't know from where it will come. Any suggestion how to take stitch? Section. Because of the proximity of the bone,
Yes, sir.
all difficulties are there.
Can you put a right angle, long right angle there?
They are not available.
छोटा divorce.
No. You just do this type of. I have seen the tip now.
Right, sir.
Yes.
Dr. Chevte sir is suggesting
Yes.
that you go near the bone, take some periosteum and
Sir, there is no space at all. निकालो. फट से सक्शन पे आ जाना. सक्शन करते रहो. There is no space there to take even to rotate this needle or like that. आप सक्शन करते रहो. I will try to take. You seeing that spurter?
Yes, sir.
These are the branches of the internal iliac. I will try to coagulate only. This is not possible to take stitch there.
ट्रॅक काढून टाकता का ते? मध्ये येऊ लागेल.
काढतो.
ट्रॅक काढून टाका. मध्ये येते तुमची.
Cut this thread. Yeah. Let that artery be there. We will remove the tract. We will get some space. Monopolar. Yeah. इधर लगाओ ना, इधर रिट्रैक्टर। या खींच सकते हैं इसको? हाँ। With the hope that no second bleeder should start.
No, there won't be any. There are no.
Hopefully, sir.
Yeah. Too hard a track. Suction. Yeah. It will be interesting to see the histopathology of this particular tract.
Yes, sir. Any tuberculosis chances will be there, sir?
Tuberculosis will not be so hard, no? दादा इसको थोड़ा सा हाँ बस हाँ नहीं
Only, see, it's a single opening. Normally in tuberculosis, what you get is multiple openings.
नहीं ऐसा रखो ना हाँ
It can happen, tuberculosis can happen, but yes, tuberculosis can be present, but this is not very suggestive of tuberculosis. It's not so suggestive of tuberculosis.
Yes.
Is it a intrasphincteric extension or what?
Sir, it is going almost supralevator. So I am now in the supralevator area.
I feel pressure.
Is it okay to if you just curate?
Yeah, cut down and curate that.
Just curate that tract rather than going supralevator?
Yeah, I am doing that cutting only so that I will be getting some space to tackle that bleeder. See, it is very hard.
Must be long duration.
You can see this blue.
Yes, sir.
Too much fibrosis.
Yes, sir. Maybe long duration, long standing duration.
Going inside the sphincter.
Vijay sir, what is your opinion? What should be done?
Sir wants curating it seems.
You should just curate it.
Yeah. That is what I am going to do now. The problem started with the bleeding.
You can see the tract nicely.
Yeah. Close that. Two zero. Yes.
तू partially cut करून opening करून curate कर अगोदर मग cut कर.
How sir?
नाहीतर retract होऊन जाईल ते.
Now I will close it. Curate it, close it. Curate, curate. नाही आता होती ना क्युरेटिक दिली होती मला हाँ suction. Now I think I will be having good curating. Remove. Your suction is hampering the view. So one more bleeder here.
It's because of extensive fibrosis. It is not closing.
Yes. दादा 10 वाइक्रिल दे तू
10 वाइक्रिल।
हाँ तुम्हारे पास मॉप है क्या? चलो मॉप मैं पैक कर रहा हूँ कैविटी धीरे धीरे करेंगे. So we are now going to tackle 2 bleeders, but I think now I will be able to tackle it because I am getting some space there. Yeah. ठीक है, रिट्रैक्ट करो. एक के हाथ में सक्शन रखो. एक के हाथ में सक्शन रखना. हाँ चलो. Now I am removing this. हाँ. दिखो. तुम्हारे सेक्शन में ट्रैक्शन भी काम करना चाहिए. It is there. Yes. Okay.
Better दिसतोय ना समोर तुला?
हो दिसतोय. हाँ कॉटरी. हा आवाज कसा येतोय? It is in between my forceps.
क्वार्टरी टिप जरा क्लीन करा.
हे दादा क्लीन करून दे. BP is still 120/80. दे.
खूप ब्लड आहे
दे.
प्रशांत तू फोर्सेप मध्ये धावला ना मोठी गोष्ट देते.
हाँ.
त्यांनी पुढे असली होत्या.
सर आता मिळाली आहे. गोटी करून टाकता. So that is stopped now, for sure. The other bleeder also stopped. Needle holder. But it will start post-operatively. So we don't want a sleepless night. We will take a suture there. Needle holder इधर है क्या? हाँ इधर है.
Can you try 5/8 circle 20 sir? It's there in the OT. 5/8 circle.
5/8 circle.
Yeah, all the one letters are used. Because you are operating in depth.
That LDL suture you mean?
Yes sir, LDL.
Okay. What other case is going on? OT? Okay. Yeah, now the things are under control, so we will shift the camera to the other case in next OT. I will let you know what I have done finally.
Okay sir.
Okay? Yeah. I am suspecting one opening there in the rectum. Rectum. So we should close it down. Yeah. See. See. Put one finger here. Don't completely poke it. Mucosa is still intact. Okay? See, mucosa is still intact. Okay? But I don't think the finger is coming on this side. Yeah. Yeah. So you will give a support. Yeah. You will give a support there.
Not that, sir.
Show me? Yeah, it is too high. No, we will pack, no, we will pack it and come out. So it's bleeder again. Bipolar. देखो bipolar.
Bleeding from that.
Bleeder, अपना bipolar.
Bleeding from that.
ये यार इसका कैसा लगा है ये? नहीं, ऊटी के लोग कोऑपरेटिव नहीं है यहाँ पर. दे आर नॉट एट ऑल कोऑपरेटिव. मैं पहली बार देखा कि हाँ ये वाला है ना?
ये वाला है बाइपोलर.
नहीं ये पहले
ये वाला है बाइपोलर पीला.
कि नहीं हो रहा. नहीं हो रहा. Can you shift that, push that there? हो रहा क्या यहाँ पर? ये तो हो रहा है.
Still down.
From the here. चलो अपन यही लेते हैं. लिया 10?
क्या सर?
10 वाइक्रील बोला था.
10 वाइक्रील घ्या. अजून एक घ्या.
अरे यार.
So it can be seen now.
It can be seen. Can we go there? Too high, huh?
Sir, I think we'll ask for the long and middle shoulder.
नहीं है ना, they don't have.
Sir, they look for the other one.
Hold that and tell me. So this white head.
So they had a long needle for the other.
Hello.
Yes, sir.
Yes, Mike.
Hello, Ladakar sir, can you hear me?
Yes. I am seeing you now.
Yes, sir. We are able to see you.
Okay. The thing that now that case is a bit over. Dr. Waterate has shown us. Now another case is there which is in front of me. This is a case that is being anesthetized now. He had a history of fistula repair surgery prior to 1 year. But here नहीं 30/5/23 को ही की थी उसका fistula repair. Patient of seizure, but now he had some just like what we see that in chronic fissure.
Okay.
That is that particular at 12 o'clock position there is a edematous swelling, and that is giving him the pain. Probably that is the inflamed what we call it as sentinel tags जो रहते हैं chronic fissure में, so that I feel that is that sentinel tags is inflamed at 12 o'clock position,
Okay.
and that is painful. So now after giving spinal, I will see that whether that sentinel tag is only inflamed, so I will just cut it, or if there is any abscess or this thing, or if there is any connection in between, that has to be ruled out. But patient, what he says that he is having only typically pain at 12 o'clock position. There is no discharge, there is no bleeding, anything. So yesterday I have seen this case. So let the anesthesia part is over when the patient is put in the lithotomy position, I will evaluate the things and then I will be back to you. Okay?
Okay, sir.
Okay.
And this is the complete external sphincter, and this is the intersphincteric groove, and we have ligated the fistula tract in the intersphincteric groove. That is the lift which we have done. And this tract was going from the external opening here up supralevator and then came down here. And in the meanwhile, we had bleeding. So now that bleeding is completely under control, so we will not close down this cavity. Let the post-operative secondary intention healing happen so that there will be no recurrence, and if there is bleeding, this packing in post-operative period will help. Okay, so we are leaving behind. We will close down this intersphincteric wound, so that only we will close down, so that there will be no deformity or stricture at this level of the anus. Okay, so we will close down this. We will not close down the big wound. The bleeding is under control. Intersphincteric fistula is closed down. The rest of the tract has been removed.
Okay.
Yeah.
What about the internal opening, sir?
Internal opening, already we have ligated it very flush. So we are not going to do anything to it.
It is like submucosal ligation.
Submucosal ligation,
Okay.
sloughed.
This part, what you have shown is the superficial portion of the external sphincter, sir.
Yeah, this is the superficial
Yes.
or subcutaneous.
Okay.
Subcutaneous, and then superficial, and then deep portion.
Okay.
So this is the intersphincteric groove.
Yeah, yes, sir. Nicely. Sir.
Okay? Yeah, thank you. So just give stitches like this. Okay? 1, 2, 3, 4 stitches. Okay. So we will shift back to Dr. Ladukar again.
Okay, sir.
Yeah, thank you. Anything what is available, even 10, जो भी है, नया कुछ मत लेना. Okay. Give stitches first at the angle. Take this to here and then give 4 stitches. Check. काढता का
Ladukar sir? Ladukar sir?
I think mic is still with Rahate, sir.
Rahate sir?
Hello.
Rahate sir?
Yes.
Can you hand over the mic to Dr. Ladukar?
Yes, they are doing that. They are doing that. हाँ, दादा जेल फोम डाल देना. ठीक है, जेल फोम दे देना.
कुठं लावतो हे सरांनी विचार.
हे माईक काढा ना.
चाय आ गया. चाय आ गया. चाय. चल ना, अभी आ जाओ. पी के थोड़ा चक्कर भी थोड़ा लगातार क्यों बैठो, है ना? आ जाओ.
झालं लावा आपण पटकन. Hello, am I audible now?
हाँ sir, audible है.
So the patient one which has taken now, this is a case
Sir,
of...
video is not seen.
No, not at all. Just somebody was asking me because this patient was taken for fistula surgery before. That was lift was carried out on on 35 last month 30th of the May. This procedure was carried out as a for fistula repair. That was lift was done, and there was there was hemorrhoids also. So laser ablation of fistula tract with laser hemorrhoidopexy was done. And after that, post-operatively, there was formation of hematoma anteriorly at 12 o'clock position.
When it was done, sir? Recently,
10 days back.
Okay.
And now because of that hematoma, and now whether that hematoma is there or whether that that particular the pedicle which is there, which is inflamed, that I have to see now. The patient is to be taken for lithotomy now. And now once the patient is in lithotomy, we will focus on the patient and I will let you know what the things are. It is not because of the lift but because of the laser for hemorrhoidopexy.
So basically this is examination under
Anesthesia,
post-op laser complication.
Yes, yes.
Okay.
That's what.
Good case.
Good case. Let us see now what it is. ये निकाल लीजिए मैं अरे अच्छा ऐसे ही कर लेते चलो नो प्रॉब्लम गिव मी गाउन लो गाउन लो टेक डाउन और इसको पैर कैन वी डू दैट अगेन वी हैव टू टेक इट हो हाँ ऐसा हाँ टेक द सर्जिकल डाउन
ठीक है बस ग्लव्स दे सर अन्ना
बस ऐसा ही चलता है उसको हाँ चलो 7.5 सॉरी बदला थोड़ा सा बदला gloves. Can you make it head down? Make this up first. Table up कर दो. बस. टेबल आप बाहर आला पाहिजे बाहर आला पाहिजे. Can we shift the patient? बाहेर आले पाहिजे. इस बाहर लो इधर है.
पेशंटला खाली ओढ. कमरे जाऊन एकट्याला नाही
ओढा. हाँ जमला. Now it's okay. Now you can focus it now. एकच शीट फक्त बस. Okay. चलो कैसे भी रहेंगे. Gauze there. Are you seeing anything over there?
1 minute. नहीं
Yes sir. There is some edematous skin tag at 11 o'clock and 12 o'clock.
Yes.
And
this is the position of lift. Posteriorly at 6 o'clock position because this is the tract of the fistula. It is seen over here. Is it?
Yes sir.
This is the fistula tract. This must have curated out, and the lift was done at 6 o'clock at 12 o'clock position, and now patient is having pain over here. So this is a complete. It is inflamed.
What is this sir?
This is a tag. This is a tag completely. But when I put my finger at 12 o'clock position, there is induration. I have. Let me see what it is. छोटा है का हाँ कमा.
Do you have plastic slit proctoscope, sir?
Proctoscope, that's that. Yes, proctoscope छोटा रहता है ना, इसका प्लास्टिक का प्रैक्टिस का प्लास्टिक proctoscope.
MIPH करायचं असतं ना तो.
हो. Where to be kept it?
MIPH करायला वापरतात ना तो.
अँटेरियरली पाहायचं आहे मला, काही प्रॉब्लेम आहे का त्या पेशंटला? अजून
Dr. Ladukar, has this patient undergone a lift procedure?
Yes, he has gone lip procedure 10 days prior, and there was also he was treated for laser hemorrhoidectomy, where the laser was put in, and now patient has developed the inflammation at 12 o'clock position. You can see this is the pedunculated part which I want that this should be excised completely. I want to see that is there anything inside, because yes, there is the hemorrhoidal pedicle is seen inside. Can you make that thing, the table be tilted again? हेडलो द्या थोडंसं फाटून जातं ते वरचं.
Any suture ligation, suture you see in the hemorrhoidal pedicle, sir?
Yes, he has put one suture is there.
Okay.
He has put one suture at the pedicle. One did not do anything now. Only thing is that this much of the pedicle, which appears to be inflamed, and it should be cut out. It is painful. I will remove it only. Nothing to be done more. Because there is this pedicle. Are you appreciating it? I will show you. There is a
pain, sir.
Yes. You see now.
No, sir, we can't see.
I will show you. एक आर्टिफोसप द्या. आतमध्ये फोकस करा. You see, this is the pedicle of the hemorrhoid. Actually, this is the long hemorrhoidal segment, just like you see. You see this is, see? Are you appreciating this? नहीं, इधर से लो, इधर से इस साइड से.
Left side से
left side. On my left side. On my left side. Now he is focusing. Can you tilt it again?
No, sir.
Tilt the table again. You see? Tilt म्हणजे head low. Head low करा, हे वरती करा. हाँ बस. Are you able to see it? No. Yes, now.
We are able to see some raw area.
This अरे नाही. इसको खींचो ऐसा. Yes. अभी दिखता है कुछ? You see?
Yes, sir.
You see, this is the part of the. This was the. Actually, this was the hemorrhoid. ये जो दिख रहा है ना, this is the hemorrhoid. ये this much. Are you seeing it now? See? सब.
Yes, sir. We can see the hemorrhoid. And some dry line.
I feel that should not be, because the pedicle is ligated already.
Okay.
The pedicle in front of that, both उसके नीचे pedicle है एक, वो ligate किया है इसके नीचे.
What do you want to do?
No, because this will not. This is not the problem, because this is beyond the dentate line.
Pain is
I will remove this much of the segment. I want cautery.
Yes, sir.
But why the pain is there, sir?
Because this is completely just like fissure. You see, just like anterior fissure, there is a pain, and this was inflamed. This particular part is completely inflamed.
Okay, and
this might be because of the energy source of the. This might be because of the laser.
And how much is the spasm?
You see?
Spasm. Another spasm is there or not?
No. Now under anesthesia there is no spasm, but he was having very painful spasm over there.
Sir, can you show the raw area again?
You see?
That could be the entry point of the laser, sir.
Yes, you see? Now you see? Is it?
Okay. So surgeon might have delivered large amount of the energy there.
That I feel so. I won't do anything for this hemorrhoid now. Hemorrhoid's pedicle is already here, sutured over here. I won't do the things now for here, and I will remove this by cautery. That is the thing. That is the thing. Cautery, yeah.
And bipolar then.
Yes, sir.
Because that will definitely take care of this. This pathology is removed once, because this is just like anterior fissure with inflamed pedicle.
If the spa was there, so wouldn't you like to do some sphincterectomy also?
I can do lateral sphincterotomy. I will do. I will do the lateral sphincterotomy here. To by closed method, that will be again nice suggestion. Other what I feel, 2 cc xylocaine infiltrate 2 cc xylocaine आणि माझ्या नाही ॲड्रेनलिन बी असेल तरी चालेल. आणि माझा एक कॅट्रॅक्ट नाईफ आहे मी आणलेला. कॅट्रॅक्ट नाईफ इज इन माय बॉक्स येलो. काढा इथे. The cataract knife is there. I will do the sphincterotomy also, so that the pain will be definitely lessened. झालं मिळालं मला. So I will do first lateral internal sphincterotomy by closed method, and then I will remove this. Okay, patient will be pain free.
Sir, why do you require a knife? The wound is already open. You can just put a little cautery there only.
No.
And do the entire center.
No. I won't doing that, because that is already inflamed area. I will be doing at another place.
So you want to give a separate?
Separate, very no. I will not open it. It is just by, it will be done by the cataract knife, closed internal sphincterotomy. Closed internal sphincterotomy I will be doing. I will be showing it how it is to be done. So the pain factor will be 100% relieved out of this. And now what is the part which is inflamed, I will cut it, because there remains the pathology because of the probably because of the laser ablation. That complete that.
And sir, in such patients, I think is it advisable to give some sort of local block containing methylene blue also, because it will give a relief for longer period of time, and methylene blue also acts as an antiseptic solution.
Yes. Some people do it. I don't have that much of experience in methylene blue, but I will be doing now left lateral sphincterotomy by the cataract knife. Now I am installing submucosally, that we have to go beyond the submucosal plane. I am infiltrating the xylocaine. So this plane is created. Now take that knife, yellow. Correct. And now I will put this knife.
Can you show the cataract knife for us, sir?
Yes, anything, anybody?
Okay.
Is it? So I will be putting this knife over here. My guarding finger is there, which will guard the anodum inside mucosa. Mucosal pressure is there. Now you put this submucosally, and now you cut the sphincter.
Medial to lateral sphincter.
Medial to lateral. This I routinely do. My only puncture is the puncture of the cataract knife. That is over.
Nice.
And now I just press it for a minute or two. Now over. Now my 2 fingers are allowed. Okay? Once I put this sphincterotomy is done, and give me a knife. This knife forceps length. Okay. Now I will cut it out. Okay. Press it. Just press it. हे झालंय सगळं बरोबर सुरू झालंय हे.
So you are just removing the unhealthy tissue there.
Yes. रिमोट हां अरे चलने रहा है चल क्यों नहीं रहा हाँ चल नहीं रहा है इसका पायाचं पैर का लो ना इसका पैर का पेडल लो ना फुट स्विच दो फुट स्विच दो दो ना इसमें हाँ क्यों नहीं रहा फुट स्विच दो ना क्यों ऐसा हो रहा है चल के नहीं नया तो ही हाँ पेशेंट हाँ काय झालं काय झालं हो यांचं बस काय झालं कॉटरी नाही चालत त्यांच्या बरोबर हां पहा ना पेशंटची प्लेट नाही का बरोबर काय झालंय तर ती पिन काढा आणि परत लावा तीच 3 पिनची काढा आणि परत लावा तिथेच लावायची आहे ना काहीच नाही म्हणाले त्याच्यामुळे तो मगाशी चिडचिड झाला माहिती आहे का नाही पण हे लावलं नाही का तुम्ही पेशंट प्लेट लावली ना बायपदर क्यों नहीं चल रहा फिर व्हाट द काहीच नाही द्या बायपदर द्या द्या बायपदर द्या थोड़ा तो कॉटली तो हो गया एक्चुअली आई हैव फिनिश्ड इट त्याची प्लेट प्लेट कोणती याची हीच आहे का नो याच आहे हाँ ठीक है
थोड़ा वाढवा नाही तर सर किती होईल
राईट
थोडं वाढवा मॅडम
काय बेकार हे याला क्लीन करायचं आहे ना मॅडम यात द्यायचं हे काढा नाही काही नाही ते थोडंसं इन्फेक्ट झालं होतं पूर्णचं पूर्ण आणि व्हॉट आय फाउंड दॅट वॉज दी ओपन एरिया विच वॉज बिकॉज ट्रीटेड विथ लेझरच्यामुळं काय झालं होतं काही नाही आहे यांची कॉन्ट्रीब्युटी चालत नाही हो बिलकुलच चालत नाही कॉन्ट्री हां चला ठीक आहे, हे द्या पॅड ठेवायला आतमध्ये नाही संपलं, काही नाही करायचं, जास्त जास्त करायचं काही कारणच नाही त्याला. झालं ना त्याला काय, त्याला एकदा तुम्ही हे केल्यानंतर काही प्रॉब्लेमच येणार नाही. स्पेसेस क्रिएटेड होतात. पण हे काम तुमचं काम का करून एवढं चांगलं आहे? पण प्रॉब्लेम ते चाललं नाही चांगलं, म्हणजे चालायला पाहिजे तसं चाललं नाही.
Before we start any live operative, we'll start dead lectures, sorry, live lectures, because we all are just, tired of waiting. And anywhere, waiting is not good. So let us start lectures. Dr. Madhukar Pai, he is from Kochi. He is very renowned surgeon there, and he has done lot of good work, and he will share some work with you. Dr. Madhukar Pai, please.
Thank you, Shifter sir. Thank you, the organizers, and as well as ISCP. A warm good evening to all of you. I'll be talking initially on lift procedure, my experiences on it, and then I'll be sharing a video on DeLorme's procedure for prolapse. Fistula in ano. It is an epithelial line tract connecting the anal canal with the perianal skin. There is low level and high level fistulas. I think those topics will be discussed elsewhere. Lot of different treatment modalities are available, like fistulotomy, fistulectomy, glue, collagen plug, seton, lift, waft, every procedures are there. Every procedure is always compared with the fistulectomy, that is removal. Our aim is to remove the entire fistulous tract from the external opening to the internal opening. That is our aim. We have to remove the entire tract from the external opening to the internal opening. In fistulectomy, we will cut these entire tissues to remove the tract. And the trauma to the patient is, one, cutting of the skin, and second is cutting of the sphincter. So a lot of procedures modifications are done to preserve the skin and preserve the sphincter. Let us talk on one of such procedure, which is known as lift procedure. It is intersphincteric fistulous tract ligation. I will go back to the previous slide. Why do we go to the intersphincteric plane? Even if a fistulous tract has got multiple branches, when it comes to the intersphincteric plane, all of them join together to form a single tract. So outside it will be multiple tracts, but in the intersphincteric plane, mostly it may be a single tract. So if we ligate the tract there, the disease can be controlled. And second thing is, a persistence of cryptoglandular abscess is what is another postulation which is told to be the cause of fistula. It happens in the intersphincteric plane. So inflammatory tissue removed from the intersphincteric plane, that will lead to the cure of the fistula. That principle led to the development of the procedure which is known as lift procedure. It was developed by a colorectal surgeon, Dr. Arun, in Bangkok, Thailand. Let us go to the procedure details. Any case of fistula, I always advise a gentle anal dilatation. A partial, that is speculum, is put inside. I usually use the partial scope which we get with the PPH stapler. It is ETO'd and reused. So side viewing scope can be used there. And only for the entry of that scope I do a dilatation. If we do a very harsh dilatation, we may lead to the breakage of the tract and the methylene blue can get extravasated. And as Dr. Ganga told in the morning, our finger is the best guide. Under anesthesia palpation, I think that is better even than MRI scan. A surgeon's finger is always better than even any of the imaging modalities. Just showing a picture of a fistula, we are seeing an external opening, we are seeing an internal opening. Just like what we saw the lift procedure, here also there is an innocuous fistula sitting there. Only one external opening and one internal opening. Dilatation just very minimum needed, and that obturator also I am using it only minimum there. Then next thing is identify the internal opening. There are a lot of ways to identify the internal opening. Some do instill hydrogen peroxide. I use the cannula so that it doesn't traumatize it, and instill the hydrogen peroxide inside. It opens up the closed tracts. After that, the tract can be delineated with the help of instilling methylene blue. Always care should be taken, don't to force the hydrogen, we should not force the hydrogen peroxide, also we should not force the methylene blue. Just take 1 cc or something with us. Otherwise, that can break the tract and methylene blue can extravasate. There are other techniques like using betadine or probing. Even if we are doing probing, the probing should be gentle and much of lignocaine should be applied. We should never force into the tissues outside the tract. This is the thing which we get with the PPH stapler, which can be ETO'd and reused so that the cost to the patient comes down. Next is, as what we saw, making a incision at the intersphincteric groove. We can feel on one side there will be hairy skin, the other side it will be skin without hair, and a groove can be felt which demarcates the internal sphincter and the external sphincter. Then dissection can be done with an artery forceps, a probe can be placed and the tract can be hooked out. It can be ligated. Then after that, after the tie is made, probe can be passed from either end to see whether what we held is the tract. Always make sure that we take the tract and ligate it. At times what happens is there will be some fibrous tissues and we mistake those tissues for fistulous tract, and the fistulous tract will be left inside if the tract is a deeper tract. After that, the distal portion, it can be managed either by coring or curating or cauterization or laser or whatsoever method. What I do prefer personally is always a coring method, because if the inflammatory tissue is fully removed, the healing is better. That is just my perception, but all the modalities are proved by different surgeons. Now, after the removal of the distal tract, what next? That is proximal tract we ligated and distal tract we removed. Now the external sphincter will have a defect. Close the defect with a PDS or a vicral suture. Then we have to suture close the intersphincteric groove. And the procedure is completed. The advantages of this lift procedure is it preserves the sphincter action, minimal tissue injury, so lesser pain, shorter healing time, and it is relatively easy to perform. And one more advantage is there is the anatomy of the anal canal, that is the circular nature of the anal canal is maintained there. Otherwise, at times what happens is once the anal canal one end heals with a scar tissue, patients do complain about after healing, maybe 1 year, 2 years later, they will say, when I walk around and come back, a bit of fecal soiling is there. Just a very pea-sized fecal matter is coming out. That comes out from at the region of the scar. So that amount of fecal soiling can happen, and if we are able to preserve the anal canal, it is always a thing which is acceptable. Lift is a procedure which is suited for a complex fistula. It is not needed for a small submucous fistula where the fistulectomy wound will be too small. It is neither suited for a very high fistula also, because the tract may not enter the intersphincteric groove. Now coming to my case. The tract was cored out as much as possible. Again, integrity was checked with instilling the methylene blue. An incision was made in the intersphincteric groove, and the cored out tract was taken out, and the tract was divided there, ligated, and that is the lift procedure. But after that, when we felt there was tract extending there, this side there was a scar tissue which was felt, and this is an iatrogenic thing. We located the tract was extending on another side, and the entire tract was removed from the 11 o'clock position also. Finally, we were able to preserve the external sphincter. That was suture repaired. We were able to preserve the skin bridge also. Just imagine if we left open this entire wound, how it will feel. It may be a horrible situation for the patient. This wound, patients can manage themselves at home. They can take sitz bath, they can clean it with soap and water, apply ointment, keep a pad and put an underwear. But if we keep the entire wound open, it may not be they may not be able to manage the wounds at home. And inner part, I usually prefer to perform a fistulectomy there rather than close the intersphincteric groove, so that the tract which is there from the internal sphincter to the inner opening is also taken care. Such high fistulas, I leave the intersphincteric wound open, because at times if the fistula recurs, this will downstage the fistula, so that a second procedure may be we will be performing on a lower grade fistula. Post-op care like antibiotics, analgesics, laxatives, lignocaneal applications, betadine ointment and dressings, sitz bath. Sitz bath should be 3 times a day, at least 20 minutes they have to sit. Then last but not the least, we have to always insist on dieting. I always tell them, take more vegetables, less spices, more water. And I always tell them, vegetarian diet and vegetable diet is different. They can take non-veg without spices. They can take chicken soup, they can take grilled chicken or whatsoever they can take. Along with that, let them take a cup full of salads. So vegetables in plenty, water in plenty, and avoid spices. And at times what happens is, especially in Kerala, we do take masala dosha. That is dosha, along with that potato curry will be there. It is a vegetarian food, but there is zero vegetable in that. Another Kerala food is puttu kadala. Everybody likes that. There also there is no vegetable involved. It is black gram and puttu, that is rice. Postural advices like maintaining, don't squat down when so much sutures are there on the external sphincter. Don't squat, just be careful that such a procedure is done there. Don't roam around on bike or something like that. Take care, take rest. And even in the bathroom, don't take the mobile phone with you, so that you may not be able to perceive if there is constipation and you are straining. You will be fully engaged in the mobiles. So never take paper or mobile phone in the bathroom. Just like having food is important, passing motion is also important, and due care should be given for that. Complications, pain, bleeding, infections, and fistula formation, that is recurrence of fistula. All those are the things. Fistula, if we miss the tract, the original fistula can reoccur. If the inner tract is left behind, there can be a step down fistula or a new fistula occurrence. And if the internal part, everything is taken care, and during curating the external part is not fully taken care, then a sinus formation develops. There are a lot of modifications of the lift procedure, what I have shown, like there is something called submucous ligation of the fistulous tract. Then there is something called biolift procedure, where bioprosthesis is kept there. And what we have shown, this surgery we have shown, that is coring out. It is fistulectomy, that is coring out of the tract, and repair of the external sphincter, which I usually prefer to tell like AWR, anal wall reconstruction. You can cut the external sphincter, but just repair it and make sure that the entire fistulous tract is taken. Thank you, all of you. Delorme's procedure for prolapse rectum. For prolapse rectum, there are a lot of perineal procedures, and there are a lot of abdominal procedures, especially laparoscopic procedures. This Delorme's procedure is a perineal procedure. The definition of Delorme's procedure is, it is a mucosal sleeve resection. It was advocated by Edmund Delorme in 1900. It involves the stripping of the entire mucosa of the redundant rectum, and the muscle is plicated. It is suited in patients with lax sphincter, especially old age, because in old age the sphincter may become lax. So if you plicate, you will get a good sphincter tone. It is also suited in younger patients, because laparoscopic procedure, as already told, it can lead to impotence. So both the ways, even if the patient is young or even if the patient is old, Delorme's is a procedure. Anesthesia is spinal anesthesia or general anesthesia. Bowel preparation is not required for the patient. Give Gerbisa some 3 tablets a day prior. Antibiotic preparation just at induction. Position is a lithotomy position, and for any, just like any perineal procedures, put a pillow beneath the buttocks of the patient so that it juts out. Delorme's procedure is suited especially when the prolapse is coming out like this. Just like what the prolapse we saw, this procedure we will not be able to perform there. And one more question was there, like if there is vaginal, that is uterine prolapse and all along with, if hysterectomy, laparoscopic and pelvic floor repair is done initially, then rectum will not come out. So if the prolapse needs to be done initially, or else do a staged procedure. Or if uterus is tackled laparoscopically, tackle the prolapse also laparoscopically. once under anesthesia, the prolapse will be inside. Just with a sponge holding forceps, we can pull it out. Then submucosa of the prolapse segment instill with adrenaline 1 in 2 lakhs, or else just take lox adrenaline also. It may give us some post-operative pain relief also. Then circumferential incision is made 1 centimeter distal to the dentate line. It is made all around and we enter into the submucous plane. The dissection should be very slow and gentle. Even if you are seeing small bleeders, just do a bipolar at the same point of time. One of my assistant is holding the bipolar and standing by the side of me. Whenever bleeding happens, it will be taken care at that point of time. Otherwise, after some time you will be seeing the entire thing is, the blood is pouring out of the entire prolapse segment. So after that, an Alice forceps is put all around, all the 4 corners, and in between we are shaving off the mucosa from the muscle layer along the plane of saline adrenaline infusion. Small bleeders can happen at that point, which we can cauterize at that point of time itself. So this sleeve is taken all around, so that, and finally we will pull it out and manually take as much of mucosa as possible. This movement should be there, what you are seeing now. It should be pulled out and maximum mucosa should be taken. Only then, with the pull of the mucosa, this repaired muscle, everything will go inside. Then with the help of PDS or with the help of vicryl sutures, we can plicate the muscle, just like we plicate the bladder in case of cystocele. What is advocated by DLOM is take some 16 suture materials and put 16 suture materials all around. Instead, what we can do is just take one at 12 o'clock position, tie it, then take another at 6 o'clock position, tie it, then go to 3 o'clock, then go to 9 o'clock, then go to in between. Like that all around we can do. As we tie each layers, gradually this plicated muscle will move inside. If we put more pressure, the muscles will get torn also, so gentle pressure should be given. Now the above sutures are over and I am going somewhere around 7 o'clock position. We are putting the sutures. Likewise, we can put 16 sutures all around as much as possible, so that gradually this muscle is going inside automatically. It is not pushed inside. It has to go inside automatically. That many number of sutures we have to put. And that pull happens by the initial pull of the mucosa and removing the mucosa as much as possible. Now it is the resection of mucosa and anastomosis. You have seen a large amount of mucosa, that is to the depth we have mobilized. If we cut it, it is very difficult to get the mucosa in the depth. So cut 1/4 at a time rather than cutting the entire sleeve altogether, and suture it. Then cut the other quarter. Likewise, the whole sleeve can be divided. And suture it with a vicryl rapidly dissolving vicryl sutures. And thus the procedure is complete. I usually used packs at initially, but now in perianal procedures, since the last conference, now I am not using any pack, because just keeping hemostasis and just putting one gauze inside, because it is very difficult for a patient to tolerate a pack. We can imagine if something is kept there and stay overnight with that, it will be a horrible experience. So as far as possible, try to get good hemostasis and don't rely on pack. Just put a gauze soaked in lignocaine and remove it at the earliest. I have already told this, that is, it is favored in elderly, it is favored in younger people also. Thank you all.
So normally how many rows of stitches you take?
Usually it comes to 16.
16?
On 1-6. Because I go from 12 o'clock, 6 o'clock, then 3 o'clock, 9 o'clock, and each in between.
And then in the last you suture the two mucosal edges.
That mucosal edges, I take 1 quarter itself, I put some 3 or 4. Like that, those also will come altogether 12 numbers. As required, we put it. Usually don't. Usually no. Perineal exercises I advise if I don't go ahead with the procedure. If we do a procedure, then rely on the procedure.
Hello, and now we are switching to important topic like fistula in ano. And the pathophysiology of fistula in ano will be covered by Dr. Jiten Chowdhury. Please.
Yeah, hi, good evening everyone. He is managing. Yeah. So, I'll be talking about the anal fistula, and it's basically my topic is restricted to etiopathogenesis. I'll just restrict myself to the etiopathogenesis of anal fistula. So, what is a fistula? Basically, a fistula is an abnormal tube-like connection that forms between two organs or vessels that are lined with the epithelium. So, types of fistula can be described by their location. So, what is an anorectal fistula? In an anorectal fistula, what we see is an abnormal communication between the skin and the perineal skin, and the tube is basically lined with the epithelium. It has got an internal opening and it has got an external opening. Whenever we drain any abscess, we basically achieve cure in almost 50% of them, and rest of the 50% of them develop a fistula. So nowadays many of the surgeons are advocating primary fistulotomy if it can be done. Primary fistulotomy in case of an anorectal abscess. This thing we can go ahead with the fistulotomy if this thing sphincter involvement is not too much and we are very sure about the internal opening. So the fistula in ano basically originates in the infected crypt and it tracks to the external opening. It can have multiple branches like we saw today Dr. Rate operating. So little bit about the anatomy, although it has been dealt earlier. What you see, this is a levator ani. This is the pivorotalis muscle. This is the external sphincter. External sphincter is basically divided into superficial part, subcutaneous part and the deep part. And in between the two sphincters is the intersphincteric space. And what you see is this is the longitudinal muscle, or it is also called as conjoint longitudinal muscle. So now coming to the anal glands. Anal glands are basically around 6 to 8 in number in each individual, and ducts open in the anal crypts on the dentate line, and infection leads to abscess formation. This is the theory of cryptoglandular origin. So for any abscess to develop or for any fistula to develop, the pathology starts from the anal glands. The infection of the anal glands leads to an rectal abscess, and chronic process of it is called as in fistula in ano. So dentate line is surrounded by longitudinal mucosal folds known as the columns of Morgagni, and the lower ends of this Morgagni at the dentate line is the opening of the anal crafts. So a little bit about the perirectal spaces. What you see, this is the upper slide. Here is the peritoneum, and just below it is a levator which is seen here, and this is the supralevator space. And what you see here is also called as an ischiorectal space or ischioanal space. Rest of the spaces I'll be dealing later on. This is the lateral view. What you see is a retrorectal space, retrosacral space, supralevator space. The three spaces are two spaces on the posterior to the rectum, and here what you see is a levator ani, and superficial postanal space is in here. I'm just running out of the slides because I'll be dealing with them later on also. So now coming to the ischioanal space. Ischioanal space is formally called as an ischiorectal space. It is basically a wedge-shaped or diamond-shaped space on the lateral side of the anal canal. Middle it is bound by the lower rectum. Above is the levator ani muscle. This space is what is a ischiorectal space. So above is the levator ani, middle is rectum, base is formed by the perineal space. Anteriorly is urogenital diaphragm, and posteriorly is sacrotuberous ligament. The space is basically covered by large lobules of avascular fat, inferior rectal vessels and nerves. So the point to ponder here in an ischiorectal abscess is that most of the times the abscess is not seen on clinically because it is bound by a septum called as a Milligan septum. Unless until the ischiorectal abscess punctures this Milligan septum, it is not felt, the tenderness is not felt. So patient may have symptoms, but from the outside you may not find anything. So you have to have a very high suspicion that the patient is suffering from the ischiorectal abscess. Another thing is the practice of dividing the loculi while we are operating the ischiorectal abscess has to be shunned, because in that case we are going to damage the inferior rectal vessels and nerves, which can lead to paresthesias and it can lead to bleeding also. Perineal space have been basically perineal space is this space just below the Milligan septum. Milligan septum divides this whole space into the ischiorectal space and the perineal space. This perineal space, the abscess is very well seen. It is quite fluctuant, and the patient presents with the painful swelling in this region. The another space of some significant importance is the intersphincteric space. This is area between the internal and the external sphincters. Boundaries are medially internal sphincter, superiorly supralevator space, laterally external sphincter, and it contains basically the fat and the connective tissue. But the thing is, the most of the anal ducts traverse this space, and that is why it is the region of high incidence of fistula is found in this space. The submucosal space is found submucosally, and it is located above the dentate line. Laterally, the lateral boundary is found by the lateral anal sphincter. Above is continuous with the submucous of the rectum, and the contents are the internal hemolytic plexus. So whenever we are dealing with the submucosal abscess, it has to be dealt in the submucosal plane only. There is no need to cut from the outside. It has to be dealt from inside only if we are very sure that it is a submucosal abscess. So another space of importance is a deep anterior anal space, which basically is joined the left space, deep anterior space joins the right anterior space, and is one of the reasons for the formation of the horseshoe abscess. The space lies anteriorly covering the urogenital triangle, and the boundaries are transverse perineal membrane anteriorly, superiorly levator ani, inferiorly superficial external sphincter, and it directly communicates with the other side. Two spaces more which are of importance are superficial post-anal space and the deep post-anal space. Just below the rectal space, you will see this is the anococcygeal raphe. So just anococcygeal raphe, basically this is the anococcygeal raphe. This divides the space into superficial post-anal and deep post-anal, and this is the levator ani muscle. So this abscess forms the supralevator abscess. This is the deep post-anal abscess, and this is the superficial post-anal abscess. This space is also known as the retrosphincteric space of Courtney, and the boundaries, as told earlier, are basically the inferior part of the levator ani, and it has been explained in the diagram which I have already explained in the previous slide. So supralevator space is located between the levator ani and the peritoneum. The boundaries are rectum on the medial side, laterally obturator fascia, superiorly peritoneum, inferiorly levator ani. I think I'll just cross this slide also. So what happens whenever there is an anorectal abscess? Their anatolis is basically painful condition, and once either this abscess drains and the patient gets cure of the abscess, or sometimes the infection persists and forms the fistula tract. So coming to the pathophysiology of abscess, whenever there is a blockage of the anal glands, whenever there is a blockage in the glandular secretion, it causes stasis, and the stasis causes infection and separation, and which leads to again the abscess formation. And the cycle goes on. The abscess formation again causes the anal crypt obstruction, unless until whether either we operate or the nature takes cure of the abscess. So basically, as told earlier, anorectal abscess is basically an acute condition, whereas a fistula is a chronic form of the abscess. A patient may have both a fistula and abscess may coexist, and may be associated with atypical internal openings and multiple tracts that result in a complex suppurative process. So how is the horseshoe abscess formed? The typical horseshoe abscess or fistula is infralevator in location, and most of these originate in the infected anal gland at or near the posterior midline on the dentate line. The infection spreads caudally to deep post-anal space and from there into the intersphincteric plane. Since the deep post-anal space communicates with the histiorectal foci, an abscess may spread circumferentially through this or intercommunication spaces, leading to the horseshoe abscess. In neglected cases, multiple external openings may be present in the peritoneum. So as told earlier, most of the anal glands are located in the posterior position. If the internal opening is dealt properly, as advocated by the lift procedure, that is the basically way to deal within a horseshoe abscess. Rest of the tract can be either curated, or it can be, if the tract is mature enough, we can go for the laser procedure also. So now coming to the Parkes classification of the anorectal fistula. See, what you see on the outside is an extrasphincteric tract where it is crossing above the anorectal ring, and what we find is there is no internal opening below the dentate line, and there is a opening in the anus from the outside. Suprasphincteric tract is basically the opening is at the dentate line only, but the tract first traverses and cover basically above and then courses down. Transsphincteric fistulas are also basically transsphincteric fistula is sort of a suprasphincteric, but it also courses both the sphincters, internal sphincter and the transsphincteric and the external sphincter. Another abscess is the intersphincteric region. So these are the basically 4 classifications of the given by the Park. Another classification which we normally see on an MRI is a radiological classification, which is called as a St. James classification, and it has been called as a grade 1 is the intersphincteric fistula, and grade 2 is an intersphincteric fistula with horseshoe extension, and Grade 2 interstitial fistula with intersphincteric abscess. Grade 3 is transsphincteric fistula, and grade 4 is transsphincteric fistula with ischioanal abscess. This is how the radiologists basically describe their radiological findings on MRI. So coming to the etiology, there can be multiple factors. It is commonly seen in patients who are immunocompromised, like if they are suffering from diabetes mellitus or if they are suffering from HIV. History to that region can also lead to formation of a fistula nano. Certain inflammatory diseases like Crohn's disease is known to cause fistulas, and previous radiotherapy to the region is also one of the responsible factors. The clinical features are recurrent. In the patient, we may find that the patient is presented with either the recurrent abscesses, or they may present with discharge which can be their external opening discharge, which can be seropurulent, or it can have a discharge in the form of an abscess. On examination, an external opening on the perineum may be seen, and this can be fully open or covered by the granulation tissue. A fistula tract may be felt underneath the skin on digital rectal examination. So clinical examination, as told earlier, is of very paramount importance. This not only tells us about the when we palpate that where the tract is going, where is the internal opening, and how much of the internal sphincter or the external sphincter is involved. So in cases where we are not able to find the tract after certain time, that means the tract is going deep inside and there is involvement of external sphincter more than 30 to 50%, and then we have to be careful while cutting the sphincters in such cases. So now coming to the Goodsall's rule, it's basically it says whenever the perineum is divided by a transverse line and the anterior fistulas basically open in a straight line, whereas the posterior fistulas, they curve and open posteriorly at midline at 6 o'clock position. Although there are certain exceptions, like if the fistula is 3 centimeter away from the anal verge, then it doesn't obey this Goodsall's rules. Not only that, Goodsall's rules holds true only in 60 to 70%, and sometimes in 30% patients, we don't see that the fistula follows this rule. Some interesting facts, like in cases of tuberculosis, we may find multiple complex fistulas, or this is also seen in Crohn's disease. Now, any inflammatory bowel disease can lead to a water pot perineum. So how to diagnose? There are various modalities. Earlier we used to do an externofistulography, but nowadays MRI is the gold standard to diagnose a fistula in ano. Some people also use dynamic ultrasound. They inject hydrogen peroxide through the external opening, and then they see where the hydrogen peroxide bubbles are going, and that is called as an endoscopic ultrasound or a dynamic ultrasound. So there are certain special considerations, like in Crohn's disease, we can see the fistula formation in up to 43% of patients who suffer from Crohn's disease. So in patients of Crohn's disease, we have to be very careful. We should not just go after the fistula and cut it. The disease has to be brought down. Most fistulas, we use infliximab therapy, and if required, we should first go for the ceton. Cetoning is advisable rather than any radical operation for the fistula in ano. I think this is out of the purview of my topic. So take home message is beware of Crohn's disease, tuberculosis and leukemia. There is a need of culture of pus, because if we find there is a anaerobic organism, like if the organisms are isolated on culture are from the gut, then there are high chances of recurrence. Whereas if the organism is staphylococcus or streptococcus, then most likely the source of infection is from the skin. Those kind of fistulas basically heal very well, and there are less chances of any recurrence. Point of incision for draining an abscess should be as close to the anal verge as possible. So this is against what Dr. Mrinal told in the theory of pilonidal abscess. Whenever we are draining a pilonidal abscess, the incision should be away from the midline. We should take a lateral incision, but in cases of fistula, we should try to be medial, as close to the annulus, so that if any times recurrence occurs or if a fistula is formed, the tract is a small tract. So beware of post-anal abscess, high rectal abscess, and fluctuance is an advanced sign which is mostly not seen in early cases of ischiorectal abscess. Whenever you are operating a fistula nano, we should always widen the external opening for draining the tract. After, even if we curate it well, we should always leave the opening wide. That's it. Thank you.
This was the very much elaborative discussion on the pathophysiology, etiology, and some points of interest. Very, he has dealt with in detail. Now there are 3-4 important aspects as far as this is concerned, but there is a new modality of treatment. Again, pioneer is Dr. Chute sir. And what he is going to talk us, the endoscopic management of fistula nano. You all heard about VAPT, that is video assisted fistula management, but this is different than that, endoscopic management, and along with that he will be talking on D&C fistula. I call upon Dr. Chute sir.
Are you tired? If you are tired, let us have break for tomorrow then. Continue. Oh, good energy. At least good energy to listen. Fantastic. Anyway, something different, I am little, not so adventurous man like, most of the people who keep on cutting. Let us have this.
Sir, take the mic in front of you. Mic.
Hello, yeah. And this, I am not that brave. So I thought, why we can do fistula without cutting anywhere. My laparoscopic colleagues, they can make some keyhole openings. If they require 1, 2, 3, 4, they can make it. They can make it, and they keep on doing whatever they want into the abdomen. So let us do something like that. We can have a small opening into the fistula and keep on doing same thing. So this is the basic thing for the fistula surgery. You should not give pain to your patient. If you give pain, you will lose the patient. Mind well, first of all, you dig down your fistula to the depth, and later on, if recurrence occurs, your patient is going to abuse you. That's why fistula surgery, you excise to the cure, I agree with you. Big wound, big pain will be there. Recurrence, definitely abusement will be there. And along with that, if you have incontinence, legal action will be there. So all these in sequences. It is not, nothing very serious, but you can face that. Patients, I'll not tell you story, but this is, one of my friend who was jailer, ACP. I operated fistula. He had a huge fistula, and I used to call him for dressing. And every time he will bring 4 of his, Sipahi with him. They used to come and hold him in operation theatre. I used to clean wound, pack it and send him back. After 3 or 4, 5 months, he healed totally. And I said, you need not to come tomorrow. Thank you, doctor. But I require help from you. I said, what help? We have already, wound is healed now. No, not that way. See, sometimes some notorious, prisoner, they don't, open mouth. So, this treatment is 3rd degree treatment. Why don't you come and give there, So, all those people will start opening mouth. Day in which he said me, I said, I am doing crime. This is certificate given by my friend to me. So I thought not to give this burning problem on the colder ice. So let us have something, think about it, a painless treatment for the fistula. And a treatment where you use scope, but for the small fistula, you don't have scope for the scope. If fistula is smaller, if it is straight and having, just transsphincteric with intersphincteric inversion or subcutaneous, you need not to require any endoscope or anything. What do we do there? We dilate the external opening, go up to the internal opening, curate, put your finger on that, curate underneath. And this curate will be totally, completely, because it is under the finger, you know what you are doing inside. And once you do that curating, you are going to do dissection of the flap also underneath for closure. So what we do after this dissection, one tunnel will be there, which is again like a fistula only. But there is no epithelium now, no discharge will be there. This tunnel of the fibrous tissue, we pack it with collagen. And with packing collagen, we take this collagen to the internal opening. And while suturing internal opening, we put this collagen, one stitch also in that. So collagen remains inside. And collagen, what it gives? It promotes the fibrosis. That's what it happens. And I feel that is what we do for simple fistula. That is called simple fistula. I'll go into definition, so many definitions are there. Somebody says a fistula going from internal to external, palpable under the skin, and only one internal or external opening. All these, definitions are given. Only one factor you remember on that. If this fistula is covered by 1/3 of the or 30% of the external sphincter, then it will be called as a simple fistula. That is the only crux or key point. Clinical examination, I think you are knowing. And what treatment? Fistulotomy, fistulectomy, they are gold standard fractures. And this treatment is going on last 1 century. And whether it is a lay open, put a fistula directly, cut open. It is a lay open. If fistula is big tunnel, you excise the part and make a marsupplyization. So this is, marsupplyization, and these are the few methods. Another is a fistulectomy. You totally excise it. In this what happens? You excise not only a external sphincter or the fistula, but you release the fistula by the side of the external opening. So what your assessment is there for 30%, that goes to 40-45% automatically. Then what you think about it? Why not to suture it? So if you suture it, this outer skin wounds may heal quite well, but inside if it doesn't heal, then this fistula continues for months together. And this is the comparison between the DNC fistula. 93% of our DNC fistula healed in 3 weeks. And you do the fistulotomy, fistulectomy or fistulotomy with, they are going to have 4 to 10 weeks. So these are the periods for that. And incontinence, if you say, not a major incontinence, like a small fluid occasionally, or flatus that which we don't consider flatus incontinence here in India, but this occurs in about 12% cases. So all this we should keep in mind. And I'll not go in detail again those figures, because I thought I will bore you a lot, but no, I'll think I am got bored now. So fissulotomy is not longer than 5 centimeter. Why? I'll tell you. Because if I want to put my scope 5 centimeter, you will not able to see much. That's why that limit is given. What we do for fistuloscopy and this thing, we have started last 2003. We have started this fistuloscopy and this wonder. First we started using with operating element of the cystoscope, all those PCNL instruments. Then we had Hagar's dilator. I'll tell you for what everything is, and curettes of the different sizes and shapes that you have. And why this single, blade scope curettes? Because you know that how much long fistula is there, you don't know. If double curettes are there, up to that strong, this thing, your curette will go inside, not beyond that. These are the curettes, not scoops, because what you have seen is a scoop. That scoop will just, granulation and this thing, just scoops. But deep things, this will cut it. This will cut and scrape it. Curettes are meant for scraping the fistula, okay? This is the good term for that. Endoscopy strategy will be there. We don't want to dilate the fistula now, if it is long. You dilate the external opening at skin level only. This fistula opening, how much you should do? You should do about Hagar's 6 number. That is the number where your operating element of cystoscope or hysteroscope, it will give at least 1 mm around it, means 2 mm broader than your scope. Why that should be required? Whatever fluid goes inside, that should come out. Otherwise, that will balloon fistula if it doesn't, have this thing. So that we want to have little larger. And once you put your scope inside and start, we use irrigation as a saline, and certain pressure is kept in saline. That will depend how much you are seeing inside, whether you are seeing through the pus, whether bleeding is there, it will depend upon the pressure. So once you go inside, fistula will start opening itself. So you need not to have, do anything else. As it shows the way, you should go inside. If it is not showing way, don't go inside. Wait there. Increase pressure if it is not opened, okay? So that should be the visualization. Now what we will do, see, this is the fistula inside what you are seeing. This is a velvety fistula. You are seeing granulation. Now once it will open, then I will go slowly inside. Now you are seeing that you are going deep down, and this fistula you are seeing some small abscess, so big cavity is there, then this, and you keep on going inside, and this fistula, you will see whether any path is there, any branch is there, and you can mark that branch. You reach up to the end of the, this is supraelevator, puborectalis muscle in between, and now you are going above the sphincter, and here fistula will end, okay? So from there now you will be coming back, and not only that, you will be seeing again same fistula, how it comes out, okay? So this is all how you have to go inside till your view is blocked totally, and then you come out. While coming out, again you should inspect the fistula. These are the usual, some sort of epithelium. What you see is, this is a pus plus epithelium. This is a fibrosis there. Tentacular some fistula is there. Don't ask me why tentaculars have occurred, because I don't have study about it. A few cases accidentally I got it, or polypoid tissue can be also there. This is, you are seeing internal opening. As you see here also I put it, and I try to see internal opening for all. And you will see fistula tracts. These fistula tracts, what you are seeing, these are round but irregular. You are seeing 2 fistula tract in the tract, that means branching is there. Second, other picture what you are seeing, that is irregular round tract. Now here you can find it. Early one picture is there for comparison, that is round but irregular. All remaining 3 pictures you are seeing on that side, they are oval. almond shapes, oblique. Why? You know that these are the fistula in the two circular tubes. That's why you are going to see this type of fistula. So we can label, if you are seeing oblique fistula or almond shaped fistula, that is intersphincteric fistula. So we can classify it. We have seen now hundreds of the intersphincteric fistula, they are oblique only. And I can show sometimes you can enter from the external sphincter fistula, extra sphincteric to intersphincteric, you can see the change. Now this is the fistula where you can see, this is you can say puborectalis, this is external sphincter, this is rectum, same thing what you get as Dr. Ganga Shankar described you, supraelevator abscess. These are the sphincter you can show you by the light source. These are the intersphincteric tag going up above, close to the rectum and not going beyond 6 o'clock. That's why these are intersphincteric. This is intersphincteric tube. Now you can see how crescentic shapes they are there. Pus was there, that's why you can see some problem. They will get washed and after that you can see better. But still I wanted to show with the pus. See, these are the oblique almond shapes. These are all intersphincteric tracts. And they are the most difficult tracts to treat. Let me tell you that also. Okay? Do you understand now? Intersphincterics are oblique tracts. All remaining extrasphincteric are irregular but circular tracts. They may be subcutaneous, they may be extrasphincteric or anywhere else. So you can see we are going up to the depth. Again same, we have reached to the wall and then we are coming back. Okay? So this is what always fistula should be examined. Now complex fistula in abscess, in one case we will take for description. I will give one example. I can talk a lot about it. How each thing should be treated, how extrasphincteric, how intrasphincteric, how circular fistula, which is called, all that can be treated in different way. But if that will take a lot of time and you will say this fistula is encircling us, we should stop better listening. So but before that I will give one example of this case. She is a 31-year female girl. She is a dancer and she had a huge fistula with abscess. And somebody said 50% your buttock should be removed and then they will be healing next 6 months, and scar tissue we don't know. She said I will lose my dance, because dance always depends on shape of the part where they have to move a lot. So that's why she said no. Then somebody told her this person does without cutting. So she came to me and she was operated earlier 1 year back for some fistula problem, and after that I saw her 2018 sometimes. Investigation we did as a routine, that MRI I repeated what she had, other thing, and she has own thing fistula. This is her fistula was there. You can see here. This is abscess totally, extending to supraelevator region, then going intersphincteric down, behind it again posterior. All these fistulas were there earlier, plus abscess was also there. So that was the biggest challenge. And now how we should do endoscopically. So we started doing procedure, again detection of the internal opening, dilatation of external fistula, fistuloscopy and other things. What we did it. And we closed the internal opening. This is, I told you already how external openings we dilate it and use for a fistuloscopy. This is the fistuloscope what we use. This is histoscopic operating element. We use 4 mm lens, 0 degree for fistula. It is like a urethra what you are seeing inside. If you have lateral opening, you can use 30 degree also, because that will give better picture. So this is the main picture when I was operating. You can see here. This was one, this fistula opening. This was for abscess, I opened it. These 2 opening were there. We removed whole of the pus from here we curated it, and then we started doing scopy. This was anterior fistula, then it was going intrasphincteric fistula, this was going posterior fistula, and this was coming directly to posterior. So I'll show you all that. So this is, see, you can see anterior tract and going beyond the midline. This is posterior tract going again beyond the midline. This is a post total going right from the up to the posterior line. And then we have curated all these fistula and these are deep abscesses. Now see, this is because of methylene blue what we injected, and we curated totally. So curating, is a very good thing. Till you get gritty sensation, you keep on curating, and it is best thing when you are curating in the abscess, because that is soft, supple tissue. It comes out very easily, and now you are seeing that. Okay, are you seeing here? Fat globules are floating in the kidney tray. When you remove pus and muck and infected granular tissue, that will settle down the saline. They will not float. Only once you remove periphery totally, then fat globules will come. That, and you are seeing kidney tray is full of fat globules. So that will give me answer that total curating has been done. See, this is the what fistula you can see. Now white fibrosis, and you can see starry structure in that. Starry structure means I have gone up to the fat level. That gives starry shining. Okay, see now, some starry structures are there. That gives really, good pleasure to listen, watch this, star structure. So now procedure is not over. Now I know that so much big tunnels I have created, so much big cavity I have created. What is to be done? Now we washed collagen. Collagen comes in, hard collagen, which is in isopropyl alcohol. We have to wash it at least 3 to 4 times. Then it becomes soft and supple. And then and this is substitute for the skin, what our plastic surgeons are using. And it creates fibroblast if it doesn't come out. This is, fibrotic fistula, like a healing. And then this is the collagen, this is what we are preparing collagen. We are washing, you can see that washing of the collagen, and then after 3 or 4 washing it becomes soft and pliable. Pliable means you can put it anywhere inside. See, this is the, I think 25 by 35 centimeter collagen that we can use it. Now how we should use it? Now you see that I am doing from this side because I have to give some scope to camera, and this it is going other side, and we are packing there first and then coming out and then pack it there. Okay, so this is anterior, we have closed it. Now this is, you are closing posterior space. Can you see that? Posteriorly whatever space we have created, that we are closing there, and this collagen will definitely act as a preventive matter for no collection inside. No dead space will be kept there. Okay, so this is what intrasphincteric tract will be closed. This is, you see that intrasphincteric tract doesn't go beyond 6 o'clock because that opens there, intrasphincteric space is there. Okay, once it goes there, it will go into the internal opening also. So while closing internal opening, again we will take this fistula, collagen there. So this is what, one of the place what we got it here was, you are seeing pus is there in here, and inside as you go, now I will show you, there is a fistula above the supraelevator space or above the puborectal. This is what puborectal is you are showing here, and this is supraelevator space. In pubococcygeus there are 2 fistulas. This fistula I was not able to communicate with our curates. So I thought I'll use some laser. I have laser, so no problem with that. So see, this is, laser use what we are doing here. Otherwise you have seen whole fistula, other sides are clean. Now that 2 small fistulas inside was reduced. I use ureteric catheter for seeing laser inside, and then we see how we can remove this laser. This is air bubble, and once you get this, you have stabilized your fistula, scope, and then you can push it fiber in the fistula tract and start your laser or press the pedal. You are seeing that, and this is the diode 980. That's why as it coagulates tissue, it will not leave, it will take it with it. So it does job of the curating. So you are seeing now, once this coagulated tissue is stuck down to fibers, now how you will get it, these fibers at all. I need not to remove anything from that or wash, because right from the muscle this will be removed. See now, muscles are open there, and whole tissue has been removed. Okay, this is what you are going to see. Supralevator fistula is into pubococcygeus muscle. Okay, so you are seeing puborectalis muscle, pubococcygeus muscle, and fistula in that. So this is what internal opening. Actually, I never wanted to show you. See, this you can close it anyway by putting a bursting suture, and that will give total closure of the fistula. And now this is why we are, this is abscess which was drained. We put collagen inside plus a Foley's catheter and inflated that. Here all collagen was filled. This was again filled. So all these things, we were very happy after doing this surgery. Now this is after 3 weeks. You seen this lady, very small opening was there. Now no opening was there, it was healed. And this was the old scar of hers, where we have opened the abscess. So abscess or fistula scar, that is the minimum. So what I promised to her, I'll keep her buttocks intact. I kept my promise. This is after 4 weeks. No, scar is seen. So this is what happens, endoscopy results of the collagen. We have done 63 cases of this type, abscess with the fistula on this thing in 3 years. Recurrence in 9 cases we had. We did similar treatment on request of patient. They said, we want same treatment because they can go within 1 or 2 days home and they can repeatedly visit. Washing is done always by putting infant feeding tube and wash, so no pain will be there. Washing we do with the saline only, no irritant substance. Second thing, if collagen sometimes it comes out, yes, if it comes out, you have to take it away. And maximum collagen comes out from the intersphincteric tract, which is very difficult to heal, but it comes from that out. So we had, problem. Once you have put 2-3 large, collagen pack, if one comes, then you have to remove totally. So whole canal used to be removed, vacant now. And then it started healing little late. So what we started doing, we made 10 pieces out of one. And we started packing it. Even one comes out, we remove small piece. So that started healing again back. So this has happened. Video assisted fistula is a very different, because that will not show you this picture, because their optic is 1 mm. That too, it is a fiber optic lens. Fiber optic lens gives very limited vision. I am not saying bad vision, but limited vision. And I'll show you some of the very good results from the 68 patient from the Poland hospital they have treated. All fistulas. Simple fistula, complex fistula. Simple fistula healed, 30 fistulas, they healed 73.3%. And complex fistula 39.4%. This I predicted when WAPT was published first time in 2011. I sent a letter to coloproctal, techniques in coloproctology, that this procedure will not be useful. 2 things are there. Your WAPT doesn't suggest how we should go in curved fistula, that is one. Second thing, it is using radio frequency which gives lateral damage, and lateral damage will cause necrosis after 2.5 months, and that time again discharge will start. So that will not heal again. So this all we are given, and that was also published after that. So Wherever now WAPT is published, this my comments also published. So there is nothing. That time also we said, this is opinion at first sight. You know now I need not to give opinion. You can make your opinion that healing is very fast and curating of long curved fistula. Now you will say, if WAPT has got problem, what you do it? Yes, we get problem, we solve the problem. You give me 10 problems, I have millions of solution for that. No problem. Where curve goes, you open your fistula there, like a laparoscopy man. Open there, that makes straight, and go from there inside. You can go to, for example, I'll tell you, if intrasphincteric fistula is there, usually people say approach through the internal opening. Yeah, fantastic. But what we do, we palpate the intrasphincteric fistula at 6 o'clock outside the anal verge. We open there and we go in intrasphincteric space. From that, we put our scope, curate everything, pack it there, and we keep that opening outside. We close internal opening. Then what happens? We can always repeatedly wash this internal fistula also, and that heals. If you are doing any surgery like toxip and other thing through the internal opening, you cannot wash it or clear it. So sometimes axial fistulas are there around it, around the rectum. Space may be one, but you cannot, my curate cannot go reverse way or lateral way. So these are the curates we have created. This is simple curates which are used for DNC, what is called a suction curate for abortion. We cut this curate in two and we have connected our rise tube. So flexible curate we put it. It can go around rectum anywhere and we can touch it. But mind well, while you are curating intrasphincteric fistula, your one hand should be in the rectum. See that it is not abnormally sucked inside. That time you have to reduce power of suction. So this is must. Otherwise sometimes like obstetricians, gynecologists or obstetricians, they suck your intestine. You may suck rectum also. Please don't do that. You put your finger and keep adequate suction there, so you will curate that thing. This flexible curate, I will not go through. That's okay. That's nothing to be shown in that. A patient of another complex fistula with some discharge and other thing. What sclerosions also we use when fistula gets removed or when collagen comes out, we inject collagen inside. Perineal abscess, another thing we do similar things. Complex fistula we do same thing. And conclusion, if possible, without any cutting, fistula should be treated. No painful dressing should be given. No painful wounds should be given. Healing in the shorter period should be managed. Patient can go work in 2 to 3 days. He can come for dressing. Even if it heals after 10 weeks or something, he comes regularly for dressing for after 3 to 4 days. And he can attend his work. Patients are happy and well accepted. You practice, and you will get good practice. Thank you very much. I am sincerely thankful to organizers, you, particularly Dr. Prakash Gatore. He has given a lot of Prakash today, so thank you very much.
Now we are coming to the flag end of this program, and in fistula, apart from fistulotomy and fistulectomy, you have heard just now what is DNC fistula, what is endoscopic fistula management. And now there are some established techniques also, like warped, lipped, and where we can put that set on. So for that, before Dr. Rahate starts, I want to announce that tomorrow we'll be having examination at 7 a.m. sharp. You have to gather over here only, na? And that exam would be lasting for 45 minutes. Okay? 45 minutes. The questions will be displayed on the screen itself, and you have to write the answers. That will be a multiple choice question type examination. And once that is done, then it will be followed by the interviews. So those who are enrolled for this workshop, will kindly note that they will be here at 7 a.m. After the examination, they can have a breakfast. I call upon Dr. Rate now.
Yeah, please don't be late tomorrow, because the questions will be displayed only on the screen, and you will be writing down the answers. So those who are late, the questions will not be repeated. So you will have to be here. For audio-visual people, we will start tomorrow at 7 o'clock. Okay? So, yeah, do's and don'ts in ceton therapy. The age-old ceton techniques are still practiced successfully in the treatment of complex anal fistulas. Many variation in material and techniques are described in the literature. A ceton can be of any type of foreign material inserted through a fistulous tract. But the recent guidelines, they are against the cutting ceton, that is Shar Sutra. Because a long-term study, almost 18 years of study has come up now with more than 8,000 cases, and it has suggested that there will be some sort of incontinence to these patients who had cutting ceton. So we will talk mostly about the draining ceton, its indications. So various materials are used. It helps in draining pus and controlling the local sepsis. It stimulates the fibrosis, and it will delineate the fistula tract better in second sitting. A tight cutting ceton promotes slow transaction of the external sphincter muscle, and therefore it can lead to pressure necrosis and minimal separation of the cut ends and discontinuity in the sphincter. Long-term ceton drainage is simple and efficient treatment procedure in treating the high anal fistulas of the Crohn's disease. There are n number of ceton materials, including rubber band, elastic ceton, Penrose drain, braided nylon, then even the Prolene suture, the suture, stainless steel wires, and whatnot. So, lot of things can be used. The insertion of a ceton is not always easy. The insertion is especially difficult in high complex because they are curvilinear path, and these grooved Locard mammary probes have been used to probe fistula tracts and help ceton insertion. There are definite probe sets available, particularly with the Ayurvedic people, but they can cause this type of false passages, and therefore the guidelines, they don't suggest use of the probing materials. The variation based on the mechanism of action of ceton, it helps to stimulate fibrosis as we have already talked about, and cutting ceton inflicts unnecessary pain also, and it is an uncontrolled method of dividing sphincter. So how to start with this ceton treatment? It is important to determine the level of fistula, involvement of the sphincter, whether there is high or low transsphincteric, what amount of local abscess and local sepsis is there, and the etiology of the fistula is to be decided. Then currently this Crohn's disease have a higher risk of recurrence because it is entirely a different ball game and treatment. Once the perianal sepsis is controlled with loose cetons, the consideration should be given for treatment of biological agents such as infliximab, and the newer type of biologicals are also available. Once the disease and sepsis is under control, this patient can choose between either long-term loose ceton or sphincter sparing surgeries. So that long-term use of this loose cetons can also be done. So the most prominent use of this draining ceton is pregnancy. As Dr. Gangashekar has said in the morning, that during pregnancy there is lot of pelvic congestion and many patients, they go in for the anorectal pathology development. So because of this pelvis congestion, there is high recurrence during that pregnant period, and therefore this set-on prevents recurrences. The most important point why this particular therapy is used in pregnancy, because of the chances of increased recurrence, and every time you are going to give some medication and that medication is going to alter some problem with the fetus. So it is better now to put a set-on there and let the thing settle down, and at the time of the pregnancy termination or completion of the pregnancy, that can be tackled. So this is a video here. Anterior horseshoe abscess in 6-month ANC patient. So it was fissure complicated into the perianal abscess. Anterior horseshoe abscess was aspirated, and then weak solution of the hydrogen peroxide is instilled, taking care that not to instill hydrogen peroxide very strong, because the wall of the cavity is vascular, and this vascular cavity, the generated hydrogen peroxide pressure can embolize that particular chemical into the systemic circulation. So where exactly to give the incision while draining this? It is very near the anal verge, so that the fistula which will be created in future will be very small. Normally, if this lady is pregnant, but otherwise we remove the set-on within 2 weeks to 3 weeks, so that the things settle down and the internal opening is curated. So we are saving the internal opening, this external sphincter, putting one set-on, that is the rubber. The simplest and very cheap material is the cuff of the glove, and that doesn't disintegrate, and if you give 4 and 5 knots, it will not come out on its own, and it will not be painful if the patient sits on it. So it is very soft. So curating is important, tackling the cryptoglandular tissue and putting a set-on. And since she was pregnant, this particular set-on was removed. You can see the dressing of the LSCS up there, and during that time that set-on was removed. So that was the end of the story then. So that was tackled. The literature says that there is 30% chance of recurrence of the perianal sepsis during pregnancy. So 30% is a huge number. So that is how that set-on is removed. So this is how we treat it. So this was again a case of huge infection, perianal infection, perianal abscess, and large volume abscess there. Horseshoe again, but this time posterior. Yeah. So again, drainage is the rule, and always posterior horseshoe abscess, the internal opening will be at the 6 o'clock. So that is the weakest point. So just put a draining set-on there, let everything cool down, all sepsis cool down, and then after 2 weeks and 3 weeks you can remove the set-on. So this is the rule that all perianal abscesses, unless proved otherwise, they are the start of the fistula. And we can tackle that. So the same story as the anterior fistula, we can put cut at the very close to the anal verge. We can go horizontally. Proper drainage is very important because this is a very large volume abscess. So proper drainage is very important. Otherwise there will be residual cavity. And mind you, don't try to break the loculi because the nerves are going there, and then the ceton is inserted there. So we will go for the next. The algorithm for use of ceton in anal sepsis is, the cutting ceton is now absolute. So we need not discuss this. The loose cetons, the material, there are different materials, we have discussed that, and where exactly we have to cut, how to operate, and what time we can remove that. In pregnancy only, it can be there for 3 months, 4 months, 5 months, otherwise we remove it in second or third week. Thank you very much. Now we will discuss the complicated anal fistulas. Already sir has given us a very good idea about the management. So the complex fistula, it is a multimodality treatment. Don't try to treat all fistulas on your own. We need a proper radiologist, we need a gastroenterologist, we need proctologist, and various modality of treatment we have to keep handy. So we will first define, Dada, ye chalu karo na. Hello. So how to define this complex fistula? The complex fistula are those with more than 30% of the sphincter involvement. All anterior fistulas in females, they are complex fistula. Those small, they are labeled as complex fistulas. Any recurrent fistula, they are complex fistulas. All associated with pre-existing fecal incontinence, that is important. You have to write down very well into your history that there is some fecal incontinence or either gas incontinence. All fistulas with inflammatory bowel disease, all fistulas associated with radiation, they are all complex fistulas. Examination, already sir has told you in detail. The office investigations, the preoperative imaging, the endoanal ultrasound and MRI, they are must to delineate the complete anatomy. But many a times you will be getting a Pandora's anorectal area because it can spring various surprises during that. So we will see the various videos about this particular treatment. So coming to the lift, we have seen one case, lift today. So lift is ligation of the intersphincteric tract. This is the fistula. So the material is going in this particular fashion. This is the external sphincter, this is the internal sphincter. So we are cutting in between the in the intersphincteric groove, so that we are disconnecting the cryptoglandular tissue to the rest of the fistula. That is simple lift. So this is one of the video, prototype video, what exactly this is called and how this is done. Incision in the Jackson's groove, and the tract is palpated and properly separated and ligated on either side so as to dissociate the cryptoglandular tissue from the rest of the fistula. So with what material it should be removed? Vicryl or PDS, it can be used, but PDS takes long time to absorb. So vicryl, uncoated vicryl can be best thing. So after tightly ligating it, remove the connection with the help of blade and properly secure the internal opening so that there will be no recurrence. This securing the internal opening is very important, and then close down this thing. The results are, as we have discussed, 61 to 94%, with very little morbidity, and healing time is around 4 to 8 weeks. There are various modification of lift. One of that has been shown that how the collagen can be used, the biological mesh interposition can be done, waft can be used, lasers can be used along with this. So distal ligation proximal laser DLPL, and excision of the lateral aspect of the tract, what we have done today. The fistula plug, but fistula plug is having very high recurrences. So what are the reasons of failure of the lift? Fistula tract is more than 3 centimeter, then chances of failure are there. Previous procedure to eradicate fistula, then obesity, surgeon's factor, the multiple internal opening, that becomes a contraindication for lift, multiple internal opening. Once each has been associated with the lift failure. So we will see this complex fistula. This particular patient had abscess drainage, right and left iliac fossa, and there was laparotomy. So we did ultrasound and there was a collection there, an abscess. So we inserted a needle there, aspirated. So we delineated that tract was going down toward the anal canal. So it was an abdomino-anal fistula. The needle showed frank pus, and then aspirated, guide wire was inserted. I will try to fast forward the thing. Yeah, the guide wire is inserted. On C-arm we can see where exactly the guide wire is going. So you need C-arm radiologist also along with that. Yeah. So after that a pigtail is inserted, dilators and pigtail. Then we see for the anal side where exactly that is opening. It is a rule that all abdominal fistula, all fistulas which are having abdominal connection, they will open at 6 o'clock, not at 12 o'clock. That is the rule. So a port is inserted into the cavity. We have dilated it enough to go the laparoscopic port inside, because we wanted to examine the cavity from inside. So all the pus, residual pus was sucked out. And then we see the anal connection. We instilled the dye, it was going towards the anal opening. Yes, was going toward the anal opening. But there was no ramification, there was no deviation of the fistula tract. So we instilled methylene blue and it came out through the anus. Now it was time to ablate the fistula, curate it, ablate it. So lift was done again so that the cryptoglandular tissue is disconnected. The same procedure again. So we will see the fistuloscopy. And as I have told you, the argon plasma, how useful it is. Very ragged material, infected material, lot of infected material. So that is to be tackled with the help of argon plasma. It is a very strong energy source, because this particular material is almost 3 to 4 millimeter thick. So the laser or monopolar cautery will not work here. There will be recurrence. So we have to burn completely, curate it, and this procedure is repeated 3 to 4 times so that the complete internal debris and the epithelium is tackled, so that it will collapse in few days. Usually this type of fistula, they take around 3 to 4 weeks to collapse. We keep on irrigating those wounds. So this is the second long fistula. Similarly, today we have did that. So guide wire is instilled, but this particular guide wire, if it is a V-shaped fistula, it will not come. So flexible tip metal probes, they are very useful. The endoscopy will show you that there were two openings, two internal openings, one here and one more there. As I have told you, it is always an inverted image which we get on the endoscopy. So lift is done, same incision. The internal and external sphincter, they are identified. This was going quite deep from the anal verge, from the skin. So proper retractors, these are the retractors which are very good retractors. They are used by the ENT people for pushing the tongue during tonsillectomy. So these are very strong, and even the suction can be attached so that, yeah, this is the metal, flexible metal tip used by gastroenterologists. It is very cheap, 100 rupees, guide wire. So that is dissociated and ligated there after removal of that steel guide wire. And then the complete tract is curated and again ablated by argon plasma. Usually these fistula, they heal by 4 to 6 weeks, but you have to keep them in your follow-up to prevent the recurrence. Don't guarantee any patient about the 100% result in anorectal. Yeah. That particular metal was a guide to palpate the fistula tract. Then curating. So a complex fistula is to be tackled by multiple ways, and the chances of recurrence are still there, but the recurrence will always be easier to treat if you don't create newer fistulas, newer internal opening. So then it is easier to treat the recurrence also. So again APC for the ablation of the tract. Now we will see a very long fistula. Examination under anesthesia is to be done. This particular patient was under Kshar Sutra treatment for more than 3 years, and there was no sign of healing, and lot of pus was coming. All underwears were staining. He has to change the diaper 1 or 2 times in a day. So this is the examination under anesthesia. So we are seeing the opening here. So that is the anal opening, and this is the fistula opening. Okay. So these are the fibers of the perianal muscles. So we wanted to go ahead to see the internal opening, but we couldn't find one. So these are the muscles which we can see. The transversus perineal muscles, they get contracted because of the fibrosis. Almost 3 years Kshar Sutra treatment was going on. So we did curating. First the fistuloscopy. Almost 18 inches of the fistuloscope went in. We used ultimately the ureteroscope to see the interior, but it was going very high. 18 inches is too long. Because of the size of the ureteroscope, the vision is not so good. And then we curated the tract. It was a very long fistula. So multiple curatings, and then APC. But it was going very high, so we decided to take the help of gastroenterologist to do a repeat scopy. We must have missed the internal opening. So the gastroenterologist did the scopy, and he could find there the internal opening way into the sigmoid colon. This was burned because of the argon plasma. So now the question was how to close that. 18 inches is too long, more than 36 or more than around 40 centimeters inside. So TAME will also not reach there. So only option was the endoscopy, endoscopic management. So we are entering into the fistula opening internally. The fecal matter was going in, and it was a big opening, so it was mandatory to close it down. Otherwise, there would have been a gross recurrence, and a recurrence at that level would have been very difficult. So we thought about what is to be used, so we used this endoscopic closure by padlock. So this particular pin is 360 degree with small sharp instruments, and it can be applied with the help of endoscope in such manner so that it can close down almost 2.5 centimeters of opening. So that is called as padlock. So this is how that is done endoscopically. Because this was done third or fourth day, so we again refreshed the internal opening. So this is the padlock clip. So it will suck the complete opening, and it will close by these 6 sharp objects there. So the complete opening is being sucked now, and the padlock is applied. And then we did, so that is the padlock clip applied. So this was how this complex thing was applied. This is the mechanism of action of this padlock clip, and it will suck and then it will be ligated. Thank you very much. Thank you. So treating complex fistula is a multimodality treatment. Never promise the patient and take the help of your colleagues. That's all. Thank you very much. Tomorrow the exam will start sharp here, so the questions will be here, and it will be around 50 questions. So the examination will be over in 30 minutes. Very simple. All those who are attentive today, they can attempt all the questions, and after that we will start taking the vivas also for the oral viva. So that is just you can tell about this thing.
Today's CME is over, but tomorrow is some of the topics are left, and that will be some perineal repair, then fissure in NO, medical management of fissure, bowel preparation, carcinoma rectum, TAMIS, and suspecting UC in PR bleed. So these papers must be with you. So the program is not over today. Tomorrow after examination, because we'll be there finishing our exam at 8:30. So 8:30 everything will be over, so that you can join again for the CME. Between the CME, these times we will be having your interviews, and after that there is some 2 or 3 cases are left. Tomorrow 2 cases will be operating. 2 cases would be there. So now there is a request for the audio visual person tomorrow. We shall be ready at 7 a.m. tomorrow. Here only. Same thing would be required. We both will be there, and those who are the examining tomorrow, they will be here. So with that, is there Dr. Prakash Gatore, sir, in the crowd? No. So what is going to be addressed? So all those who are to appear for the examination will be coming at 7 a.m. sharp tomorrow. Followed by this, we will be finishing up to 12 or 1. The program, full program will be over.
Newer methods to reduce the pain. That is, he is a plastic surgeon working in Solapur for last 10 years. So I request him to give the lecture in 15 minutes.
Good evening, everyone. Today, in this evening, I am going to talk on the anoplasty. What is anoplasty? Anoplasty is a repair or a reconstruction of the anus, and as you are aware of this, anus is a lower end of the large intestine. It's a short length of 3 to 4 centimeter, and it is surrounded by the muscles, internal and externals, which are parasympathetic and sympathetic in nerve stimulation. So basically, in which condition I am going to stress on the anal stenosis, how the anal stenosis will occur. It is the stenosis may be caused by intrinsic or extrinsic pathological process of the anal rectum. Anal stenosis may follow almost any condition that causes scarring of the anoderm. The causes of the anal stenosis include surgery of the anal canal, trauma, inflammatory bowel diseases, radiation therapy, venereal diseases, tuberculosis, and chronic laxative abuse. I am going to focus on the treatment of post-surgical anal stenosis. And 90% of the anal stenosis is caused by the overzealous hemorrhoidectomy, that is, removal of the large areas of the anoderm and hemorrhoidal rectal mucosa without sparing adequate mucocutaneous bridges leads to scarring and a progressive chronic stricture. Anal stenosis is a rare but serious complication of the anorectal surgery, most commonly seen after hemorrhoidectomy. How to diagnose the anal stenosis? Diagnosis of this condition is very easy. The patient usually reports difficult in and painful movements. It is a rectal bleeding or the narrow stools, and per rectal digital examination will help confirm the diagnosis. And the other one is the anorectal manometry, is an objective method for assessing anal musculature tone, rectal compliance, anorectal sensation, and verifying the integrity of the anorectal inhibitory reflex. Classification. The classification of the anal stenosis is a mild, moderate, and a severe. On the basis of the severity, that is mild, only the tight anal canal, the index finger can be, with the lubrication, can be negotiated, and the moderate rectal stenosis, forceful dilatation is required to insert either the index finger, and severe anal stenosis, even the little finger cannot be inserted. Depending on the severity of the anal stenosis, that is mild, moderate, and the severe stenosis, conservative and the surgical management includes. Mild and the moderate stenosis can be treated by conservative method, that is by the digital lubrications and digital dilatations and laxatives. High fiber diet can be given. So I am going to focus on the surgical management, that is, it includes lateral advancement, mucosal flap, VY advancement, diamond shaped flap, and the rotation flap. The conservative is the non-operative, that is the high fiber, stool softener, gradual natural dilatation, and anal dilatation is the uterus. If these all things fails, then we will consider the surgical management. First, the lateral mucosal advancement flap, that is the first diagram shows we are cutting the anal stricture and creating the raw area, and the raw area will be covered with the lateral mucosal advancement flap. We are giving an incision over the mucosa and pulling the mucosa from the anal mucosa and suturing it to the raw area which are created after the incision of the anal stenosis. Coming to YV advancement, that is the same principle is we are inserting, we are cutting the anal stenosis and creating a raw area, and raw area will be either in the anal, even on the more on the perianal side or in the anal mucosa. So whichever flap is convenient, that is it has to cover the whole of the anal mucosa from inside to outside and the stricture area. So VY advancement, first again the lithotomy position after aseptic conditions, painting, draping, we have to give a lithotomy position or a prone position we can do, and giving a cut over the stricture, creating a raw area, and again the coverage of the raw area with the VY or a YV, both advancement flap can be done from the perianal AGA. So we are giving a straight line, straight incision over the stricture, and the stricture same line we have to on the perianal side we have to give in a V shaped, and the same thing V, that is the skin, we have to advancement inside the stricture area, that is the raw area what we have created, and the tip of the advancement flap has to suture to the anal mucosa. So this is the diagram. On either side, depending on the severity of the anal stenosis, we can advance from the both the sides. This is the, and final stage will be here. So less commonly I use this one VY. More commonly this is the diamond shape flap. We in the practice I am commonly practicing with this one. So basically it is used in all the types of strictures, that is anal stenosis, either the moderate or the severe stenosis, depending on the stenosis, that is the distal per rectal examination, or the length of the stenosis, that is the anal canal length also, depending on that stricture, that is the 3 to 4 centimeter, half of the more than 50% of the anal canal is involved in the stenosis, then this flap is very with the good results we can, and reliable one we can do. So first again in a prone or a lithotomy position we can this one, in this position again stricture we have to cut the stricture, that the first diagram we are creating the cutting the stricture, creating the raw area with the same thing, the tip of the stricture, that is the raw area, from there we have to width we have to measure with the raw area, and the same width we have to take the diamond shape flap. On all the sides we have to cut the flap. As the diamond shape, it includes the vascularity, that is the perianal mucosal, so perianal plexus, subdermal plexus, it is the islanded one, and it is a very reliable, and we have to advance the diamond shape flap to the tip of the raw area in the anal stenosis, and the donor area can be closed primarily. The flap should be well mobilized to reduce the tension and to provide enough blood supply to preserve the underlying structure. So anyone, almost this is a very easy procedure. You are not dependent on the other. If you are having nearby any reconstruction surgeons are not available, you can this one. This is the diagram, that is the first diagram is showing the anal stricture, anal stenosis, and the diamond flap has been figured, and the next is the releasing of the anal stenosis and making all the cuts to the diamond shape flap, making it is islanded one, it is totally dependent on the underlying vasculature, and advancement of the diamond shape flap into the anal canal, how much is required, 2 to 3 centimeter it can go inside. It is also dependent, that is on either side we can take either the 3 and the 6 o'clock position we can take out. So simple to perform and reliable and more commonly performed. Last one is the rotational S flap. It is if it is the strictures are anal stenosis is very big, it is in the position that it is 12 o'clock and the 6 o'clock position, and after the putting the patient in a prone position, the scar tissue has been excised and full thickness S-shaped flap is made in the perianal skin with the size of the as great as its length, starting from the dentate line to approximately 8 to 10 cm. The flap then rotated and sutured to the normal mucosa. What are the post-operative cure? It is the simplest. Again, we have to give as usual high fiber diet, laxatives, mineral oil for a short time in the post-operative. Sitz bath, maintenance of the local hygiene, and flaps with multiple or extensive dissection should be require hospital admission. Otherwise, all the procedures are done under daycare basis. If the flaps are much bigger, then we have to give a nil by mouth for liquid diet or 3 to 5 days. What are the complications? That is all the flaps have the complex, that is the flap necrosis from the loss of vascular supply or due to infection or the local sepsis, suture dehiscence from the excessive suture line tension, and ischemic contracture of the edge of the flap which will suture to the normal mucosa of the anal canal. Thank you very much. Thank you, Gatole sir, for giving opportunity for presentation this. Thank you, sir.
Yeah, hello, hi.
Yes.
The first flap you described was a Martin's flap.
Yes, sir, Martin flap.
That flap basically can cause whitehead deformity.
Yes, sir.
And in the post-op there can be a lot of this thing, no? Discharge coming on
Discharge
for long period.
coming from this one thing.
Second is like you were talking about
Diamond shape flap, sir.
Diamond flap is sort of a advanced, it's a modified VY flap.
VY flap, sir.
But the thing is, if there is a more of scar tissue, would you like to do internal sphincterectomy also along with that?
Yes, sir. With or without, that is the this debate is there, with or without. But it is better to do with internal sphincterotomy and then go for a diamond shape flap.
Any exposure with the house flap anoplasty?
Yes, sir. But commonly it is one of the type of house flap or a U-shaped flap we can do. But the principle is the anal stenosis release and the surrounding skin has to be put in the raw area, and which is more dependent, that is reliable flap, that is with underlying vasculature. So we can cover these things, and the diamond shape which will enter the anal canal easily as it is islanded one. So the connections are less. Other things are U-shaped or a house flap or a VY or a YV advancement. These things will have attachment to the surrounding structures. So the tip necrosis are more common. The strictures results are variable as compared to the diamond shaped, sir.
And the last, what are the post-op advice to the patient? Because this is the area where you are making a flap that is going to be soiled with the stools every day.
Yes, sir.
So what is the advice you give to your patient?
Actually, sir, again, if the one is we have to maintain the local hygiene, and not all the procedures, not all the patients I will advise you should not kneel by mouth or but as much as possible avoid the things that is the liquid. I will put on liquid diet, and if the vascularity of the flap is good, then it will sustain the local
After how many days can patient sit?
It is I advise around 3 weeks, sir. 3 weeks the tissue will be stabilized and the suture will on the 8th day or the 10th day, and the 3 weeks he can sit, sir. Okay.
Sir,
thank you, sir.
Sir, just because we are doing this anoplasty. Anoplasty is that bringing the flap from the skin towards the mucosa.
Yes.
Can it sometimes, are there any of the indications that you can go for a muco advancement flap?
Yes, sir. First one I have told, that is the lateral mucosal advancement flap. Either we have to go from inside to out or outside to in. But the thing is the popping out mucus discharge will be there, and the anal control will be difficult, sir.
So viviplasty or the diamond flap?
Diamond flap is
very nice. The results are also very nice.
Yes, sir.
Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, Dr. Sharan Hiremat, for his excellent lecture. as in our day-to-day practice, we face such problem repeatedly. But if tight stenosis is there, the patient is very restless. He has operated many patients in his career, and his 80 to 90% success rate is there, and that is very prestigious from a plastic surgeon point of view. Our last lecture will be there at 8 o'clock. The dinner will be ready. Dr. Walke is going to talk on colonoscopy. So it's only 10 minutes talk, and after that we will go for the dinner on the 6th floor. Thank you.
So this lecture will be followed by dinner. So everybody has to wait.
He is a renowned gastroenterologist in Solapur, practicing for last 3 years only. But his results and the diagnosis is very helpful to the surgeons in many situations. Doctor.
Thank you very much, Gatroy sir, for such a beautiful opportunity. Today I am going to talk on colonoscopy tips and tricks. As we all know, colonoscopy is not that simple as we think about it. These two stalwarts, Dr. Wilhelm Wolff and Hiromi Shenya, invented colonoscopy in 1969. So there are few challenges. I think since last 5 years I am doing this colonoscopy. Since 6 years I am doing colonoscopy. These challenges I find during colonoscopy even nowadays. Difficult sigmoid anatomy, this magic of mesentery that causes loops during colonoscopy, difficult splenic fracture, hepatic fracture, different assist techniques to complete the colonoscopy. Nowadays, Olympus 170, 190 scopes has variable stiffness, and different size of colonoscopes can be used during to complete the colonoscopy. And most important thing is when to give up during colonoscopy. So first part, anticipate the altered sigmoid anatomy. So for rectosigmoid angle, as we all know, it is maybe very acute in elderly patients with stenosing diverticular disease or with malignancy. Those who have history of low abdominal or pelvic surgery, there may be adhesions that causes stricture or stenosis at that segment. And even particularly young women, we have to be very careful while negotiating the sigmoid. There is very high risk of perforation at that during loop reduction at the sigmoid in young women. So basic and most important rule for colonoscopy is never push against the fixed resistance. So force will not work in the endoscopy or during the colonoscopy. Force will land up in unnecessary excess degree of force will land up in perforation, particularly in cases of suspected infectious colitis or severe IBD or during the event of diverticulitis. So force should not be used as minimal force that can be used during colonoscopy is the best for the patient and the endoscopist. Maximize sensory feedback from the scope. Sensory, what would you mean by sensory feedback is the just force that we are applying. We should know how much force we are applying. Let's start with how we hold the scope. Scope handling is very important for the sensory feedback. That we hold soap with our fingers as a pencil, not as a tennis racket. So maximize sensory feedback from the tip of the scope, and the inform about the tension is by the fingers that we are using the colonoscope. Straight scope without any loop will remain floppy at the anus and will fall easily on bed. In contrast, when it is severely angulated or looped scope, it will very stiff and it is very difficult to move or to and fro movement, and it will stand alone and will not fall on the bed. That is a simple technique to assess the straight or looped scope. Most important part of colonoscopy is mastering the left side of the colon. We must spend almost 2/3 of total insertion time in the left colon. All loops should be reduced at sigmoid, at splenic, before you enter the transverse colon. That is the most important part of doing colonoscopy for the patient. So in short, I talk about the loops, different common we encounter loops during the colonoscopy. This is the alpha loop that is most common in the redundant sigmoid or loose mesentery. This is the reverse alpha loop, more commonly found in the older woman or multipara woman. N loop is again common in the those with redundant mesentery and very large, very elongated sigmoid. Gamma loop common in the transverse colon, and transverse loop, as we all know, it is just a long transverse colon that we encounter. I will talk to how to reduce all these loops. I will talk in the further talk. So this is just small video that we can, when we encounter N-type loop, there is the best part is to go about till the splenic flexure, then give a clockwise torsion, just reduce the scope. It will straighten the scope as easy as possible. It will definitely reduce the pain of the patient in this case. This is the alpha loop. In alpha loop is very painful for the patient and for endoscopies, because why we push the scope, there is no one-to-one movement during the colonoscopy, and it will again cause more and more loop. In this case, full clockwise reduction with 180-degree reduction is very easy to reduce the scope, but it is very painful for the patient. So changing position sometimes help while reducing the alpha loop. Same is the case for the anti-alpha loop. In that case, we have to reduce the scope in the anti-clockwise direction instead of clockwise direction. Is only after reduction of the scope patient we can have one-to-one movement during the colonoscopy. This is the in general idea. It cannot be applicable to the all patients, but what we usually think while during colonoscopy, our sigmoid colon should be at about 20 to 30 centimeter after scope reduction. Splenic flexure should be at 40 centimeter, and cecum ideally at 60 to 70 centimeter. It will help easy to negotiate IC valve, and it will be comfortable for the patient. So we encounter nowadays even most experienced people, those who have done thousands of colonoscopy, experience difficulty during the colonoscopy. What is important is to change the solutions quickly. Attempt each response once or twice. But what I mean by response is when we find that we are not moving forward, there is no one-to-one movement, this is very painful for the patient, then we have to change the position, we have to reduce the loop, or we have to come back to the rectum and again try by the abdominal compartment, abdominal pressure. So each response only once or twice. If solution does not work after 2 attempts, then it is unlikely to succeed by repeated attempts, and so there is no repetition of maneuver it will be helpful for the patient. It is just going to be painful for the patient. Changing instruments, yes, changing instruments help particularly in difficult sigmoid cases. We usually use gastroscope or pediatric colonoscope because of narrow size and flexibility of the scopes. And we talk about gamma loops in the hepatic at transverse colon, is buckling of scopes at splenic flexure and even at the sigmoid colon. It is very common during the passing the transverse colon. So reducing the scope by coming back to the splenic flexure is the best thing while doing the colonoscopy by the gamma loop, and shortening when proximal transfers by clockwise and clockwise torque is the same reduction maneuver will be helpful for the reducing the gamma loop in those cases. Most important is be willing to quit. As a general rule, cecum if has not been reached within 20 to 30 minutes, then I think we should stop and reattempt at other time. Or there is no progress to insertion or halt more than 10 minutes at the same point, then I think we should stop. And most important indication at that point is inadequate preparation. Inadequate preparation, we can't see anything, and even if any complication occurs, it will be more hazardous for the patient. So few real life scenarios we'll talk about. It's stenosis, stenotic or sharply angulated segment or fixed rectosigmoid, I already said. Right, definitely abdominal pressure, right, hypogastric pressure medially downward above the pubis will help. If still it don't work, change position supine or even in right lateral will help, or changing the scope as we already talked about will help to negotiate the fixed rectosigmoid. This commonly occurs in a young woman. Long resistance free left colon forming N loop, alpha loop or complex loop. At all these cases we have to identify the looping segment. That is the most important part. We can identify looping segment just by palpating the abdomen during colonoscopy. So reduce loop at each point at splenic flexure, at sigmoid, at splenic and in mid transverse is very important to achieve the cecal intubation in those cases. and even looping still patient scope is still looping and we cannot reduce at that time. Best point is to withdraw the scope to the rectum, then apply the abdominal pressures and then reattempt to negotiate the transverse colon to the cecum. When there is trouble passing the splenic fracture because of high or mobile splenic fracture, particularly in multipara women, there is also cause looping of sigmoid. In these cases also, abdominal pressure will definitely help, or coming back to the rectum and reducing in this sigmoid will help to negotiate the splenic fracture. Or apply even Olympus 190 or 170 scope have variable stiffener that we can use during the negotiating the splenic fracture at that time. Most and in these cases, particularly with long splenic fracture, supine pressure, supine position or right lateral definitely help to negotiate the scope further. In cases of non-progression or mid and proximal transverse colon, where invariably applying pressure in the upper abdomen below upwards will definitely help, or we can push scope to 7 to 8 centimeter when there is no pain, and while reaching the cecum we can reduce by suction or just pulling back. Changing position will definitely help. When reaching cecum is sometimes difficult in some cases, so particularly in cases of pulled up cecum, the scope in ascending colon, but cecum is looking at distance. This is a very frequent scenario in when scope is more looping in the transverse colon. At that time, gentle forward or backward movement will aspiration or just reducing the scope will definitely help to reach the cecum. Or just not only the changing the position, changing the posture also definitely help during the reaching the splenic fracture. Just simple tricks for the colonoscopy, just short of. Yes, thank you. Yes. IC wall negotiation, yes, IC wall is to by ASG guidelines, complete colonoscopy is to reach the cecum. Those cases there is a IC thickening or specific indications. There is very nice technique explained in the textbooks, is the bow and arrow technique. We have to identify the appendicular orifice, reach the appendicular orifice and just pull back with anti-clockwise torque and suctioning. Anti-clockwise torque, not wheels, torque we can pull back, will easily enter the terminalium. Yes. Yeah. Yes. Yes, sir. Reduce. Yes, sir. Yes, sir. Old scopes don't have any facility to identify the loop, but newer scopes, even AVS Xera 3, have system called scope guide. They have magnetic plates in the scope, and along the side the screen there is small screen that shows where is your scope and how it is mobilizing.
I am using Axion series.
Axion series don't have that facility. or you can use fluoroscope, C-arm. Yes. Thank you very much, sir.
Now the size of the scope has become very small. In addition to that, there is a radio opaque substance and the guidelines. Trauma rarely occurs, but it is a skillful job, and these specialist people will give the very good guidance. One take home message is that when you are doing per rectal examination for the piles, if you see the brown color or black color blood, one should undergo for the minimum sigmoidoscopy or colonoscopy, then only we have to go for surgery, especially above the 40-50 years of the age and long standing cases. Thank you very much, Dr. Walke, for giving the excellent lecture. Today's it is our last lecture. Some announcements are there. Those who have applied for the fellowship course and examination, tomorrow the fellowship examination will start at 7:30. 7 o'clock, and after that breakfast and once the breakfast is over, few lectures and 1 or 2 operations. This is a very, I am very thankful to the number of the delegates who have attended. I think all course we have tried our level best to do the best. If any deficiency, pardon us for that. And tomorrow we will finish the program up to 12:30 or 2 o'clock. 1 or 2 operations are to be posted in between, but according to the availability of the case. Thank you very much. Join for the dinner on the 6th floor. It is ready. Don't go anyone out of this campus. Take the food and have a rest in the night. And tomorrow morning, fellowship students are expected to come at 7 o'clock in this hall only, as Ladukar has advised. Sir, anything you want to tell? Thank you very much. Today's program is we have completed. And any suggestions if you want to give in writing.
Actually, our examiner, tomorrow's examiner is very strict. He never allows to sleep us also before 7. He will be asking me to come at 7 a.m. sharp. We have conducted this examination at Agra where 400 candidates were there. This was a massive practice we have done. So tomorrow that much of strength is not there, but still Dr. Rahat is there. But wonderfully I will ask you to attend in a fixed time, because those questions are not only for the examination but for learning purpose also. These are the very good questions he has taken up from his practice only. All those are the practical questions, not theoretical much. So do attend early, come at about 7. We'll start at 7:05. And after that the questions are focused. Then later on the questions are discussed, answers are also discussed. So this will be in addition to this CME, that will be a part of knowledge also as far as coloproctology is concerned. Thank you.